Okay, ma'am. Ma'am, we will start, ma'am.
Yes.
Saiti. Sambat, ma'am, please start, ma'am.
Yes. Good morning to all. I welcome you all for this South All State Federation. A hearty and a warm welcome to each and everyone who had gathered here upon our invitation and on their own interest. Sollu Priya. Hello, Priya, Kadla Vrida.
Yeah, you
Yes,
are
ma'am.
audible,
Please, ma'am.
Yeah.
Yeah, audible, ma'am. Please continue.
A hearty and dear friends, a hearty and warm welcome to each and everyone who have gathered here upon our invitation and on their own interest of bettering their acumen and also to share the expertise with the budding gynacs. It is a red letter day for us, TNFOG. Apart Fox's regional conferences, it is the first time all the 5 southern federations have come together to conduct a webinar. It is also a golden event in the sense that about 79 societies have congregated here through digitally on this day, but the day is not far off for a physical meeting. I thank the president and secretaries of all the 79 societies and the presidents and secretaries of 5 state federations for taking the effort to be here in our midst. The tech explosion today have also brought an advantage. We could now sit in the comforts of our house and can still interact with one another digitally without having to bother about traveling distances. When I first started my attempts in stitching up 18 plus odd societies for a federation, it seemed like an impossible task. But with each day and with great people like Dr. Anjalakshi, Dr. Palaniappan leading their shoulders, the thought came to fruition and is now celebrating the first regional conference. Of course, it goes without saying that if not for the helping hands of many seniors and helping hands of the farmer like Shield, Torrent and Sun, the task could have become not only onerous but also insurmountable. My special thanks to them. I request them to herein, dear former friends, continuous support in incoming years to scale many more peaks. Similarly, Dr. Ganga and Dr. Uma Shankar from Andra Pradesh, Dr. Narasimha Reddy, Dr. Shanta Kumari and Dr. Jamuna Devi from Telangana, Dr. Kasturi and Dr. Venugopal, Dr. Bharti Rajshekar from Karnataka and Dr. Sarina and Dr. Venugopal from Kerala and all 79 societies, president and secretaries. Thanks for making it a reality. A request to my fellow sister state federation president and secretaries. Please continue this momentum and have such regional conferences every year in all your states. I should say thank Dr. Shanta Kumari, Foxy President and Telangana State Federation President, and Dr. H.D. Pai, incoming Foxy President, and my own TNFOG President, Dr. Anjalakshi, for the help and support in the conduct of this first regional conference. Sir Dr. Arul Kumaran and Dr. J. Ravichandran from Malaysia. Dear sirs, I thank you from the bottom of my heart for joining us today in this great event. It is really heartening to have Dr. Jaydeep Tang, Dr. Kurian, and Dr. Madhuri, Dr. Hema, Dr. Meg, Dr. Sheila Mane, Dr. Sunita Tendulkar, Dr. Girija, Dr. Fesi Louis, Dr. Sanjay Gupte have all found time to be part of this event. Sincere thanks to them. And my pillars of strength, Dr. Anjalakshi, Dr. Vijayalakshmi Jnanashekaran, Dr. Kalpana, Dr. Hepsiba, and all Dr. Ramani Devi. Only a few of names I could mention, but there are many more whose names I have not told for the want of time. Mrs. Sri Priya, the event organizer, have been of great help in the successful conduct of the conference. We are now TNFOG, 1 year old, and our very own TNFOG annual conference will be in the month of November 11th, 12th, and 13th at Hotel Savera in Chennai. We seek your wishes and kind patronage for the same. Thank you all once again. Just sit back and enjoy the scientific feast. You will also relish it and carry home memorable moments. Now we will go with the inauguration. I will call Dr. Priya Kannappan. So I hand over the mic to Dr. Priya Kannappan. Dr. Priya?
Yes, ma'am. Thank you. A very good morning to all the attendees in the conference, all the dignitaries and the delegates. It is very happy for us to, invite you to this special event. It's the first of its kind to involve active participation from all the 5 states of the South India. We cordially invite all the delegates and the dignitaries for the inauguration of this A to Z of Obstetrics and Gynaecology. Morning is a God's way to say one more time, go, live your life, make a difference, touch one's heart, encourage one's mind, and inquire one's soul. We begin the program orderly. Let us invoke the presence of the Almighty Lord Ganesha.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you. And I would like to request all of you to raise for the Tamil Thai Valtu, the invocation of the Tamil, our mother Tamil. As a symbolic representation of dispelling the darkness of ignorance, let us have the lighting of the Kutuvilakku to, to encourage the knowledge and to make it spread. Can we have the lighting of the Kutuvilakku? So it's online. I invite all the dignitaries to please participate in the lighting. Thank you. So it is indeed a great honor to invite Dr. Anjalakshi Madam for the welcome address. So can I have Madam speak, please? Madam is a founder, president, TNF OG. She's a past president of OXY, and she has been done various methodology and research medicines in GDM. So whenever anybody thinks of GDM, it is only Dr. Anjalakshi. So over to you, Madam, for the welcome address.
Thank you, Dr. Priya. Good morning to all. Respected chief guest, the Galaxy of South Indian Societies and Tamil Nadu Federation of Obstetrics and Gynecologists, it is my immense pleasure to give the welcome address. I welcome the chief guest, Dr. Shantakumari, and the guest of honor, Dr. Madini, Dr. Sindhya, and the special guest and TCOG Secretary, Dr. Jamna Devi, Dr. Fessy Lewis, Foxy Vice President, South Zone, and Dr. Ganga Susmitra, President of APOGS, and Dr. Uma Shankar, Secretary of that society, Dr. Kasturi, the President, and Dr. Bharati, Secretary of KSOGA, Dr. Sarina Gilvas, President, and Dr. Venugopal, Secretary of KFOG and TNFOG, and our international faculty, Professor Dr. Arul Kumaran UK, who always feels that he is more an Indian, and Dr. Ravi Chandran from Malaysia, and our own vibrant national faculties, Dr. Alpesh Gandhi, Dr. Hema Divakar, Dr. Rishikesh Pai, Dr. Jaydeep Tang, our loving brother, Dr. Kurian Joseph, Dr. Madhuri Patel, the Secretary General Foxy, Madhini Madam, who is Mandakini Madam, who is close to our heart, and Dr. Narasimha Reddy, and Prasanna Kumari, Dr. Sanjay Gupta, and my dear Dr. Sunita, and our dear delegates. I welcome all of you with cheers and my warm greetings, and to every one of you. I am so happy that the federations, that is 79 societies, such a huge number, joined together to give this academic feast. I also welcome the coordinators of this 2 days program and chairpersons and eminent speakers. And it will be a big list if I have to mention the names, so just forgive me. And this conference, our colleagues from all southern states, coordinators, and the cheerful, when I saw the cheerful messages in the WhatsApp, the amount of coordination and the expectation and the cheerfulness of our people, how they wanted to join together and to conduct this program, it was overwhelming. I have seen together we can do wonders. We can from each other, learn from each other, and do better service to our mothers. And this conference is going to have the galaxy of speakers, efficient chairpersons, keynote address, debates, and covering almost all the topics of obstetrics, starting from COVID. And also from the gynec aspect, the important subjects like PCOS in adolescents, infertility, endometriosis, and fertility preservation and whatnot. All the subjects will be covered in this 2 days conference. I request all the delegates to enjoy this program and know the current developments, and also know the law of the land and get benefited. I welcome every one of you with my bottom of the heart once again, and I wish this conference a great success. And I will be failing if I don't congratulate and thank my secretary, Dr. Sambat Kumari, who is the pillar, who is actually the all the 4 pillars for this 79 societies to conduct this, to organize this, the mega event of 2 days webinar. I thank her once again. I thank all of you for this opportunity that is given, and thank you. Jai Hind.
Thank you, ma'am. Madam, invite. Anjalakshmi madam.
Yes, ma'am.
Introduce our guest of honor, Cynthia madam and ma'am.
Okay. Now I welcome our guest of honor, Dr. Cynthia Alexander, who is a great friend of me, a well-wisher of me, a mentor for me. Okay. And to introduce her, she is a former director of Institute of Obstetrics and Gynaecology, Chennai, and Superintendent Government Hospital for Women and Children, Egmore, former HOD and professor of ObGyn, Madras Medical College. She has joined Tamil Nadu Medical Service in 1972 and retired after the good 35.5 years of her service to the public. She served in Kilpauk Medical College, and also as superintendent of the government RSRM hospital. So she has worked in all the 3 primary government institutions and the hospital, HOD and professor of ObGyn Stanley Medical College. She has been awarded A.L. Mudaliar Traveling Fellowship, was awarded the Lifetime Achievement Award by the MGR University. She is a pro-life activist and member of CASA. By this program, she has gone into the heart of many adolescents, and she is a resource person for family life education. And so with all these credits, I invite Dr. Cynthia Alexander, the guest of honor, to bless this conference and also address to the delegates. So Dr. Cynthia, please.
Thank you, Anjalakshi. Good morning and lovely Saturday wishes to all. I feel greatly honored to be invited as the guest of honor, and I feel doubly privileged to share the name with my dear friend and colleague, Dr. Madini. We both joined MBBS in 1965, so all of you must be calculating. A long and fruitful friendship. I thank Dr. Anjalakshi, Dr. Sampath Kumari, and Dr. Vijay for the invite. I am touched by this gesture of theirs to honor us. We have been colleagues working in many teaching institutions, and personally, I am grateful to Anjalakshi for being my great support in DIPSI. The invitation is remarkable. Nobody is left out. All our dear friends are in the list, and it's lovely to see all of them on screen. As we just celebrated 75 years of independence, true to our nation's call, the conference has gone beyond boundaries and borders. The districts of Tamil Nadu is included, the southern states of India has been included, and across the Vindhyas, and it has gone international also. Great job done by the organizers. They have shown unity in diversity. And to quote Sir Rabindranath Tagore, they have gone beyond narrow domestic walls. So it's a lovely start for the TNFOG. And to quote Tagore again, where the mind is without fear and the head is held high, into that haven of freedom, let my country awake. I wish all the best for the conference and remarkable work by the organizers, and Jai Hind. Thank you.
Thank you, Dr. Cynthia, for these lovely words. Now, I invite Dr. Madini, another person who has put in about 50 years of government service after her qualification. She is a retired professor in HOD Department of ObGyn and Chennai, and former director of Institute of Obstetrics and Gynaecology. She is an undergraduate and postgraduate teacher for more than 45 years, contributed chapters in the OG books, examiner in various universities, has been an advisor for UPSC, given orations, and had been a chairperson, speaker in conferences, and a chief guest and guest of honor in many of our conferences, and presented papers in various national and international levels. Madam is well known for the discipline and the what to say. Okay, she is well known for the discipline. I invite now Dr. Madini to give her advice and the blessings to the conference. Dr. Madini, please.
Good morning. Thank you, Dr. Anjalakshi, for the good words. And good morning to ever-smiling Dr. Shanta Kumari, the president of FOXY, Dr. Fessy Lewis, the vice president, FOXY, the efficient and energetic Dr. Sampath Kumari, the vice president-elect, Dr. Angela Shi, the able president of TNFOG, Dr. Sarina Galwas, the president of Kerala Federation of Obstetricians and Gynecologists, Dr. Ganga Sushmita, the president of AP Obstetric and Gynec Society, Dr. Kasturi Dominath, the professor of Karnataka State Obstetric Gynaecology Association, my dear friend, Dr. Cynthia Alexander, Dr. Vijayalakshmi Gnanasekaran, international, national faculty members, organizers, and the august audience of fellow obstetricians and gynecologists. It is indeed a great honor to be the guest of honor for this academic feast, this inaugural integrated venture of the 5 southern states. That is A to Z in obstetrics and gynecology. I thank Dr. Angela Shi, Dr. Sampath Kumari, and their organizing team for giving me this opportunity. It is a great effort and achievement, and I congratulate Dr. Angela Lakshmi, Dr. Sampath Kumari, and all the society members of the southern states. Thanks to technology, we are able to enjoy the feast from wherever we are. Sippumori Padinetudayal in Sindane Undudayal. This is by the great poet Subramanya Bharatiya in the early part of 20th century. That is, even though we speak different languages, the thought process is the same. So even though we belong to different states of India, our aim is to disseminate knowledge so that the women of this country will benefit and hence their families too. Pandit Nehru said, when a woman moves forward, the family moves, the village moves, and the nation moves. The variety of delicious feasts is awaiting us as we have different topics, including prevention, nutrition, infection, immunization, diagnosis and management of obstetric and gynec disorders, debate, preservation of fertility.
Madhuri madam, Dr.
Yes.
Santa Kumari has joined.
Yeah,
Ah.
yeah, I first told only they ever smiling Shanta Kumari. Preservation of fertility and uterus, PASCO, MPP Act, and so on. I wish the webinar to be a fruitful one and hope this collective initiative will continue in the coming years to help us to learn, unlearn, relearn, so that we can do the best to our society. Thank you all. Jai Hind.
Thank you, Madhuri madam. Thank you. Since our chief guest, Dr. Shanta Kumari, has joined now, I invite her for this academic feast given by this Galaxy of South Indian Societies and Tamil Nadu Federation of Obstetrics and Gynaecology. And Dr. Shanta Kumari is the president of FOXY 2021 to 22, FIGO treasurer 21 to 23, senior consultant OBG, laparoscopic surgeon, Hyderabad, chair of the FIGO Publication Management Board, director of FIGO Trading, and chairperson ICOG, secretary ICOG, national corresponding editor for JOGI. And she has
Thank you, madam.
to her. And
Madam, thank you.
I welcome Dr. Shanta Kumari to this conference and bless our conference.
Good morning, everyone. It's indeed a pleasure to be seeing you all on Zoom. I'm so sorry. I'm actually just entering the airport, Delhi airport. And Sampath Kumari, congratulations for bringing together all the southern states together. As President Foxy or FIGO Treasurer and the President of the Telangana Society. And we are AP and Telangana very, very close to each other. I'm very happy that we are doing a lot of good academic activities. And this webinar, though on a Saturday morning, I see you got a lot of participants. That shows how very important academic activities are, and especially when the southern countries are, southern part of the country is together. So I wish you and all of us all the best. Great job. And everyone is really looking forward to have more presence of southern people in the mainstream of Foxy. So I wish more of our people come forward and work actively in Foxy so that we have more Foxy presence from the southern part of India. So all the best to everyone, and it's really a pleasure to be with Vistara Valaidari. Okay. So thank you very much.
Madam. Thank you very much.
Thank you, Dr. Shantakumari. You are the
Thank you.
leader and people will follow you.
Thank you. I'm
Thank
so
you.
happy, Dr. Angela. Madam, I can see Dr. Cynthia. I'm sorry on the phone. I was very worried I won't catch the flight.
No. Okay.
Good morning,
okay.
Shantakumari.
Good morning.
Bye.
Good morning.
You will
Bye,
catch
bye.
the flight. No?
Safe
Good
journey,
morning.
madam.
So like rainwater bringing life and prosperity to the land. Your words help with enthusiasm and strength for our hearts, madam. Thank you, Anjalakshi madam, Madhuri madam, Sindhya madam, and Shantakumari madam. Your words have been given more lot of motivation for us to go ahead with the conference. So now I would take a great pleasure in inviting our special guest of honor for today. So can we have our series? A special guest, Dr.
Priya, 1
Fessy
minute.
Lewis.
Can we invite Dr. Serena, madam? She is in the airport first. Then Dr.
Yes.
Fessy,
Yes,
if you
madam.
don't mind,
No problem.
you invite
Madam is
Dr.
about to
Serena.
board a flight.
Dr. Serena, madam.
Doctor, can we have the CVs, please? Dr. Serena Gulraj, madam is the head of the department, Jubilee Mission Hospital and College. And madam has done a lot of achievements. Madam has been written more of scientific papers. She has written textbooks for undergraduate and postgraduate. And madam has received A.L. Mudaliar Award and many awards to her honor. Over to you, madam. We are privileged to invite you for our conference.
Thank you. Let me start off by wishing all the presidents of our co-federation, Dr. Shantakumari, Dr. Angela, Dr. Ganga, Dr. Kasturi, Dr. Fessy, our vice president. I would say this is a very novel idea, a very good initiative by the Tamil Nadu Federation under Dr. Angela and Dr. Sampath Kumari. I would say it's a great way to bond, interesting caption A to Z, lovely topics, faculty. I'm hoping that more of such sessions would be held. I conclude wishing this Congress all success.
Thank you, Serena, madam.
Thank
Wishes
you.
from the flight. Thank you so much.
Yes.
Hi, Dr.
We feel
Serena.
as if we are also flying.
see
Thank
you.
you, madam.
Shanta, madam,
I
thank
think
you.
they have asked to switch off the phone. I think madam has switched it off. So can I have the CVs of Fessy Lewis, sir, please?
Shanta Kumari, madam is traveling by road from Agra to Delhi, I think. In the meantime, I told her.
Madam, airport
Yes, like that. So I told definitely you should be there at least for 5 minutes.
Yeah,
Anyway,
yeah.
Thank you so much, madam.
Okay, bye-bye. Hi, Dr. Serena. Also, I saw Dr. Revati and everyone.
Ma'am, good
Hi,
morning,
ma'am.
ma'am.
Happy journey, madam.
Namaskar, madam.
For the CME.
Good morning,
Bye,
ma'am.
both
morning.
Dr.
Namaskara, Kasturi madam.
Shantakumari and
Namaskar,
Serena.
madam. See you at Hubli.
Chanagidra?
Chennagide, madam. Waiting for you
Ma'am,
at
can
Hubli.
I do
Yes.
some screen sharing and try, ma'am?
Yeah. Hi,
Namaskar,
Palani.
ma'am. Hi, ma'am. How are you, ma'am?
Good morning.
I am fine.
Good morning, ma'am. So
I'm
nice
very
to see
happy
you.
I reached the airport in time.
So nice to see you,
Happy
ma'am.
journey, madam. Happy journey.
Yeah.
Thank you.
Thank you. Bye-bye.
Thank
Good
you.
morning.
Dr. Fessy.
Yes. Okay. Hello.
Yes, Fessy,
Yeah,
we
we
can
can
hear
hear.
you.
Okay. Is good morning to all of you. I think this is as all of us are here for this wonderful initiative. In fact, when Sampath Kumari madam, after starting TNFOG, when we had a discussion, how to bring about all the South Indian societies together, just like we had about 10 years back, we had Dakshin, like that, how to bring about all this idea all came. And I think more than just idea, to materialize is a very, very, very novel thing and very difficult thing. And that as an initiative, we started, I think, Sampath Kumari madam, along with all the 5 federations, that is Andra, Karnataka, Telangana, Kerala, and Tamil Nadu. We are starting this wonderful initiative of 79 societies. And I think it's still growing because smaller towns, when more gynecologists are getting installed into the societies, Foxy, new societies are being formed. But the importance is that because when the All India conference occurs, that occurs in one part of the country and all are not able to go there. So not only to get the socializing with our fellow gynecologists, but academical dissemination also, academically attending workshops, everything is getting difficult. That's why this wonderful initiative, when we have enough number of people is there, we must be united and show our strength and come in the Foxy in a big way. That's how this wonderful initiative of South Zone Federation is started. I think today we'll be for 2 days, we'll be covering A to Z in obstetrics and gynecology. And being Vice President of ObGyn, I am really honored to be part of here. I hope the next Vice President, I think Sampath Kumari Madam is there, and then Charmla is there, and coming generation people will be motivated to.
Madam, I was
into the
a guest of
mainstream.
honor at that South Zone conference.
Yes.
I'm just talking. I'll talk to you after 15-20 minutes.
Kasturi ma'am, please.
Yes, yes.
And all will be motivated to come into the more and more into the committee activities also. Now we know a lot of people are very active, just like Kalpana is very active in the infertility committee. Like that, lot of people are becoming nationally very active. So that is very important to be academically and socially very important in the national forum. So this will be a stepping stone to all the people who are coming to the national front. So we wishing all the best for all the societies and all the South Indian members in the future also. Wishing all the best today's endeavor. Thank you for inviting me.
Thank you, sir. Thank you, Dr. Fasiza. Your words mean a lot to us, and it helps us to carry on a lot of wisdom and vision for our future. So thank you. Can I invite our next guest, please? Can we have the CVs? Dr. Ganga Madam. Yes. Madam is from Andra. Madam is a well-renowned gynecologist there. Madam is the president of the Andra Society. So Madam is a gold medalist, and Madam is also a practitioner of heartful meditation. Over to you, Madam. Ganga Madam.
Yes, Ganga Madam, unmute pannu.
Madam, you're muted.
No, she has to unmute it. Rahita.
Ganga Madam, you
Yes,
have to
ma'am.
unmute
I
yourself,
have
Madam.
unmuted.
Priya.
Madam.
அவங்களுக்கு unmute பண்ணணும்ப்பா. அவங்களால பண்ண முடியலன்னு நினைக்கிறேன்.
Yes, ma'am, I'm helping.
Click பண்ண மாதிரி இருந்தது, but பண்ற மாதிரி.
Yes.
Now, yes.
Ganga ma'am.
Thank you very much for your invitation. On behalf of Andhra Pradesh Federation of Obstetrics and Gynaecology, I extend my greetings and best wishes to the webinar, which has been aptly named A to Z in Obstetrics and Gynaecology. And I admire and congratulate Dr. Sampath Kumari and her team for organizing such a huge webinar, pushing and pulling all the 79 societies with her elegance and etiquette. I admire them. And of course, it is a unique occasion, and it's up to the PGs to make the most of it. We as obstetricians and practitioners, though we are quite aware of what's happening, it's for the postgraduates to participate and gain from their own, gain the knowledge from their own hospitals without taking a leave. So it all shows our interest in getting together. And thanks to COVID, we are all used to these webinars. Otherwise, it was always a live event. And I think we also should learn to survive in the utmost jeopardy. Thank you, and wishing you all the best, Dr. Sampath Kumari and her team. Thank you very much.
Thank you, Madam. Still now we have 1,600 registration participants.
Thank you for your warm words, Madam. Can I invite Dr. Kasturi, Madam? Can we have the CV, please? Madam is the president of Karnataka ObGyn Society. Madam has held many posts in the Karnataka ObGyn Society, and she has also been a president of Hubli Society as well. Madam has been contributed many books. She has conducted many workshops, CMEs, and conferences. Over to you, Madam. Kasturi, Madam.
Yeah. Namaste to one and all. A pleasant morning to all. And I'm really a moment of honor and pride to join this mega event, done by all the 5 societies of South India, Karnataka, Kerala, Andhra Pradesh, Tamil Nadu, and Telangana. It is really a very great initiative. My hearty congratulations and best wishes to Dr. Sampath Kumari, Dr. Anjalakshi, and Dr. Vijayalakshmi for conducting such a mega event. People are able to sit at their home comfortably and listen to this academic extravaganza. And my special namaste to the Foxy President, Dr. Shanta Kumari Madam, guest of honor, Dr. Cynthia, Dr. Madini, Fesiluis, Sarina, Ganga, and all the organizers and all the president and secretaries of all the 5 societies of Southern India. And it is really a great initiative and a grand academic extravaganza, I call it. And I request all the members of all these 73 societies to take the this thing from this conference, from this webinar at the comfort of their home. And really it has covered all the A to Z. The real name is also very nice. A to Z, you have covered all the topics, and you invited such a eminent faculty from international and national, from all states. It's going to be a real great event. And my best wishes to all of you and for all of us. Thank you, Anand, and looking for many more such events. Thank you.
Priya, 1 minute. Shanta Kumari Madam is still there. As a Telangana president, I think she can give few more words. Shanta Kumari Madam.
I'm entering. I'm so happy now. I reached the airport in time, Sampath.
Yes, same way. Okay, Madam. Thank
I
you.
think we have to mention that our President Shanta Kumari doctor has received a UN Special Appreciation Award.
Yes, she was in Geneva.
That we are all proud of you, and we must congratulate you.
Congratulations, madam.
Congratulations.
Congratulations, ma'am.
Thank you.
Very
How
proud
to
moment.
going to UN. It's a very great.
I was representing FIGO and for women's health against and discrimination against health, and also we are doing big time work in the WHO, UN and all. So
Yes, madam.
for women's health, I think, and being FIGO and Foxy, I think it's really a wonderful opportunity that I'm able to represent the whole country and the whole global community of women at the UN. So
Good.
I think Foxy gives us a lot of I think strength, and of being in FIGO, it's been very this thing. No words actually, and thank you all for being with me. Looking forward to have all of you work more for women's health. Thank you.
Tamil
You're all committed. Because when you look at maternal health, maternal morbidity, mortality, our Indian community has done a lot, and we have been able to reduce the maternal mortality, and that's a big achievement. FIGO also acknowledges the Foxy's presence and everything, Thank you all for everything.
Thank
Now
you,
I'll
Madam
have
Kumari.
Yes, madam. We know you are the pride of Foxy Awards. It is a very well-deserved pride of Foxy, madam. Thank you.
Thank you.
Thank you.
Thank you. In our program, our CM, Mr. Stalin, has also joined through Geeta Lakshmi.
Okay, very nice.
That is that KGH photo. Yes, madam. Thank you, madam. Yes, we will go.
So
with scientific
I would
section.
like to thank all our guests for their enthusiasm, their dedication, and on their insight.
Priya,
And we-
1 minute. Priya, 1 minute. As TNFOG President, Dr. Anjalakshi, 2 words.
Yes. Madam Anjalakshi, madam, can you just address the gathering
2 words.
as a TNFOG president, madam?
Okay, that's what, it is a very great pleasure for me, when I saw this A to Z being arranged, and the Sampath was taking so much of effort in contacting people, and I was going through the WhatsApp messages, and people were so enthusiastic to participate in that, in this program. So I think by combining all these societies, joining this region, the southern region of India, to conduct this academic feast, it is a great thing, and it will be a good learning for all people from all the southern states. Okay, and we wish similar programs are happening in the future. I wish this conference a great success and everyone get benefited. Thank you.
Thank you, madam. Thank you for your words of wisdom. So to give a perfect end to this inaugural event, so I would request, can we have a slide, Dr. Vijayalakshmi Nyanashekaran, Madam, to deliver the words of gratitude. Madam is an associate professor of the ACS Medical College Hospital, and she has formerly worked in Karnataka Vinayaka. She's an executive committee member at present. Madam has been secretary of OPSI as well. Madam is a honorary treasurer at TNF OG, and her fields of interest is high-risk obstetric, adolescent, gynec, and infertility. Over to you, Madam. Madam Vijayalakshmi Nyanashekaran, Madam.
Priya, am I audible? Both Priyas?
Yes, Madam. Yes, yes. Now we are audible.
Priyas, am I audible?
Now we are audible, Madam.
Thank you, thank you. With folded hands, I deem it as a great honor and privilege to propose the vote of thanks for a first of its kind conference and program, a very memorable occasion for all of us, bringing together 5 federations and 79 societies. Quoting John F. Kennedy, we must find time to stop and thank the people who make a difference in our lives. So here I am to say, Nandri Marapandrandu. So I am to say thanks to all those who have made this program a really very special one. Dear Lord Almighty, thank you for your blessings that you have always showered upon us, and especially for these special days. Thank you so much for making this conference a grand success, and prayers to you, making it today's and tomorrow's specific session. Be with us today and guide us, dear Lord. Heartfelt thanks to the very sincere and hardworking lady who have really risen to such a great height. Our Tamil Nadu's Marumagal, I always address her as like that. Our dear president, she calls herself as Tamil Nadu Marumagal. Our president of ObGyn, president and president of Telangana Society, Dr. Shantakumari Madam, for your gracious presence as the chief guest of today's program. In spite of your busy schedule, Madam, you could find time with us to share a few moments on this special occasion, both at the capacity of the President ObGyn and the capacity of President of Telangana. And as per your wishes, Madam, we have to take it upon ourselves, and we will do it. More people representation from the south to ObGyn, we definitely take it up. My sincere thanks to all the special guests of today's program. Our most unassuming and achieving man, Dr. Fessy Lewis, Vice President of ObGyn. A very great academician, Dr. Sarina Gilvas, who's President of the Kerala Federation. Our dear Dr. Ganga Sushmita, President of Andra Society. Dear Dr. Kasturi V, President of Karnataka Society. Our dear Dr. Anjalakshi Chandrasekhar, President of the Tamil Nadu Federation. And for all of you for adorning today as special guests of today, the presidents of all the federations who have been special guests and sparing time, thank you all so much. My special thanks to our veteran senior obstetricians and great academicians, our own Dr. Cynthia Alexander and Dr. Madhini Madam, for your blessings which you have showered on us always, and especially for being today's guests of honors. Thank you both so much, Madam. My very special thanks to the pillar, our enthusiastic, hardworking, extremely good planner, our secretary of the TNFOG, Dr. Sampath Kumari Madam. You have thoughtfully planned this mega event, which is one of your dream projects. Thanks a lot for it. Best wishes for many more of your dreams to come through as the Vice President of ObGyn elected, and always appreciating, unassuming, enthusiastic president of our TNFOG, Dr. Anjalakshi Chandrasekhar Madam. You always give us a free hand to plan and conduct all the activities. Thank you for always being there with us, Madam. My sincere thanks to the all the faculties, international faculty, Professor Dr. S. Arul Kumaran from UK, Dr. Ravichandran from Malaysia, our national faculties, the GEM obstetricians, Dr. Alpesh Gandhi, Dr. Hema Dibakar, Dr. Rishikesh, Dr. Dilip Tan, Dr. Kurian Joseph, Dr. Mari Patel, Dr. Mandagini Mik, Dr. Narasimha Reddy, Dr. Prasanna Kumari, Dr. Sanjay Gupta, Dr. Sunit Tandulwakar. Thank you all so much who are going to be. All of you are going to be with us in the next week. Faculties who are going to be in today's as well as in tomorrow's programs, for being with us and sharing time and knowledge in this scientific program. Immense thanks to all the presidents, secretaries, and members of all the 79 southern societies, the presidents and secretaries of the 5 federations who've been with us in organizing this program. Thank you all so much. No conference is successful without you delegates, 1,600 and odd delegates so far. Without you delegates, no conference is successful. Thank you for being part of this wonderful conference, the first of its kind. Please join, update your knowledge and also relax. Special thanks to Shri Priya for all the coordination. Priya, it's really beyond words. Thank you. Thank you so much for all the efforts that you have put in. Shield has been a great support for all our academic activities. Thank you, Shield, immensely for planning and supporting and sponsoring this mega event. Thanks to all the presidents behind the scene, the audiovisual aides, the various other people who have been there with us always. Thank you all so much. I have missed out anyone. It definitely isn't intentional. Kindly forgive me. Once again, I would like to say thanks. Nandri, Dhanyavadlu, Valaran Nanni, Dhanyavadakulu, Shukriya. Thank you all. Thank you all once again.
Thank you, madam. Thank you. That was wonderful. And your finishing was very beautiful with all the languages. So can we just proceed with our academic session, madam? Sambat Kumari, madam, can I?
Yes, Priya.
Yes. So we will try to keep on with time. So just forgive us if we are going to stop you anywhere and saying that your time is there. So we are making sure that we'll stick on to the time for the conference. So I'm very happy to invite the chairpersons for the first session. So the first session for today, Dr. Sumati Madam. Dr. Sumati Madam is a professor, Department of ObGyn, KGH. She has 30 years of experience in government and she has 25 years of experience in the ONG, and she's been a teacher for so many years and been a master trainer. She's a trainer of trainer. Welcome to you, Madam. Can we have the next slide, please? Dr. Medharam Mitla Vijayashree Madam. Madam is a professor HOD of the Mamata Medical College, Telangana Hospital. Madam has been the former Foxy Secretary for 3 years and she's been the Vice President SHKM MOGS. And Madam has been awarded the FIC ObGyn in 2017, and Madam has been a great teacher and she has many credits to her, many academic credits to her CV as well. And I would like to invite Dr. Manonmani Madam, the professor and head of Coimbatore Medical College. Madam has been the UG and PG teacher for so many years. We all know she has been got Johnson's Award from the MMC. That is the maximum award people get, and then they award the Johnson's Medal. So Madam has been the medalist throughout, and Madam is still a very good academician. We all know that. So it's a privilege to start with you people. So now over to the chairpersons. Madam Sumat.
Yes.
To invite.
Good morning. Thank you, Priya, for the kind words. I would like to thank Dr. Sampat Kumari, my friend for more than 25 years, who had just asked me to start this session on A to Z in obstetrics and gynecology. I'm first thankful to all the people who had joined here to honor Sampat Madam, because she has been my friend, but not only that, she's been a person who has got dreams to bring everybody together, which I had seen starting from 2000. She has got a dream of bringing everybody together, binding everybody, making laddus and calling her son-in-law as Laddu. So she has made a bond of all the societies of South India. And I am very thankful for her in starting that. I think this academic session should not end with just the academics. Her dream is to reduce all the maternal deaths in whole of India, and all the South Indian societies have to come together, join together in providing care so that we reduce it. Since that is the dream which she always used to say. I hope her dreams of academics continue and also makes it a successful one. With this, we'd like to start the first session. And this session is also very thoughtful for her to start as COVID and pregnancy, where COVID really had we thought that it has sent everybody away from each one, but actually it has bonded everybody through technology, through webinars. And so we are able to connect each one more closer, like how we are. So COVID has really made us together with webinars and academics. And so this is also a very thoughtful thing on bringing us together. So I'd like to invite the first speaker, Dr. A. Geeta Lakshmi. She's a senior consultant and registrar of ISO KGH. And she's a UG and PG teacher. She's also a treasurer of OXY. She's a member of Chennai Menopausal Society. She's got various publications, national and international. She's a very good academician and also a student, teacher who has been welcomed by all the students, very student friendly and a very student initiative. I'd like to invite Geeta Lakshmi to give the first session on COVID in pregnancy. Over to you, Geeta.
Thank you, Dr. Sumati, for the kind words. It gives me an immense pleasure to be the opening batsman of this prestigious webinar A to Z in obstetrics and gynecology. And I really appreciate my friend, Dr. Sampath Kumari, for the initiative. And to go with my presentation, my topic for today is COVID in pregnancy. And I shall share my screen now.
It's okay, நான் முடிச்சிட்டேன். இது செல்ல பார்க்கறதா இருந்தா நோ ஆடியோன்னு வந்து என்ன பண்ணணும்?
Slideshow.
Can we mute the other people, please? Priya,
Is my slide visible, Sampath?
Yes, madam. Yes, your slides are visible.
Yes, Geeta. Proceed. Okay. So to start with COVID in pregnancy, it was WHO on Jan 12, 2020 named a new virus as coronavirus, and now it is called as COVID-19. It is identified following multiple patients who were affected by pneumonia in the Wuhan city of Hubei province. Of COVID and postpartum, it is initially a pulmonary infection, which is by the infected macrophages, and the transmission is by the respiratory droplets containing COVID-19. As far as the transmission of infection of COVID-19 from the mother to the fetus is, the vertical transmission is still a query. And as far as the fetus is concerned, the problems of the fetus can be presented as a intrauterine growth retardation, preterm birth, and the precautions that has to be taken as far as the COVID is concerned is washing hands carefully and regularly, cover the nose and mouth with a tissue when coughing or sneezing, avoid touching the eyes, nose, and the mouth, and maintain a distance of at least 1 meter from others. As far as the symptomatology is concerned, it presents as fever, fatigue, diarrhea, and myalgia. The presence of SARS-CoV-2 genome in vaginal swabs, placental tissue, and cord plasma from a pregnant women, that is the presence of specific anti-SARS-CoV-2 IgM and IgG antibodies in the umbilical cord or of the pregnant woman, as well as in the milk specimens, still the data is to be proved. Next slide. So according to the COVID symptomatology, the factors which play a role are the age, malnutrition, obesity, cardiometabolic comorbidities like hypertension and diabetes, other non-communicable comorbidities like chronic lung disease, including asthma, sickle cell disease, cancer and immunosuppression, infectious diseases like HIV, TB and malaria, and finally the socioeconomic status. The immune changes of pregnancy, the cardiopulmonary changes of pregnancy, the gestational week, and the gestational diabetes and hypertension play a role in COVID in pregnancy. As far as the severity is concerned, when the COVID-19 infection is severe in a pregnant woman, it needs hospital admission, ICU admission, mechanical ventilation, and finally it results in mortality also. The potential effect on the pregnancy, that's a pregnancy outcome, can be in the form of small for gestational age, intrauterine growth restriction or FGR, placental thrombosis and infarction, stillbirth, miscarriage, preterm, premature rupture of membranes, low birth weight, neonatal ICU care, neonatal SARS-CoV-2 infection and disease, and finally the neonatal mortality. Hospitalized pregnant women with COVID can have a severe illness. About half of the hospitalized pregnant women with COVID-19 had symptoms and some presented with a very severe outcome, which resulted in ICU admission, mechanical ventilation, and death. Slow the spread and protect yourself from COVID-19 during pregnancy. It is always better to wear a mask, stay 6 feet apart, wash hands frequently, and continue receiving prenatal care. People who are pregnant or recently pregnant are more likely to get very sick from COVID-19 compared to people who are not pregnant. Among the 598 hospitalized pregnant women with COVID-19, 54.5% were asymptomatic at admission, and 8.5% required invasive mechanical ventilation. And among 272 pregnant women with COVID-19 who were symptomatic at hospital admission, and 16.2% were admitted in an intensive care unit. So during COVID-19, associated hospitalizations, 448 of the 458, that is 97.8%, completed pregnancies and resulted in a live birth. 10, that is 2.2%, resulted in a pregnancy loss. So these are the statistics which show that the hospitalized patients, some were symptomatic, some were asymptomatic, and which resulted in live births where they completed the pregnancies, and a very few resulted in a preterm status. Severe illness includes illness that may require admission in an intensive care unit, ventilation, extracorporeal membrane oxygenation, ECMO, and advanced life support technique used for patients with life-threatening heart and or lung problems, and may even result in death. COVID-19 during pregnancy increases the risk of delivering a preterm earlier than 37 weeks and or stillborn infant. The studies reveal COVID during pregnancy is associated with preterm birth. Then came the Delta variant, that is the second wave. The emergence of the Delta variant in June of 2021 was associated with an even greater risk of severe outcomes for pregnant people, including an increase in ICU admissions, an increase in required medical interventions such as invasive ventilation and ECMO, and an increased number of deaths than was previously reported in the pre-Delta period. The risk of admission to an ICU was 41% higher than in the Delta period. The risk of death in the Delta period was 3.3 times the risk in the pre-Delta period. The risk of invasive ventilation or ECMO was 83%, which was higher in the Delta period, which was a real nightmare to the obstetricians. Non-pregnant versus pregnant, 5 times the risk of admission to an ICU, and 76% increased risk of invasive ventilation or ECMO. Pregnant women may be at increased risk for severe illness from COVID-19 compared with non-pregnant women. So pregnant women and the families should take steps to stay healthy and reduce the risk for getting the COVID-19. So this was a study which was done in Scotland, and we looked at the data that 87,000 pregnant women in Scotland, that is from 1st December to 31st of 2021, 18,395 women had at least one dose of COVID-19 vaccine during pregnancy, and 4,950 confirmed case of COVID-19. Thanks to the CDC for introducing the vaccination. And we all know that vaccination against COVID-19 provides a crucial protection for pregnant women and their babies. Pregnant women doubly vaccinated by the time of delivery was 32%, and all women aged 18 to 44 doubly vaccinated was 77%. Severe outcomes less likely in vaccinated compared to not unvaccinated and the pregnant women with COVID-19. Pregnant people with a symptomatic COVID-19 have a 70% increased risk of death. Only 31% of the pregnant people have been vaccinated against COVID-19. Thanks to the government of India, and we need to educate our patients to get vaccinated from the COVID-19 vaccine, which is nearly available. The impact on pregnancy, there are no certain guidelines as far as the optimum time of delivery and also the route of delivery. This needs to be decided according to the obstetrical indications only till date. There is no clear-cut evidence suggesting that there is a vertical transmission from the mother to the fetus. So a word about isolation and screening. Pregnant women with suspected COVID-19 should be isolated, kept in a single room for screening. Confirmed cases should be kept in the negative pressure room, preferably, or isolation room. Critically ill patients should be in ICU. Delivery rooms and operation theaters should have a dedicated negative pressure room. For newborns, also should have a negative pressure and isolation rooms, and visitors should be limited. As far as the treatment is concerned, there is no definitive treatment. Differentiate illness from the other co-infections and treat accordingly. Only supportive care, adequate sleep and rest, adequate calorie intake, fluid and electrolyte balance, oxygen and respiratory support in advanced cases, ICU stay in serious cases. Initiate the broad spectrum antibiotics to cover community acquired pneumonia, empirical antiretroviral therapy like not yet recommended worldwide, which is tried in China, the alpha interferon inhalation, lopinavir or ritonavir, 2 capsules per day in the dose of 200 milligram or 50 milligram capsules. Clinical monitoring, that is the vitals have to be monitored, oxygen saturation, ABG analysis, review of the X-ray chest as and when needed. Monitor the CBC, metabolic panel, markers of the end organ function and coagulation profile, C-reactive protein. Identify the pathogen. X-ray chest might be required with an abdominal and acute renal failure due to sepsis is difficult to treat by conservative management and may require hemodialysis. As far as the perinatal care and fetal monitoring is concerned, a continuous electronic fetal monitoring, ultrasound is used, Doppler and amniocentesis is avoided in active infection, early delivery only if the mother is critically ill and that may cause impending death of the fetus. Vertical transmission is yet to be confirmed and antibody production in the newborn is doubtful. As far as the mode of delivery is concerned, my subsequent speaker will be speaking in detail about it, but a word about it is that negative pressure isolation room or OT is preferred. According to the obstetrical indications, the route of delivery is decided. Elective LSES is yet to establish any benefit. General or epidural or regional anesthesia can be allowed. Shock, mostly due to sepsis, is treated with fluid replacement and norepinephrine to maintain mean arterial pressure at 60 millimeters of mercury. Oxygenation, that is the oxygen saturation, should be at 95% to maintain the fetal oxygenation. Also humidified oxygen, non-invasive ventilation and endotracheal intubation may be required. The placental disposal, it is treated as a biohazardous waste. Delayed clamping is not recommended. Immediate cleaning and drying of the neonate. Newborns of the mothers who are suspected or diagnosed should be isolated for 14 days. Mother and the newborn are isolated separately. Breastfeeding not recommended, though it shows no virus, can be given once the infection is cleared, and she can express out the milk until the disease is cleared. And this is as far as the neonatal care is concerned. Personal protection and personal wash hands with soap and water, frequently wear masks, isolation, avoid close contact with others, get recent updates regarding the COVID-19, and women with suspected symptoms should contact and follow the guidelines from the isolation treating doctor. And last but not the least, can breast milk transmit SARS coronavirus 2? It is unknown whether SARS coronavirus 2 can be transmitted through breast milk because very few breast milk samples have been tested. So it was the WHO who did that study, and the breast milk samples from 43 mothers were negative for SARS-CoV-2 by reverse transcription polymerase chain reaction, that is the RT-PCR, and samples from 3 mothers tested positive. But specific testing for viable and infective virus was not performed.
Sorry, madam,
So
we are like
this
running
is a
short of
nutshell
time.
of COVID in pregnancy. I thank
Madam,
the
sorry.
organizers for giving me the opportunity, and especially Dr. Sampath Kumari for giving me the opportunity. Thank you. Thank you once again.
Ma'am, I'm Dr. Vijayashree from Kamam. Thank you, Sampath ma'am, for giving me this opportunity. I'm the chairperson, one of the chairpersons for this session. And that was a scintillating talk by Geeta Lakshmi ma'am. We also had a lot of problem to counsel all the patients for vaccination. And I now like to take the privilege to introduce Reena ma'am for the next session. Kindly project the slide, please. Yes, Reena ma'am. She is the professor and head of the department from HBT Medical College from Mumbai. She is a program committee chairperson, Association of Medical Consultants. She is a member of FOXY and COVID guidance and vaccination in 2021. She is a president, Mumbai Breastfeeding and Promotion Committee. She is also a core committee member of FOXY Violence Against Women's Cell, ICOG Governing Council member. And she also had 50 plus chapters in FOXY and other books, with 75 publications in journals. It's really a privilege, madam, to really introduce you. She had 2 gold medals, 5 distinctions, more than 25 prizes and awards. She's also editor of 14 books and author of 2 textbooks, MOGS Person of the Year Award 2021. And she also awarded MGOS Pandit Award for Women's Empowerment in 2017 and many more. She's also PG and duty teacher for more than 3 decades, examiner and referee for MRCOG. It's a great privilege, ma'am. We welcome you, ma'am, Reena ma'am, for the next session. Thank you so much for giving me this opportunity. And again, greetings from Kamam, OG Society. And we will be definitely there with you in the future endeavors, ma'am, Sampath ma'am. Thank you for giving us this opportunity.
Thank you. Thank you.
Welcome, Reena ma'am.
Thank you very much. And it's a pleasure and privilege to be here with you all. And with permission, I will share my screen now. Special thanks to TNFOG. And in fact, if I start taking names of the people here, I think my time will get over. So I thank all of you for the privilege to be here and speak to you on my favorite topic, which is related to COVID in pregnancy. And I am going to focus on the obstetric outcome, since our other speakers are going to speak on neonatal outcome and vaccination. I'm going to focus on the concerns and challenges when the woman is COVID positive at the time of delivery. And that is when we talk about obstetric outcome. And just a word, we just celebrated World Breastfeeding Week and with Dr. Shanta. And before I carry on, I would like to say breastfeeding in COVID positive is definitely recommended. And as the president of the Mumbai Breastfeeding Promotion Committee for last 3 years, we have seen evidence, and we also have data from all our municipal. Yes, can we mute all the others, please? Yeah, and we have data from the Municipal Corporation of Greater Mumbai across all hospitals, which have shown with rooming in, having 1 minute delay in cord clamping. Despite that, we have not had an increase in transmission. So when we talk about the spectrum of presentation, when I talk about obstetric outcome, I would like you to focus on numbers 2, 3, and 4. A majority are mild to moderate. And in fact, I have data of more than 650 patients managed by us in our own hospital, and most of them have done well. But those who come with severe symptoms or are critically ill, or as my previous speaker pointed out, the various high-risk factors, immunocompromised elderly patients, are where we need to look at the problems in the outcome. Sorry, I don't know where this. The slideshow is not happening. Just give me a minute. Okay. The second wave guidance for COVID management in pregnancy was showing that according to the largest systematic study, pregnant women are not at greater risk of dying.
Reena, can you go to slideshow?
Yes, I don't know why it has just exited
Ma'am,
slideshow.
she tried, but it was not happening.
Okay, one second. I'll try again. Huh? Sometimes the computer misbehaves. Yes, thank you.
Yes.
We are back in business.
Done.
Yes, okay. So this is a review when the Delta virus came. Even at that time, there was a review of guidance. You know, we have all changed down the years of 1.5 years. Although we call it COVID-19, I would say it is still there in 2022. And in fact, in my hospital, we are still wearing masks. I'm happy we have shut down our COVID ward. But Overall, there are certain factors of poorer maternal outcome only when they are positive at the time of delivery. Hence, we should not be very worried when things are not going right at that time. Okay. Yes. Now, there is a categorization given by the CDC and WHO, category B1, B2, category C. Most of the women come in the earlier categories where they can be managed by home quarantine. So we need not be worried or have problems. But when they come to you in the hospital for delivery, that's when we are talking about the obstetric outcome, especially if they are category C. Those are the patients we need to be worried about. And when we talk about clinical stages of severity, please note, friends, it is basically by certain red flag signs, such as that she is breathless, having chest pain, drowsy, or hypotension. Only then we really need to be worried. Those with influenza-like symptoms usually do pretty well. And in fact, there is no rush to deliver. In the first wave, we were having more preterm births, more cesarean sections, even in our FOXY analysis. This was because we didn't know what to do. Everybody was confused. Let's deliver them and get on with it. But that is no longer true. When she comes to you in labor for obstetric outcome, the first most important decision is where should you admit her? If she's a suspected or confirmed case, based on the severity of symptoms, you need to decide whether she needs to be admitted to the labor room or to the ICU. Ideally, it has been said we should have obstetric ICUs with beds for admission, but all of us don't have that facility. In the delivery process, a good outcome can happen. Induction of labor may have a longer length of stay, and there are no data about which mode of birth is preferable. Elective cesarean section is definitely a no-no, and I will talk a little bit more about the mode of delivery in another couple of minutes. This is a wonderful review which is actually put up by the WHO. Dr. Mercedes Bonet has reviewed everything from across the various countries, and all of them have come to the same consensus that when they are actually having COVID-19 at the time of delivery or when they are delivering, yes, there is higher preterm birth, higher incidence of NICU admission, and for the mother, higher incidence of ICU admission and ventilation. Stillbirths are more, this was more seen in the second wave, but neonatal deaths are similar. Now for this, before I go forward, we have to understand, this is a little busy slide, but how to understand, test and treat to have a good outcome. There was a lot of confusion on CT score. Now CT stands for cycle threshold. It also stands for CT scan severity score. And people used to get confused between the two. If the cycle threshold of the RT-PCR is more than 35, it's good news that now she's negative. But if the CT score of the CT scan is showing more than 15, it means she has severe COVID. So we as obstetricians need to understand these terms also and interpret the investigations in conjunction with your medical team. And inflammatory markers like D-dimer, CRP, ferritin, LDH, ESR are helpful to us in deciding how to manage the patient. And again, for example, D-dimer, the values can be given in nanogram per ml or microgram per ml. So when the value is above 500, that was a cause of worry if it was in nanogram per ml. So again, understanding your terms is very important for testing and triaging, because people used to get very confused and then land up with problems. And there were many people who were not using the technology or using your masks correctly, which led to further problems. This is a little busy chart put up by our AIMS with ICMR guidance. But here I would like to remember two things. Steroids. Why in our country we had an epidemic of mucormycosis, which was not seen in many other countries, is because general practitioners, doctors started using steroids when there was no hypoxia or very early in the disease in the phase of viral replication. Yes, when there is COVID in pregnancy, we should consider steroids if there is hypoxia. But very important, low molecular weight heparin or unfractionated heparin is very, very important. Pregnancy and postpartum itself is a thrombogenic state, and COVID increases this. In fact, I have one of my own residents who post-COVID has developed brain thrombosis and was admitted into the ICU weeks after COVID. So here we must remember that when we are managing the COVID pregnant woman, the MUSE criteria or maternal early warning criteria, or what we call as the SOFA score or sequential organ failure assessment score, can be modified and used to understand, looking into the confirmed inflammatory markers and decide how we want to manage her further. Due to lack of time, I cannot give you details of the management, but please remember, imaging with abdominal shield should be taken up when required. Most of the times on your clinical symptomatology and your oxygen saturation, you can classify them. In labor, it is a multidisciplinary approach, and very, very important is that pulse oximeter, maintaining the saturation to 95 or more. For non-pregnant women, up to 92, 93 was also acceptable. Otherwise, all your management of labor is as per your standard guideline and preferring a semi-propped up position. Birthing room can be kept separately. Ideally, negative pressure was mentioned by my previous speaker and all the guidelines. But friends, most of us do not have negative pressure rooms, either in the OT or this. So just simple separation, having a separate area where you will going to deliver, and having facilities for neonatal care, delayed cord clamping, skin to skin care, rooming, breast milk, family access, communication, counseling are the key. Do not discriminate against her because she is COVID positive, but have one female attendant who will wear a mask and will look after her along with you. Another thing is about position in labor and proning in non-pregnant patients to improve your outcome. There was a CARP protocol, which is COVID awake repositioning proning put protocol. This worked very well to reduce the risk of intubation. And by putting bolsters, even in pregnant women, you can do this. And for pain relief, of course, if she's already intubated, it's a different question if she's severely ill, but epidural analgesia can be given. Now, the important dilemma, should you continue conservative management of COVID infection or should you deliver the fetus? This actually has to be individualized from case to case. ICMR guidelines had stated that only when there's fetal distress, check indications and only then deliver the patient. There is no indication for cesarean delivery apart from the routine obstetric indications. And in serious cases, if you feel the pressure on the abdomen is going to help her in the ventilation, as the team, you can decide whether you want to deliver her and whether the outcome will be good. But again, informed high-risk consent of the relative should be there so they don't blame you that it was your section which pushed my patient towards death, which should never happen. So timing of delivery, clinical stability, period of gestation, fetal condition, and then you decide based on risk-benefit ratio. Now, where to deliver if she's in labor? Again, if you're trying for a normal delivery, if she's critically ill, we should be prepared to go and deliver her in the ICU. That would be better because it would be under proper supervision, especially if she's immunocompromised or critically ill. And you look at the SOFA score or the MUSE score. In this wonderful A to Z conference, I would like to say that how to treat was also A to Z, starting with antibiotics, antivirals, anti-helminthics, immunomodulators, steroids, Ayurveda, homeopathy, and finally Bhagwan Bharose. But here I would like to say many trials like the recovery trial, the Covacta trial have given certain data which has said appropriate use of remdesivir, appropriate use of steroids in active phase, not in the replication phase, would be useful. And we had a COVID helpline number also when President Sir Dr. Alpesh Gandhi was managing, and we did help or reach out to a lot of people. These guidelines, in fact, in the Municipal Corporation of Greater Mumbai, we ourselves have come out with a book which has been released, which is available with actual management principles from our own experience. And we had a complete hospital called 7 Hills, which was dedicated to it. Physicians' obligations as per the Hippocratic Oath is first of all, do no harm and assess the balance between risks and benefits. Vaccination is going to be covered later, so I'm not going to talk about it. But this is our own cases from the tertiary public hospital in Mumbai where I work. Although we were not a dedicated COVID center, you will find that we had a good obstetric outcome in most of the pregnant women, with just a few having preterm vaginal delivery and not an increased cesarean section rate. In fact, in the first 8 months, we analyzed all the cesarean sections which happened with COVID. And here you can see overall the cesarean section rate in our hospital was 42% because we are a referral center. It did not differ in the COVID positive and COVID negative. And one important
I'm
thing.
sorry to interrupt, 2 more minutes.
Yes, the GA was used only in some cases, and what we had was a good outcome, but the need, now out of 5 patients who went to ICU, only 1 died, and there was no difference in the death in COVID positive and COVID negative. And one important factor, are males more at risk for mortality in COVID? We found that in the second wave, our ladies were at a higher risk. You can see the peak of the second wave in Delta was when women mortality increased. Otherwise, we had a very low case fatality rate. Long COVID outcomes, need for cardiac evaluation is also important in the postnatal period, and continuing low molecular weight heparin for cesarean sections or aspirin. And these are data from our own hospitals, which is showing that with bedding in, keeping skin to skin contact, even then we had very, very good outcomes, and only 0.9% of babies in my own hospital turned positive despite following all these principles. So use your facility preparedness with the with SOPs, infrastructure, PPE, personnel and infection control, have workplace segregation, redistribute. COVID, one of the benefits was that teleconsultation, which can also be done with your COVID positive patients, follow protocols, and it is teamwork. You can see that mobile at the bottom. Doctors from Sion Hospital are giving teleconsultation to Dharavi to overtake, which is India's largest slum during COVID, to overtake the monster of COVID. And with proper infection control, we will have very, very good outcomes without separating mother and baby unless really sick. And with this, I would like to thank all the 5 Telangana OBGY societies for inviting me here to share our experience, and my COVID warrior team. And we promise to give even COVID positive women safe and positive childbirth experience, knowing the proper protocols. Thank you very much, and Foxy for all, always. Thank you.
Thank you, Reena ma'am. Thank you, Reena ma'am, for your valuable information you are given us. Thank you so much.
Yes, Dr. Reena, it was wonderful. Your experience is also very explanatory, that you gave an experience of your hospital's outcome. Dr. Geeta spoke on COVID in pregnancy, and she also had so much of cases being handled in our hospital, where there was, during the first wave, it just came and went away. Whereas during the second wave, we really had so much of problems in managing the patients. And as Reena said, it has to be obstetric indication, but many of the indications were because they were critically ill, where we had to support them respiratory wise. So we had to go in for C-sections. Though we did not have a proper indication for the mother's sake, we had to go in for sections to improve her respiratory outcome. So that was a thing which we had been following during the management of pregnancy in labor. And we have to have our hats off to all the young people who had been going and working along with those pregnant women. All the older chiefs and all were saying that because of this comorbid condition, it was only the younger generation who had been right from the entry till the 24/7, all the younger generation who had been along with all those pregnant women, and also the anesthetic colleague who had so much of effort in managing them. And some of the people, we had to forego, just the mothers, we had to go forego. This was very pitiable condition. We had to lose many of the mothers. So thank you, Reena, and thank you, Dr. Geeta Lakshmi, for the wonderful talk, and also sharing your experience in managing COVID and pregnancy, and also during labor. We would like to invite the next speaker.
Good
Dr.
morning,
Manu,
one and all.
can you introduce?
Yeah, I'll introduce. Good morning, one and all. I thank Sampath ma'am and team for giving me this wonderful opportunity and be a part of this very great CME A to Z. It is my pleasure to introduce Dr. Luke Ravi Chellaya, who is a professor of pediatrics, MMC and Institute of Child Health, which is a very big one throughout the Southeast Asia, and he has been working in government service for the past 3 decades and served in rural government health services. And he had been a team coordinator in many epidemics, and he was COVID ward in charge, apt person who had worked for the past 2 years along with Dr. Srinivasan, and the largest children hospital, treated more than 1,500 pediatric COVID and neonates along with the mothers too. He had got publications in India and international journals, and has been examiner, and he was an office bearer in IAP TNSE. So we welcome you, sir, to speak on your topic on COVID and neonates. None other than who you can speak on that. You're the authority on that. Welcome you.
Good morning, everyone. At the outset, I would like to thank Dr. Sampath Kumari Madam for giving this opportunity. I would like to say that myself and Dr. Srinivasan, a very good friend of mine, and he is now the State Child Health Nodal Officer for the entire government of Tamil Nadu. We both were looking after this COVID at ICH for the past 2 years. Still, we are going through it. So, as the previous madam was telling, it was a younger generation. Of course, we too were the older generation, about 55 years. We have gone to the ground zero. We have seen each and every child, and roughly about 1,500 children along with their parents. So 3,000 patients we have seen, plus the newborn, neonates, and almost for the past 2 years we have been seeing all these children. So a small introduction. Ours is the biggest hospital in Southeast Asia. It's an 837 bedded hospital. We have 36 super specialties and specialties, and we converted one building which was given by JICA, the Japan International Corporation, into a COVID ward, and we had about 100 beds there. So we had different rooms there. We were looking after the COVID children and their parents. The neonates, we created a nursery. It was a brainchild of Dr. Srinivasan to create a nursery in the JICA building, which is a 3-floor building with a lift, and we had postgraduates. Our main backbone were the postgraduates, pediatric postgraduates. I salute the 121 postgraduates and about 200 staff nurses who have taken care of this, without which we both would not have had any problem so far, because they too were on ground floor. So we had staff nurses, 6 staff nurses worked for a week in various shifts. They were staying on the top floor, and we had 3 exclusive staff nurses for neonates, and we had 6 to 9 postgraduate students. So every week they'll go inside the building, they'll stay there for a week, and then they come out after 1 week. They had a quarantine, and we had a good help from the administration and from the government. And so with a small introduction, I like to share my experience with COVID in neonates. So we had seen basically a lot of COVID in what we saw in ICH. We had seen about 55 neonates. We had seen, and out of the 55 neonates, when we did a small study, we found out randomly we picked up many COVID positives, because the policy was we have a newborn nursery at ICH. We have basically extra babies delivered outside. So when they come inside, when they come with a fetus of sepsis or any other issues, we the screening, because everybody was afraid that one baby or one mother should not spread to the entire nursery. So the moment it was found positive, they were shifted to our control. So we both were looking after these neonates and the mothers. So we had about 55 babies we saw during the last 1 year, the peak of COVID last year we saw. And except for some babies who had thrombocytopenia, lymphopenia, and a little bit of neutropenia. And we did not see much changes in neonates, because all the newborns were behaving like normal newborns, except for some few children who were having some comorbid conditions like septicemia or surgical conditions or cardiac conditions. The rest of the 90% of neonates did not have any problem. They were just admitted. They were taken X-ray chest to make sure whether there is a pneumonia or not. Interestingly, in pediatric pneumonia, we never had any pneumonia going for a COVID positive or COVID positive having pneumonia. Hardly we had less than 3% we had. Because in children, I think most probably it's due to the maturation and functioning of the ACE2 receptors, which is very, very much immature in children. I think almost nil in neonates. That is the reason I think most probably the newborn population and the children population, we did not see much mortality except for the comorbid children, of course. We lost 9 children out of 1,500. All the 9 were having comorbid leukemias, heart diseases, kidney issues. And neonates, out of the 55 neonates extramural, we had only 3 deaths. And 1 was referred from a private hospital in Chennai, and which had gone to home, both delivered normally and went home. Both the parents were positive. and referred to us on the 13th day in a very morbid situation. And 36 hours later, we lost the child. This child had a classical GGOs, ground glass opacities, and all the pneumonias. And we tried remdesivir also in this child, but because basically all over the world, nobody knows the treatment of COVID. Even till now, I am very sure, because we have been working in and out with all the children. Even now, I think nobody is very sure. You give this drug, you can cure COVID. Give this one, this will take care. All were symptomatic management. Everybody were giving a trial of error, and we have tried many our own antibiotics. So the basic thing was antibiotic cover for children who were sick and the neonates who were sick. And breastfeeding, we never discontinued. We encouraged breastfeeding. We made sure the masks were worn by the mother, and hand washing, hygiene, sanitation was taken care of. And the mother and the baby was kept inside. We were given very good nutrition. The excellent support by the state government and the administration, we were able to provide nutrition for the entire 2 years, and for the mother and for other children also. So basically, it was the nutrition support, the breastfeeding support for the neonate, and symptomatic management. And basically, since even though the protocol sometimes said you don't repeat COVID while this thing, and to the basically all these children were RT-PCR positive. They were not other tests. And all these children, we made sure only RT-PCR, COVID RT-PCR positive only we kept inside, and then we took it. And the antibody, very few turned positive, some did not turn positive. So we did not have much issues. And another one, they were talking about the multi-inflammatory system, inflammatory response and MIS-C. Not much we saw. It was about less than about 5% or so, because this is the age-old concept. Previously, when we had been dealing with dengue for the past 6 years in Tamil Nadu, it's something called secondary HLH, hemophagocytic lymphohistiocytosis. I think it was renamed as MIS-C, I think, recently for many reasons. So not much of a MIS-C we saw, and when everybody were doing antibodies, RT-PCR and all, we just kept quiet. We kept the children, neonate, breastfeeding, symptomatic management, treated, discharged. So almost 99% of these neonates just went home very quietly. The 3 deaths were one child had a Hirschman's disease, died because of many surgical. 3 times it was operated, it died. And one child had a florid septicemia. This was a baby whom I just spoke to. And one more child had a heart disease. So we did not lose any neonate due to COVID per se, if I am correct. So our experience, I tell you, COVID neonates, we did not have any issues. And I think it was something around 8 to 9% of the total deliveries, they had COVID positive babies, RT-PCR babies, and only about less than 1.5% was having horizontal transmission, what we said, because whenever we say vertical transmission, it is day 1 or maximum day 2 within 24 to 36 hours. But what we saw was basically horizontal transmission. They go home, they come out at day 5, or they go to the postnatal wards, they come from there. So vertical transmission, horizontal transmission, it was 1/4 of the positivity babies. So 10% we get among the total deliveries, and out of the 10%, 3/4 were vertical, that is 1 to 2 days. Again, we did not know how much babies were handled by whom. So it all comes to square, and basically the only issue was the treatment was symptomatic, breastfeeding was given, and there was no statistics regarding lower socioeconomic or higher or middle socioeconomic. In fact, lower socioeconomic, we did not see any mortality. It was less than hardly 10%. So again, the demographical pattern and the socioeconomic group pattern, we did not find much difference. Male-female ratio also we did not find much difference. And CT chest we did not do for any neonates except for this only baby who was done CT chest and referred from outside. Only for children, few children we did CT chest. CT chest was never done for any neonate except when they were symptomatic. So our investigations are very simple: CBC, X-ray chest, CRP, and then after the day 5, inflammatory markers such as ferritin, procalcitonin was done. So the simple thing, we just managed the entire thing. Symptomatic management, regular antibiotics, ampicillin, gentamicin, acetylfox, amikacin was given. And few children, they received piperacillin, tazobactam, and 3rd generation cephalosporins. So this was our experience, myself and Dr. Srinivasan, what we saw in ICH. So with this, I would like to thank everybody, especially Dr. Samathkumari Madam and the entire OG team, because my wife is also an obstetrician. So I like to definitely have to thank the OG team, she'll get all right. So once again, thank you so much for everyone. Thank you for the opportunity, Madam. Thank you so much.
Thank you, sir. Thank you for sharing your vast work at ICH. So in Coimbatore also, in the second wave, we had maternal deaths because the second wave it peaked and we had so many mortalities because of COVID. And as you said, the involvement of the baby neonates were very less only. And some deliveries we had to plan cesarean, as Sumati madam was saying, for maternal resuscitation. So we had 1,000 deliveries during this entire COVID period for the past 1.5 years in Coimbatore, because we were the nodal center for the nearby 4 districts, and we had a better NICU here. So our NICU team stood with us in treating the COVID mothers. So thank you so much. Thanks, Sambat ma'am and team, for giving me this opportunity.
Manonmani, only one point. I told Dr. Ravi yesterday night only.
Okay, madam.
Due to some problem. So thank you, Dr. Ravi, so much.
Thank you, madam.
Yes, and thank you, sir, for sticking on to the time. So we are like very well in time. So thank you all chairpersons, and thank you speakers. It was wonderful session on COVID, and it was very enlightening for us. So now, thank you. So I would like to call the chairpersons for the session 2. We are moving on to session 2. So our first chairperson is Dr. Soumya Patil Madam. She's Assistant Professor, Department of ObGyn, Mahadevappa Rampur Medical College, Kalaburagi. And Madam is a Secretary Foxy there. And can we have the next chairperson, please? Yep. Dr. Rupa Prakash Madam. Madam is from Mysore. Madam is an Assistant Professor of KMC Manipal, and she's been the unit head of JSS Medical College. Sorry, madam, we can't hear you. You're talking. Sorry. She's been a teacher for UG and PG, and madam has been the organizing secretary for many conferences as well. The next CV, please. So Dr. Kasturi Madam, we already introduced Madam in the inauguration. Madam is a President Karnataka ObGyn Society. Madam is from KIMS Hubli, and she has been the organizing secretary for many workshops, CMEs and conferences, and she's been the trainer of trainer and PG and UG examiner as well. So can we, I'm just handing over the mic to the chairpersons. So Dr. Soumya Madam, can you introduce Dr. Aruna Madam? You're muted, Dr. Soumya ma'am.
Thank you. Very good morning to everybody. Dr. Aruna Kumari K. Madam, she is graduated from Ranga Raya Medical College, Kakinada, from in the year 1991.
Yeah, you can introduce.
Yes. Dr. Soumya Madam, sorry, we can't hear you. The network is not very good. So I would like to, Madam, can you hear us?
University. She was topper for the university in her final MBBS, and she has done postgraduate ex-associate professor for GSL Medical College, Rajhalton, in Harsha Hospitals, Rajahmundry. Pregnancy. She started Rajahmundry. Hello, ma'am. Am I audible?
Yes, you're audible.
Good morning, ma'am. Yes. Hello.
Yeah, you're audible, madam. Please go ahead, ma'am.
Soumya, you can proceed. Dr. Aruna Kumari can start presenting, I think.
Yeah, because we have
Thank
already
you,
introduced.
Thank you for your kind remarks. Can I share my screen now?
Yes, ma'am.
Yes. Yes, ma'am.
Good morning, everybody. It's really honor and a privilege to share this screen with all of you. First, let me thank the TNFOC organizers, especially Sampat Kumari Madam, Sri Priya Madam, and my president, Dr. Ganga Madam, to giving me this opportunity to share few of my views on RH management of RH ISO immunization with all of you. So, RH allo immunization, once associated with increased perinatal morbidity and mortality, is now a rare clinical entity. Advances in prevention and treatment of RHD allo immunization has been one of the great success stories in this modern obstetrics. This story started 80 years back in 1940 when Lance Steiner and Wiener identified RH factor in rhesus monkeys. 1 year later, Levne et al. Identified that this is the cause for the disease erythroblastosis fetalis and immune hydrops in babies. Thus, 60% of this story is completed in 1961 when Lilly characterized the natural history of this disease and did serial amniocentesis to identify severity of the disease and provided Lilly charts for identification severity of the disease and started intraperitoneal transfusion for hemolytic anemia, which is the first treatable fetal condition. Later on, the story is almost 100% completed in 1964 with active immunization with anti-D by Freda et al. So after that, since then there's so much progress has been occurred in identifying and understanding intricacies of this complex disease and improving the prognosis. The key developments among them are the performance intravascular transfusion done by Rodak et al. In 1981 and the diagnosis of fetal anemia with non-invasive technique, that is MCA Dopplers, in 2000 by Mary and co-workers. So friends, today I'm going to discuss this story under the headings of incidence, pathogenesis, prevention and management. Coming to incidence, the prevalence of Rh negative blood type in Indians is around 5%. Approximately 16% of the negative pregnant people become allo-immunized after birth of the first Rh positive baby with ABO compatibility. If these babies have associated ABO incompatibility, the chance of allo-immunization is only 2%. With the availability of the effective immunization protocol, this chance of getting allo-immunized has decreased to 1 to 2% with postpartum immunoprophylaxis. This chance of early immunization is further reduced to 0.0 to 0.3% with the addition of routine antenatal administration of anti-D. So before going to pathogenesis, first I want to remind you there are 30 different blood group systems and 328 red cell antigens are identified on human red cell membranes. The Rh blood group system itself contains more than 50 antigens. The common antigens that can induce sensitization are capital D, C, E and small c. Mind you friends, all these antigens can cause allo-immunization in the pregnant patient and can affect fetus. The RhD antigens are more immunogenic when compared to other Rh antigens. So the presence or absence of anti-D antigen will identify the patient as Rh negative or Rh positive patient. Coming to pathogenesis, when Rh negative individual exposed to a Rhd positive antigen will cause stimulation of an immune system to produce anti-D antibodies, that is allo-immunization. Initially, these antibodies are IgM, which cannot cross placenta because of their bigger size. This is the reason why the majority of the first pregnancies are protected. After some time, maybe after 6 months, the IgM antibodies will convert into IgG antibodies. So during next pregnancy, when this patient got second insult with the second conception of the Rhd positive baby, there will be increased production of IgG antibodies, which can cross placenta and can affect the fetus. They will bind with the fetal red cells and cause destruction of the fetal cells in the fetal reticuloendothelial system, leading to fetal anemia, which is the basic cause for the pathogenesis of all fetal and neonatal consequences. With the fetal anemia, there will be fetal hypoxia and stimulation of erythropoietic system, erythropoietin, leading to extramedullary red cell synthesis, hepatomegaly, splenomegaly, hepatic failure, hypoproteinemia, hypoxia, cardiac failure, everything. The main main problems associated with fetal disease we can say are fetal anemia, hydrops fetalis. When there is severe anemia, the fetus will develop cardiac failure and hydrops fetalis. Hemolytic disease of the fetus and newborn, icterus gravis, neonatal and kernicterus, stillbirth and neonatal death. So because it's a vast topic, I should cover in 15 minutes. I'm a little fast with my slides. So the events that can cause maternal allo-immunization are, first, the most important thing is transplacental feto-maternal bleeding during pregnancy. The events that can cause transplacental feto-maternal bleeding are abortions, pregnancy terminations, ectopic pregnancy, invasive in vitro procedures like chorionevelus biopsy, amniocentesis, cardocentesis, second and third trimester fetal deaths, abdominal trauma, maternal abdominal trauma, antepartum hemorrhage, external cephalic version, etc. The other events that can cause sensitization are inadvertent transfusion, mismatched transfusion, etc. So, the transplacental feto-maternal bleeding accounts for virtually all cases of maternity alloimmunization. The frequency and volume of spontaneous feto-maternal bleeding increases with advancing gestational age and is highest at delivery. Usually in the first trimester it is less than 0.3 ml. At delivery it can go up to 40 to 250 ml. So less than around 0.1 ml RHD positive RBC are sufficient to cause alloimmunization in the mother. The antibody response develops slowly and usually not detectable until 5 to 15 weeks of the first exposure. So how much bleed has occurred we can identify with the help of K-Bedke test or flow cytometer. With this test we can identify how much transplacental feto-maternal bleeding has occurred. Coming to prevention, all pregnant women should be tested at the time of first prenatal visit for ABO grouping and RH typing. All those who are RH negative should be tested for presence of RH antibodies with ICT test at the first visit and in the third trimester around at 28 weeks and after delivery. If this patient is RH negative, her partner should be tested for ABO blood grouping and RHD typing. If the father is RH negative, then the baby is safe. The baby will be RH negative, then there is no need for any monitoring of the pregnancy. If the father is RH positive, then if the facilities are available, we should get the paternal RHD zygosity. If father is homozygous for RHD positive, then which will occur in 40% of cases, all fetuses in this patient are RH positive. So all of our pregnancies should be monitored carefully. If the father is heterozygous, which can occur in 60% of cases, then there is 50% of chance for this baby to become RH negative and 50% chances for RH positive. In this case, we should be able to get the RH typing of the baby with non-invasive cell-free fetal DNA testing from the maternal plasma or by doing PCR and uncultured amniocytes obtained from the amniocentesis. So for immunoprophylaxis, usually we use this anti-D immunoglobulin. A single dose of 300 micrograms contains sufficient antibodies to suppress immune response of 15 ml of D positive fetal red cells or 30 ml of D positive whole blood. The half-life of this anti-D is around 24 days and it provokes protection for 12 weeks. The low antibody titers after one injection of anti-D may persist for many weeks. So in first trimester, because the transplacental bleed is very less, only 50 micrograms dose of anti-D is enough. In second and third trimesters and in postpartum, the standard 300 micrograms dose is recommended. The RCOG and ACOG now recommends the screening for excessive feto-maternal bleeding, either with the KB test or with flow cytometer, and adjust the dose of anti-D by using the following formulas. I'm not going
sorry
into
to interrupt. Last 2 minutes, ma'am.
Last 2 minutes. Oh. Immunoprophylaxis, it can be postpartum prophylaxis or antenatal prophylaxis. Postpartum is within 72 hours. If you cannot give this within 72 hours, which the recommendation is we can give it up to 28 days after delivery. And the antenatal prophylaxis is single dose at 28 weeks after confirming that the patient is ICT negative. Coming to immune prophylaxis in antenatal period, it should be given in all occasions where the transplacental feto-maternal hemorrhage can occur. After abortion, if the surgical termination is done, after molar pregnancy termination, if with a recurrent hemorrhage, recurrent antenatal hemorrhage, if it is occurred within 3 weeks after anti-D, we can withhold the anti-D, we can repeat the anti-D titers. If they are negative, then only we can repeat the anti-D. All these conditions should receive immunoprophylaxis. Coming to management. The first pregnancy is always mild disease. With successive pregnancy, the disease will become more progressive and more severe. The main steps are first determine RH fetal type, monitor the fetal anemia. If anemia is severe, then confirm it with fetal blood sampling. If the anemia is severe near term, then deliver. If it is removed from term, intravascular transfusion. So RHD type identification we already discussed. Coming to management of first history is very important. We should take the history of previous pregnancies, obtain indirect Coombs test in the first visit, and repeat it every month as long as it is stable. If it is rising, then repeat it every 1 to 2 weeks. If it reaches critical titer, then we should start monitoring with MCA Dopplers. The MCA Dopplers, the indication is when we reach critical titers in first pregnancy or from 16 weeks in the subsequent pregnancies. If the MCA is more than 15 MYMs for gestational age, then we should start doing fetal cardiocentesis and estimate for anemia, levels of anemia. Coming to intrauterine transfusion, the main indications are severe RH alloimmunization before 34 weeks, or severe fetal anemia, that is hematocrit less than 30%, hydrox fetalis. Intraperitoneal transfusion, nowadays it's rarely indicated, only in severe disease before 18 weeks of gestation, where intravascular transfusion is very difficult. Coming to intravascular transfusion, it's the most preferred one. It should be under ultrasound guidance into the umbilical vein. Our aim is to reach the target hematocrit of 40 to 50%. It can be repeated every 2 to 4 weeks depending upon the severity. So coming to prognosis in subsequent pregnancies, usually they are severe than first pregnancy. The antibody titers are inadequate in surveillance of these patients. We should begin MCA, the middle cerebral artery Dopplers, from 16 to 18 weeks itself. If those patients with severe disease in the previous pregnancy may benefit from type of immunomodulation, but the effect is not proven. Neonatal outcome, usually in unaffected baby it's normal. After intravascular transfusion, if it is non-hydropic baby, the survival rate is around 92%. In hydropic babies, it is around 70%. And long-term outcome in 90% babies, it's normal. So as I already discussed, with each subsequent pregnancy, the severity will increase. If the patient has severely affected during this pregnancy, it is better to avoid Rhd positive conception in this pregnancy. How can we do that? By using donor sperm of Rh negative father, or in vitro fertilization with peri-implantation genetic testing, or use of a gestational carrier. So take home message. To finalize, the Rh alloimmunization is a rare clinical entity now. The Rhd negative non-immunized pregnant women should be screened for presence of Rh antibodies at first visit at 28 weeks and after a delivery. The antenatal prophylaxis should be given at 28 weeks after confirming negative indirect Coombs test. The postpartum prophylaxis after delivery should be given within 72 hours after confirming Rh positive status of the baby and negative direct Coombs test. Coming to management of alloimmunized pregnancies. So as we already discussed, first we should determine the Rh group of the baby. If baby is positive, then we should start doing serial maternal anti-D titers. If the titers are stable, it should be done every month. If they are rising, then it should be 1 to 2 weeks until it reaches critical titer. Once the critical titer has reached, then we should start doing middle cerebral artery Dopplers and peak systolic velocity at 1 to 2 weeks. If it is more than 1.5 millimoles, then we should do the cardiocentesis for fetal hemoglobin estimation. If the hematocrit is less than 30% and the patient is nearer term, deliver her. If the MYMs are less than 30 and patient is remote from term, then do intravascular transfusion. And if the MCM Doppler is less than 1.5 MOMs for gestational age, then we can continue with the monitoring the Dopplers till term and we can deliver the baby at around 37 to 38 weeks. If the MOMs are more than 1.5 for gestational age and the cardiocentesis showed that its anemia is not severe and the hematocrit is more than 30, then we can continue monitoring this baby with every 1 to 2 weeks cardiocentesis and estimation of the hemoglobin. If there is severe anemia occurred, then we will go for intravascular transfusion. If the baby approaches term, then we deliver the baby. Thank you.
Thank you, madam. Now I would request Dr. Kasturi madam to introduce Dr. Kurian sir for the next talk. Dr. Susila madam is having some problem with the network connectivity, so madam will be doing it after this presentation. Can we have the CVs, please? Yes, thank you. Kasturi Madam. Madam.
Oh, Kasturi Madam is not there, I think. So now we will go. Dr. Kasturi?
Yeah.
I told her, Madam, she said she'll do that.
Okay, no problem. It's our pleasure to introduce our Dr. Kurian sir for the keynote.
Hello.
Dr. Kasturi?
She's come, Madam. She's back. Dr. Kasturi, Madam, are you there, Madam?
Hello.
Dr. Kasturi, are you there?
Yeah.
Yes, you can introduce our keynote address, Dr. Kurian sir.
Yes. It's good morning, everyone. It's a moment of pride and pleasure to introduce such an eminent personality whom we are following since many years, Dr. Kurian Joseph sir. He is the director of Joseph Hospitals, a more than 60-bedded hospital at Chennai. He is a pioneer in gynec endoscopy in India, started training. I think he's the who's who of gynec endoscopy and the first one to start. We always used to look up to sir's training when we were students. And he's president of Asia Oceania Federation of Obstetrics and Gynaecology, 2013 to 2015, International Society of Gynec Endoscopy, board member till 2011, Federation of Foxy Vice President 2008, organizing chairperson ASIOG 2015, Chennai. I remember still, it was such an excellent event. Still, we hold the memories of ASIOG 2015, sir, under your chairmanship. And past president OGSSI, chairman of Tamil Nadu chapter of Indian Association of Gynec Endoscopy. With these few words, I welcome Dr. Kurian Joseph sir. It was real honor and pleasure to introduce you, sir, to this august platform. Over to you, sir.
Thank you, ma'am. And let me see where my video is now. Can you see the video?
No, sir.
Yes, sir. We cannot see the video, but
No. Can you see the slide?
No,
sir, we can't see anything.
No, we can't.
Sorry, I'll do it again.
Sir, please click on share screen one.
Yeah, I thought I did it.
Yes.
You see
Now
now?
we can.
We can see your slides, sir.
Sorry. Can you see that better now? Yeah.
Yes, sir. Yes, sir.
Okay. Good morning, everybody. I'm happy to be back in Chennai. I was away for about 10-12 days. I just got back from the University of West Indies in Kingston, Jamaica. And the people there are such lovely people. You can see people from all over, from Antigua, from Barbados, from Bahamas, all of them coming to learn laparoscopy. But what I learned from them is they have a cesarean section rate of 21%. They have problems similar to us, maybe even more. One of the beautiful, unusual fruits you find in the West Indies is called the ackee fruit. You see that red fruit there? That is used in curries. It's an excellent dish to eat. So that's what I enjoyed there. My grateful thanks to the AKKTT societies for inviting me. My only query to Dr. Sampath and others was what happened to little P? Why did we ditch poor Pondicherry? I think we should have all of them also as part of the group. Anyway, that beside, my topic today is VBAC, its relevance in 2022. Simple, because we are with South India, southern states have a higher percentage of C-section deliveries. I don't know, this Telangana rate is so high, 57.7, but these are all 2018 data. I couldn't really get anything for 2020 and 2021. But whatever it is, it definitely highlights the issue which we are facing. The northern states, I feel those reports are not really very correct. 6.2% C-section rate in Bihar is a big joke. I don't think that's correct at all. But anyway, let's see with our problem. South India, we have such high rates. But what about worldwide? What's the picture? You have fantastically high C-section rates in countries like in Brazil. We're talking above 50%. Women don't like to have normal delivery because they believe that the vaginal passage gets damaged irreversibly if they undergo cesarean section. So you see rates are very high. Even in the United States, it's about 32%. So Indian rates are variable from anything between 17 to high rates of 60 to 70%. So the story which we were facing was in 1916. Once a cesarean, always a cesarean was the dictum. Then in 1966, it became once a cesarean, always a trial of labor. Then later in 1997, once a cesarean, what to do became a big controversy. WHO issued a statement in 2015, which said that every effort should be made to provide cesarean section to women in need, rather than trying to achieve a specific rate. So it's not important to only sit on the rate, is what they are emphasizing. What have we been able to do in our own hospital? In our own hospital, I've just put the data over the past sort of 5 years. Our C-section rate is around 20.89. But if you see over the 5 years, during the COVID period also, our workers, especially led by Dr. Tarun, Dr. Sivashankari, kept everything quiet. We had a fair number of deliveries and C-section rates, but the rates were kept very much under control. So this I would think of not as anything fantastic, but this is what I think that most of you should try to achieve in a normally running hospital setup. So if you take our LSCS rate and analyze it a little more, you'll see that our primees who underwent LSCS, that's the first LSCS, the rates are more or less standard. And the total keeps varying depending on the multis and depending on the repeat C-sections which keep coming up. So let's stop discussion on the CS rate. We have to put it on hold. Let us start collecting data uniformly, which will be able to move our focus from CS rates at population level to CS rates and outcomes in each group based on the Robson classification. Only if you can do that will we have data and evidence, plus only then we can compare ourselves with what rates and pictures, or rather where we stand. So with this in mind, I thought I'll just have this talk on relevance of week back in 2022, although I'm not able to get very much literature of 2021 and 2022. But I must appreciate our obstetric team, Dr. Sivashankari and Dr. Priya, who was working with us, for providing me with the data which I'm trying to present to you. So the first question is, should we attempt VBAC? Yes or no? If the answer, which you're going to tell me, is no, then my talk is over. I don't need to spend your time talking to you anymore. But in my talks with consultants at corporate hospitals in Chennai itself, the standard statement, we don't have time to sit and watch these patients. It's so much easier to do an elective section, elective repeat C-section, and everything is over. Everybody is happy. So why should we do it? So this is a big question which all of you will have to keep thinking about. Because if all these patients are going to have elective repeat sections, then this would be the scene outside the OT. Patients are going to line up for C-section from morning to evening, and you're going to get fed up doing sections, not to mention the associated problems of multiple C-sections and thereafter. So in today's stand, where do we stand? We select patients, monitor, counsel, induce labor, if they don't have spontaneous onset, and instrument delivery. A few points. So the first thing is the terminology keeps changing alphabets. If you have delivery after C-section, it's today termed as planned repeat cesarean birth or cesarean delivery. So that will be PRCB or PRCS. The trial of labor is simple. TOLAC, T-O-L-A-C, that is trial of labor after cesarean section. Vaginal birth after cesarean, all of you would know the VBAC term. And the other term which comes in is emergency repeat cesarean section, or ERCS. I don't know why they had to put so many English alphabets to confuse you, but each time somebody says the words, you're going to get confused. So for just clarity, the planned repeat cesarean birth or delivery in a patient who is unfit or unwilling for TOLAC is PRCB or D. The trial of labor after C-section is feasible in over 80% of the patients. And you will see even we have had very good results doing trial of labor and delivering these patients. So vaginal birth after C-section is the ideal endpoint which we are all aiming at. But the dreaded problem which we are very worried about is emergency repeat cesarean section, which is the most unwanted endpoint. So who would you counsel for VBAC? The nice guidelines are very simple. History of one uncomplicated lower segment transverse cesarean section in an otherwise uncomplicated pregnancy at term with no contraindication to vaginal birth. So it's a simple looking statement to read, but you can see there are about 5 variables in it. And all the other things outside this would be for what they call as elective or a repeat cesarean section or cesarean delivery. So when we are looking at trying to deliver a previous cesarean, what would you look up in the past history? Are you worried about the indication for the cesarean section? If the CS for cesarean section was done for maternal indications, if it is a repetitive indication, definitely one would be worried. But if the cesarean section was done for fetal causes, one need not be so worried because it may not recur in the next pregnancy. So look for the indication for the previous cesarean. We mentioned of Robson's classification. Robson's classification is very simple, using just 5 criteria and grouping all sections into 10 groups. Now, if you group it on this, the big advantage is this classification helps in a critical analysis of C-sections. You'll be interested to know that in our hospital, every week the deliveries are grouped and classified according to Robson. So presenting the data at the end of it makes matters very, very simple. So this is the data of last year, 2000, I can't see it sitting up there, that's all right. Sorry, yeah, 2021, yeah. Where we had about 200 odd C-sections. These were the C-sections here. The important part is Robson group 1 to 5 focused on the majority of the cases. That's about nearly 80%. Group 6 to 10 accounted only for about 15% of the obstetric population. That means a relative contribution of just 20% of the overall C-section rate. So once you can put it in Robson's grouping, it makes matter very, very simple. So what else would you like to look for in the past history? Look at all the incisions, the inverted T made, or the J, or the previous 2 cesarean, or the previous myomectomy. Previous single layer closure has been highlighted several times. But even today, there is little in literature saying that there is an increased incidence of rupture following single layer closure. We have been doing a single layer closure for the past at least 10 years to my knowledge. We have hardly had any ruptures because of that. And we also know that the patients stand VBAC deliveries very well. What about previous classical cesarean? Definite no. And previous lower segment, vertical incision, again a big problem. One should not think in terms of all that. So look for all these previous incisions. If you know that these previous incisions are there, be careful. This brings us to the next aspect. Today, we have an option of using calculators or models to predict vaginal birth after a previous cesarean delivery. Some of the standard calculators are the MFMU, that's a maternal fetal medicine unit calculator, or the VBAC calculator. If any of you are interested, just Google MFMU calculator. The calculator will jump up to you. It's an online calculator where you can put the relevant data like maternal age, height, weight, pre-pregnancy BMI. The race has been taken out in the current version. Prior vaginal delivery, prior VBAC, all makes things better for delivery. And previous section for arrest or non-descent is a problem which one has to watch. So if you put in all these data into the MFMU calculator, you'll get a score. And based on that score, you can try and proceed further. But an important point to note about calculators is the calculators have still not been prospectively validated. We are trying to do a study. If we get some results which are worth it, we'll be able to tell you. No calculator has been validated in women with multiple gestation. And the other important thing of a calculator is it does not highlight patient-specific morbidity. That means whether a particular patient is more prone for rupture uterus or not does not come in the calculator. So if you get these calculators working, then your job is very simple. You have to straight away go to an algorithm. The algorithm are, it's very simple. You check whether any of these following are present. That is previous uterine rupture, the scars I mentioned to you, any other contraindication to vaginal delivery. If there is one of these, straight away, TOLAC is contraindicated, patient goes for elective repeat cesarean section. But if it is no, then you think of the incision which was given at the previous cesarean. Now, if that incision is known to you, it's a classical type, there is no problem. But if the incision is unknown to you, then you'll have to think in terms of what type of incision. Was the gestational age of the patient at that C-section below 28 weeks? Was there lower uterine pathology which caused problems? Anything telling us that the incision is extended into the upper or the fundal portion of the uterus, then that's a no-no for a VBAC. But otherwise, use the calculator and pick up the numbers. If you use the calculator, you get a result of greater than 50%. Remember that this is a positive sign. The chances of her delivering are very good. But then again, please note that a result of less than 50% does not rule out VBAC, but tell the patient that it is below 50%, and thereby we will watch her at labor and then think in terms of doing an elective C-section. So once you've done this, then where to attempt the VBAC? You definitely have to have an ObGyn trained setup, nurses, good anesthesia support, neonatal care, and equipment for running the doing an emergency C-section. All these are standard requirements available in most cases. So what you need to do is to just go ahead with that. But what about in the smaller hospitals where support systems are not very good? This is where we will have to try, our society will have to draw up a basic minimum need, which they can set up and thereby proceed with the with trying to do a TOLAC or a trial of labor after C-section rate. Antenatal counseling for VBAC. Sit the patient down when to start at antenatal booking, no doubt at all. What to emphasize? Greater than 70% success rate and definitely another 1 to even just 2% low rupture rates. Do we need to record it? This is again becoming a problem because patients will later on say that nobody even asked me whether I want a cesarean or a normal delivery. All these statements will come only if there is a problem. So the question of recording it is something which you will have to see at your individual hospital level. But the important thing is, if you have done this at antenatal booking, when she comes in labor, please reinforce it. Tell her if you want an elective section, we are willing to do it straight away. But if not, we are willing to do a trial of labor. But remember, your success rates are good in most patients. It is around 70%. That means just 30% escapes. So what factors lead to success? the first and the most important factor is the desire of the patient. You have such committed patients coming, saying, sir, I want to deliver normally. They come in labor. We think they're not going to progress. And before you know, the baby comes out. The desire of the patient paramount, and you have to pay attention to it. If the patient has had a previous vaginal delivery, that is before a C-section, the chances are very good. Spontaneous onset of labor, very, very impressive to support and proceed with the patient. A previous non-recurring indication for C-section, also very favorable for us. And also you must have a managing team which has time on their hands. You have to spend time with the patient. She will progress normally. So I just want to leave you with the words of Abdul Kalam. He said, don't read only success stories because you will only get messages. Read failure stories and then you will get some ideas on how to get success. So what are the factors responsible for failure? Here, the time interval between sections, less than 18 months, is a problem. Induced labor or BMI, which is large, or in a short-statured patient, again a problem. A patient admitted with cervix dilated less than 3 centimeters will take time. If the onset of labor is greater than 41 weeks, your chances of failure are higher. I'm not saying you can't attempt, but failure is higher. And a big baby, yes. A big question is being raised about the male baby. I've got nothing to support it, and that's why I put a question mark next to it. Intrapartum management, immediate access to C-section if needed, blood if needed, emergency, continuous fetal heart monitoring. A partogram is very important because the partogram helps you to time the delivery. If the delivery is going on for too long, remember that your chances of failure are definitely higher. So prolongation of labor is an important sign of dystocia, especially when you're trying labor in a previous C-section rate. What about the intrapartum support? Two important factors, role of induction and the role of augmentation. Induction, we do as a routine with Foley's catheter. We do not use any misoprostol, no other prostaglandin is used because we believe that the Foley's catheter works much better. Once the patient gets into early labor or is not getting into labor, we believe in doing an artificial rupture of membranes. If needed, we use oxytocin. The importance is to have a planned protocol. Should we have elective induction greater than 39 weeks? That reduces the rate of C-section rate and a risk of perinatal morbidity. That came in the NIH report in 2018. But remember, that also may result in a prolongation of labor, which may result in associated problems. So when labor is induced, the rate of uterine rupture was low. But remember, the risk was found to be high. And also the risk of LSCS was higher. So the important message is, if you can get the patient spontaneously in labor, nothing like that. If not, go ahead and induce. So the factors which are affecting the success of TOLAC is the place of C-section important. Around 62% of the cases we tried for TOLAC were C-sections done in our hospital itself. So we were not worried. But the remaining 45%, one would have to be worried. But today, we just monitor the patient as if they were all done in our hospital. And any sign of distress terminate the attempt of TOLAC. The lower rate of successful vaginal delivery in older women. If they are greater than 35 years, yes, failures are more. BMI again above 30, were 50% less successful for VBAC. Twin multifetal gestation pictures not clear at all. We have had both sides pictures. Some of them get into labor easily, proceed. Some just don't get into labor. We end up doing repeat section. As I mentioned earlier, the inter-delivery interval should be less than, I'm sorry, it shouldn't be greater. Less than 18 months results in a decreased rate of VBAC. What about fetal anomaly? This is the tricky aspect. If the fetal anomaly is not macrosomic, yes, you could definitely attempt a VBAC. But if the baby is macrosomic, do not do that. What would be the effect of epidural anesthesia on the success of VBAC? The regional anesthesia should really help us because the patient gets calm and a calmer patient dilates much better. Effective regional anesthesia should not be expected to mask signs and symptoms of uterine rupture. And if needed, use Ventouse or use the forceps as indicated. Any advantages of doing a VBAC? Multiple. The mother does not have problems of multiple C-sections. All of you will be seeing the issues of cesarean niche, mothers with a densely adherent placenta. All these issues are not there if you have a VBAC. Babies, if taken care properly, no problem. Obstetrician feels very satisfied and the insurance companies are very happy with you. But there are problems with VBAC. I don't have to say that. The biggest problem is the emergency repeat C-section. Because the patient has gone to labor, problems are increased, and if you struggle in a stretched out lower segment, you may damage the mother, you may damage the baby. Emergency repeat CS is the biggest bane of VBAC. Other problems are rupture uterus, dehiscence, fetal death and morbidity, and sometimes you have even hypoxic ischemic encephalopathy. All these are fortunately unusual, but even one of them is enough to spoil your whole year's record. So be careful of that. This is a record of what we have done in our place. You can see that each year, these were the patients we had previous cesarean section. So in 2021, we had about 153, of which 54 were delivered. Our incidence of vaginal delivery is about 64.28%. In 2020, 2019, 18, all the years, these results look quite impressive. But the sad part is the last line. We've had ruptures. Fortunately, most of these ruptures were very early wound dehiscence, picked up, baby delivered through the scar itself, and the wound closed. But one rupture we had in 2021 was bad. It was a very sudden rupture. The uterus ruptured, the bladder was torn, and the baby also was very badly affected. That was the only baby we have lost. The baby was lost due to HIE. So remember, you have to be careful in all these situations. Sometimes incidents occur very fast, and that's the importance of keeping your setup ready. The signs of uterine rupture, you know very well. I don't have to go into that.
Hello.
Sir, we can't hear you.
Sir has lost the connection.
Sir, our screen freeze, madam. So I think network
internet
connection
issues. Screen is seen, but sir's video and audio.
Videos.
Maybe
Dr.
network
Kurian?
issues, sir, but might have got disconnected, I think so.
Call பண்ணி பார்க்கலாம்.
Dr. Kurian?
Back, ma'am.
What happened, Priya?
Sir, you're muted. Sir is back, madam. Sir is muted. Sir is back.
Okay, okay.
Sir, you're muted, sir.
And everything went off with that. Sorry about that.
So
Okay.
we lost
Just-
the connection when you told about the signs of uterine rupture, sir.
Yeah. There's nothing much you've missed out. Don't worry. Yeah. So can you see my screen?
Yes, sir.
Yes,
Yeah.
yes.
Just the last couple of slides only. So
No, the uterine rupture, the red color tabular column.
No problem. That's okay.
Yeah.
Yeah.
So I just go into the slide. So this was a paper we presented at Mumbai. One of our doctors presented and got a prize for it. And you can see them very happily sitting with Michael Robson and enjoying the meeting. But the important thing was we presented our trial of labor and they were very appreciative of it. And we got an award for that. But as I mentioned in the talk, if you prolong the duration of labor, you are in trouble. In short-statured patients who are below 150 centimeters in height, again, you have to carefully monitor them and go ahead with that. So, fortunately, none of our babies stand up and say this to us, that why did you take me out quickly through a cesarean section? So the final options for a patient are simple: repeat C-section or attempt vaginal birth. In Akegi has said, the hallmark of labor management in the 21st century should be individualized care for the laboring woman. The important word being individualized care and expectation of a successful, safe vaginal delivery with the ability to intervene with a cesarean if needed. So what is the plan of action I can leave you with? Option very simple. In a suitable setting, see the previous cesarean patient antenatally as soon as she comes. Use an algorithm. If okay, use the MFMU calculator. That will help you to sit and discuss the situation well with the patient and the family. And once you have discussed it, if they are willing, monitor the labor and proceed with that. If in doubt, throughout labor, always be prepared to deliver the patient. I think it's feasible. I think most of you can attempt it. I'll be happy to answer if there are any questions. And thank you for your participation. All the best for TOLAC. So the simple picture I want to leave you with, if your target is not possible, adjust it.
Priya, 1 minute, ma'am.
I finished.
1 minute.
Thank you.
Thank you, Dr. Kurian, for that excellent keynote address.
Oh,
all of you give an applause for him.
Thank you, madam.
Let him get the sound.
Sorry. Sorry, my power went off suddenly.
Thank you. He has very clearly discussed the indications for the VBAC and counseling for that from the start of the antenatal visit and the selection of the case, patient's desire and the support you should have, and the important thing, the partogram. If you do everything, the success rate will be 70%. He has shown with all statistics. So let us say in a non-recurrent indication, let us always counsel the patient for a VBAC in the institutions, also in the private setup, so that we can get a good success rate. And we have to learn from the failures, what he said, and the factors affecting the
screen freeze ஆயிடுச்சு.
Sir, only one question, sir. Could the cause for sudden rupture in your single patient be determined?
No, madam, you really can't find any cause for it.
Only
problem she had a long interval between pregnancies. So we're worried whether there was some sort of dehiscence earlier, and that sort of gave way at that time.
Yes,
that was
sir.
quite a horrible experience. Yes.
Do you put a continuous CTG for all, sir?
Yes,
Yeah,
excellent.
all our patients in labor are monitored continuously. We don't, all of them have CTGs. Yeah.
That is one reason why many are reluctant to go for TOLAC. Because you cannot find any reason, suddenly you will land up with that.
Yeah, definitely, madam. That is a problem. But at the same time, think of the 99 others who are going and delivering normally. That is the problem I'm just trying to say.
Dr. Kurian, that was an excellent keynote address.
Oh, thank you, madam.
Medical
Thank you, sir.
legal
It was very
issues is the only
excellent lecture with lots of take-home messages and very practical tips. And with your
disturbance on the connectivity.
Yeah. Hello.
I think you should
Kasturi, madam.
we should do more.
Yeah, definitely. I think there are, with your lecture, everybody is more inspired, and then we should do more and more.
If you need any help, we are there to support. Absolutely no doubt about that. Okay.
Yes, yes, yes,
Right.
yes.
Somebody has asked a question: forceps or ventose, which you prefer? Now, the important message is when you're using an instrument for delivery, use as if it was a previous cesarean. You don't have to do anything special because it is cesarean. So if the head is well down, you think the ventose is coming. I remember in early days, they would tell us don't use because patient has to strain more and all that. All that doesn't really hold good now. We would use the vacuum or the forceps as indicated for a normal pregnancy. Okay.
Thank you.
Thank you.
Thank you, sir. Thank you.
Thanks, madam.
Priya.
Yes, ma'am. So thank you, madam. Thank you, Kasturi, madam, and thank you, Anjalakshmi, madam, and thank you, Dr. Kurian, sir. It was such an excellent. We were mesmerized, and suddenly, only when we lost the connection, we just understood that we are in between a talk. So it was such a wonderful, listening to you, sir. So now I would request Madam Rupa, madam, to introduce Madam Sushila.
Good morning, everybody. Can you hear me?
Yes, madam. Yes,
Okay.
yes,
Good
madam.
morning, everyone, and thank you, Dr. Kurian, for that wonderful lecture. And to introduce Dr. Sushila, she's a consultant obstetrician and gynecologist at Lata Super Speciality Hospital, Vijayawada, and also in Samatha Multi Specialities in Mangalagiri. She is the current president of Vijayawada ObGyn Society, secretary of Menopause Society, member MTP committee, and lots to tell. We will not, I think we will call Sushila Pinnamaneni to start her deliberation on postpartum, peripartum cardiomyopathy. Peripartum cardiomyopathy is a very, very sort of ill understood situation which suddenly comes as a lightning in the last 1 month or maybe in the immediate postpartum period, which is little ill understood and quite fatal. So, but there are a lot of changes in the current thinking about etiology, investigations, and management. So, I now request doctor to start her deliberation. Over to you, madam.
Thank you, ma'am. Shall I share my screen?
Yes, ma'am. Please share your screen. Yes, ma'am. We can see your slides.
Sushila, madam, go to slideshow, madam.
Just near to the animation, you have a slideshow.
No, on top, Sushila.
Madam.
To animation, you have slideshow.
Yeah.
You start there.
Yeah, start from beginning. The first one, come down, madam. Leftmost corner from the beginning.
Yeah,
from the current.
Yeah, from beginning.
Thank you.
Yeah, thank you so much. Yeah. So thanks for the organizers for giving me the opportunity. So I'm going to talk on the peripartum cardiomyopathy. So in 2010, the Heart Failure Association of European Society of Cardiology Working Group has defined peripartum cardiomyopathy as an idiopathic cardiomyopathy presenting with heart failure secondary to left ventricular systolic dysfunction, either towards the end of the pregnancy or within the 5 months following the delivery. So this is basically a contractility issue or a pumping dysfunction. So, and there is no other cause to be found out for the heart failure. So the diagnostic criteria indicate that left ventricular ejection fraction is less than 45%, and there may or may not be any ventricular dilatation. So this is basically a pumping abnormality, and the outcomes are variable. There may be complete recovery or partial recovery with persistent myocardial dysfunction, or they may be having a heart failure or rapid deterioration and landing in death too. So this is a case which I have seen last 2 weeks back, 21-year-old Paravan living one, full-term delivery, which was uneventful. She was discharged in a stable condition and presented after 2 weeks on 14th postnatal day with complaints of exertional breathlessness, easy fatigability, and bilateral swelling of the feet. So she was febrile with tachycardia, tachypnea, BP was normal, and oxygen saturation at the room air was 82%. There was elevated JVP and also bilateral pedal edema. And there were rails also in the auscultation, and echo revealed gross LV dilatation, and the LVF was 25%. So she was seen by cardiologist. And so women presenting with heart failure due to left ventricular systolic dysfunction, we name it as peripartum cardiomyopathy, and it should be considered when no other cause is evident. So in this case, we named the patient having peripartum cardiomyopathy and hence treated in that format. So coming to the incidence, it is 1 in 1334 in India, and it was a South Indian study. And the rising trends are because of the increase in maternal age at pregnancy, and most of the peripartum cardiomyopathy patients are more than 30 years of age. And it is also due to the multifetal pregnancies due to the fertility techniques. About 7 to 14.5% of them, 7 to 14.5% of them land in peripartum cardiomyopathy. And the incidence is also on rise because we are recognizing the disease with the echocardiography, which is like routinely done in high-risk cases, but the true incidence is not still known. So the risk factors are the African ancestry, preeclampsia, hypertension, and 15% of the women have a family history of the cardiac disease in the first degree relative, either a peripartum cardiomyopathy or a dilated cardiomyopathy or a history of sudden death or arrhythmias. So even in case of long-term use of tocolytic therapy with beta-adrenergic agonists, the women can land in peripartum cardiomyopathy. Multiparity and cocaine abuse has also been attributed to the peripartum cardiomyopathy. The important part is it is not just a simple additive effect. The risk factors cause a synergetic effect. That is, presence of one risk factor increases the chance of peripartum cardiomyopathy by about 2-folds, and presence of 2 risk factors increases the chance of peripartum cardiomyopathy by 11-folds. So the etiology is not fully understood. So much of research has been done, but still they say it is only a multifactorial problem. Nutritional deficiencies, viral myocarditis, autoimmune processes have been studied, but they are not proved to be the mechanisms of peripartum cardiomyopathy. The important aspect is the hemodynamic stress of pregnancy, and vascular hormonal pathology have been attributed to the peripartum cardiomyopathy. The important thing what we should understand is the cardiovascular changes are the maximum at the second trimester. But if a patient comes with heart failure in second trimester, it is basically due to the pre-existing cardiac disease, but not due to peripartum cardiomyopathy. So peripartum cardiomyopathy is only in the late part of the pregnancy or after the delivery. And we all know that the prolactin has been named as one of the cause for the endovascular damage, and 16K DA prolactin fragment is vasculotoxic, pro-apoptotic, and causes vascular and myocardial dysfunction. So the genetics have also been one of the causes for the peripartum cardiomyopathy. Single nucleotide polymorphism near the PTHLH gene, which regulates a vascular hemostasis, and pathogenic variants in the genes that contribute to the dilated cardiomyopathy, STTN and BAG3, have been postulated to be the causes of peripartum cardiomyopathy. So regarding the diagnosis, timing and clinical presentation, majority of the women, they come after delivery in the first postpartum period, and we do get confused because it is an overlap of signs and symptoms of normal pregnancy with those of the heart failure. Hence, there is a frequent delay in diagnosis and the under recognition. So this causes increase in incidence of the preventable complications, and also the diagnosis, the outcomes are worse. So this has been given by the AP government on 9/4/2022, saying that all high-risk cases need to for which we need to do 2D echo in second and third trimester. This is to prevent cardiomyopathy, and also we need to document with history and the report. And the symptoms are dyspnea, edema, chest pain, cough, fatigue, dizziness, palpitations. Occasionally we may have the patients with hemoptysis in later stages, and also with the signs of the pulmonary thromboembolism. So these are the common symptoms which the most of our pregnant patients do report to us, but we should have a little bit of suspicion, and the high index of suspicion in us starts when there is hypoxia, tachypnea, hypo or hypotension, tachycardia, rales, systolic or diastolic murmur, or there is peripheral edema, elevated JVP, displaced apical impulse, cardiogenic shock, severe arrhythmias, thromboembolic complications. Hence, in all patients who come with dyspnea, we have to get an echo done, and in all patients who have peripheral edema, we need definitely to auscultate for any extra sounds or a diastolic or a systolic murmur, and take the blood pressure properly, see for the respiratory count, if possible for SpO2 too. So these are the signs and the symptoms which mimic the heart disease in a normal patient. We usually know many of the patients come with the peripheral edema, but we should definitely see for elevated JVP, and is there any reduced exercise tolerance. In case of dyspnea, as I said, echo has to be done. So in the diagnostic testing, echocardiography is the gold standard when we suspect it to be a case of postpartum cardiomyopathy. But in echo, other findings can also be seen in the later stages where there is a biatrial enlargement with mitral and tricuspid regurgitation. The important point is intracardiac thrombus may be there at the left apex. Hence, in the echo, we have to we should request our cardiologist to view it properly, because the pregnancy is a thrombotic event, and hence the thrombosis is common. So we need to inform the cardiologist that they need to see the LV apex, because the intracardiac thrombus is one of the indicators for a bad prognosis. Level of the brain natriuretic peptide and N-terminal pro-BNP are markedly elevated in postpartum peripartum cardiomyopathy, but it is only mildly elevated in preeclampsia, normal values in pregnancy. The ECG may show a normal pattern or an abnormal pattern, but if it is a normal pattern, it doesn't mean that there is no peripartum cardiomyopathy. Chest X-ray can show the signs of pulmonary venous congestion. If we are in a doubt with the echocardiography, maybe the cardiologist can ask for a cardiac magnetic resonance imaging for accurate ejection fraction and chamber measurements. And endomyocardial biopsy, which is very rare in peripartum cardiomyopathy, to be done, but may be asked in giant cell myocarditis. So we always should think about the differential diagnosis, because peripartum cardiomyopathy is a diagnosis of exclusion. And then we need to think about the valvular diseases and cardiomyopathies prior to the last trimester. That is, usually the cardiac valvular diseases are common, which present in the second trimester. And severe
Madam, we have 2 more minutes, madam.
Oh, severe preeclampsia can cause heart failure related to diastolic dysfunction. But one important point here is severe preeclampsia, we have a diastolic dysfunction, and PPMC, we have the systolic dysfunction. So this is the differential diagnosis where the main important thing is left ventricular ejection fraction is maintained both in preeclampsia, hypertrophic cardiomyopathy, and pulmonary embolism. So we must go for echocardiography. Regarding the management aims, we have to treat the heart failure, arrhythmia management, anti-thrombotic therapy, timing and mode of delivery, mechanical treatment, and bromocriptine. So relief of the symptoms in cardiac failure is good oxygenation, decreased activity, salt and fluid restriction, optimization of the preload, support with inotropic drugs or the vasopressor drugs, and beta blockers are the loop diuretics are the drugs of the choice. In case patient has hypertension, labetalol can be added, and in decompensated heart failure and hypertension, nitroglycerin is also the drug of the choice. If we cannot have relief with the other drugs, digoxin, which is the category C drug, can be added. So these are the drugs that are usually given during peripartum cardiomyopathy. Regarding anticoagulation, as we all know, pregnancy is a hypercoagulable state, and if LVEF is less than 30. Hello?
Sushila, madam?
Yeah. Are the slides changing?
Yeah, it's changing, Sushila.
Yeah. Madam, I'm audible, ma'am?
Yeah, you're
yes,
audible.
ma'am, yes.
Yeah. As pregnancy is a hypercoagulable state, and if the LVEF is less than 30 in some studies and 35 in other studies, we need to give anticoagulation. Low molecular weight heparin during pregnancy, warfarin and low molecular weight heparin both can be given in lactation, but the novel anticoagulant has not been studied yet. So bromocriptine is an experimental treatment, and it is said it is a weak recommendation for use of bromocriptine, and we should be very careful because it causes thrombosis. So whenever we give bromocriptine, we need to give anticoagulant. So the prognostic factors are like the initial one, what is the LVEF is important to predict the adverse effects, and additional adverse effects are dilatation of the LV, thrombus, right ventricular systolic dysfunction, obesity, African American ethnicity. In case of mainly what we see is the preeclampsia, and if in case if the biomarkers are elevated, or in case of fibrosis, we have a bad prognosis of the patient. So the recovery is usually 72% recover in 12 months, and the LVF reaches more than 50%. So the adverse outcome include the brain cardiopulmonary damage and thrombotic complications. The mortality is like 1 year, it is about 4 to 11%, 2 years about 16%, and above 5 years it is 7 to 20%. This means that peripartum cardiomyopathy is comparatively less mortality is there compared to other heart failures, that is hypertrophic cardiac failures and others. And labor and delivery, timing and mode of the delivery has to be discussed with the cardio-obstetric team, that is the obstetrician, cardiologist, anesthesiologist, nursing. And we need to stabilize the mother to avoid potential fetal complications of prematurity, and hemodynamic instability despite medical therapy should prompt early delivery. And stable patients are delivered vaginally. Laboring in sitting position would be ideal, and epidural anesthesia or the neurologist analgesia is best mode for cesarean delivery. And detailed pre-delivery plan should be charted out with the multidisciplinary team. Unstable patients may benefit from invasive hemodynamic optimization, that is LAAD or ICDs. And following delivery, removal of caval compression, we have to anticipate pulmonary edema and fluid overload. So we have to optimize the IV fluids and monitor for 48 hours.
Your closing comments, madam.
Two more slides. So the breastfeeding has to be continued, and there are no adverse effects with lactation, and contraception should be more effective method has to be given. Tubal ligation, vasectomy are the best options. We cannot give estrogen containing contraceptives. Progesterone containing contraceptives can be given, that is Mirena or the implant can be given, can be advised, but only thing is effective contraception has to be advised to them. So the duration of the treatment depends upon the LV function. In the subsequent pregnancy, we always have to discourage the patient if the LVEF is less than 45%. And that is, we have to explain that there is a 20% relapse, and severe deterioration is rare. So we, if the LVEF is more than 50%, we can at least counsel them and then continue the pregnancy. But if it is less than 50%, higher risk of relapse is there. So we need to inform. So this is regarding the clinical assessment. Echocardiography and BNP should be performed at regular intervals prior to conception, first, second trimesters, immediately before the delivery, and 1 month after the delivery, to assess the condition of the pregnant woman. So this is a nutshell of all my talk. That is, what is the definition? What are the management options? What do we need to do during pregnancy, after pregnancy, during the delivery, and outcomes? This is an important slide which is there in the Journal of American Cardiologists in 2020. So the conclusion is the diagnosis of peripartum cardiomyopathy should be considered in any patient or postpartum with the symptoms of heart failure, and echo is the gold standard, and the prompt treatment with medication and tailored for the pregnancy and lactation prevent the adverse effects, and acutely ill women should be managed by the specialized multidisciplinary team. And thank you so much for the opportunity. Thank you, Sampath Kumari ma'am.
Thank you, Dr. Sushila.
Thank you, Sushila ma'am.
Yeah, it was a very good deliberation. And postpartum cardiomyopathy is a diagnosis by exclusion. There are no concluding etiologies. Risk factors should be considered. And what we must remember is that it is not as dangerous as it used to be earlier because of the multidisciplinary approach. and the death rate is only around 25%. In fact, it used to be around 90% in the past, but now it's only about 25%. And doing an echocardiography in the antenatal period does not assure us that this woman does not go into peripartum cardiomyopathy. It cannot be predicted. It cannot be prevented. It can only be treated. It can only be treated. So thank you very much for your wonderful talk. And I thank the organizers for giving me this opportunity. Thank you very much.
Thank you, madam. Thank you. Thank you, chairpersons, and thank you, speakers. It was an excellent session. So we are coming to the end of the session 2, and we will be starting with the session 3. I would like to invite the chairpersons for the session 3. I would like to invite Dr. Nagaratna madam. Madam is a professor of ObGyn at SNMC, and she has been done her MBBS from Davangere and from PG from Mysore. And madam is a past president of Bagalkot OBG Society, and she's been the organizing secretary of Kasoga 2018. And
Bagalkot, not Bagalpur. Bagalkot.
Bagalkot. Sorry, madam.
Bagalpur is different.
Dr. Lalitambika madam. Madam is a former professor and HOD Government Medical College, Alappuzha. Madam is a president Alappuzha ObGyn Society, and she has been the president of Kerala Society of ObGyn. Welcome to you, madam, and over to the chairpersons. Okay. I would request Dr. Nagaratna madam to introduce Dr. Sanjay sir.
Sanjay Gupta sir is there, no? Sanjay sir?
Yeah, I'm very much there.
Yes, sir. Welcome, sir.
Thank you. First of all, I would like to thank Shankumari madam for giving this opportunity and all the organizers of this wonderful webinar. I would like to introduce Dr. Sanjay Gupta, MD, DGO, FICOG, LLB, and FRCOG. And he is a Ethics Committee ex-chair, FIGO, the International Federation. And he is a secretary to General World Justice Organization, has been awarded FRCOG by the Royal College. He is the president of FOXI 2010. He was the president of DIPSI 2013. He was the chairman to Technical Research Committee of the Indian Council of Medical Research, and he had authored 8 books, and he had written many chapters in about 40 books. He has more than 150 publications to his credential. He was ex-honorary professor, postgraduate teacher, obstetrics and gynecology, and he was the director of Gupta Hospital and Center for Research in Reproduction, and he is also the director of Green Array Genomic Research and Solutions. With this introduction, I would like to welcome Dr. Sanjay Gupta to start his lecture.
Thank you. Thank you, ma'am, for that, your kind words. Let me share my presentation. I hope you can see.
Yeah, we can see the slides, sir. Yes.
Slides. Okay. Thank you, Sampat Kumari, madam, for having me here for this talk. And right. So we're going to talk of gestosis, that as we know, hypertensive diseases of pregnancy, we prefer to call it a gestosis for various reasons, because we feel that that is the correct description of what's actually happening. It's not just hypertensive diseases anymore, but it's an inflammation of inflammatory condition in pregnancy, and that's why gestosis. So let's talk of today simple ways of screening, and that is by screening and scoring. And why it is important, because as you can see in this slide, we have a gigantic task with 26 million deliveries, and we know that 10.3%, according to our National Eclampsia Registry, are the patients of preeclampsia or gestosis. So we need to really consider this magnitude and mortality and morbidity, and so there can not be two opinions regarding early and universal screening for these conditions. Why do we want to screen? Because screening for preeclampsia will help us in careful surveillance during pregnancy, with maybe more frequent antenatal visits to detect complications early. We'll be able to use prophylactic measures such as
low dose aspirin and calcium and even proper exercise during pregnancy. We know as of at least now there is no treatment as such for preeclampsia. For screening and early prevention goes a long way in preventing complications. But is the screening possible? By now we know that there are hundreds of clinical as well as laboratory tests, right from rollover tests to people who have tried everything under the earth to find out what kind of predictive test we can have. But we still do not have a single definitive marker for diagnosing this. And that is why, rather than using a lot of complicated tests, for example, we know that Nicoraides group has predicted 81% of early onset preeclampsia by using many 5 different criteria during early pregnancy. But for our country, these tests are costly. They require expertise and not available everywhere all across the country. And that's why we need to find some simple solutions. What we know about preeclampsia is that prediction is better for early onset than late onset preeclampsia. Combination of risk factors and uterine artery PI increases the prediction. And if we have combination of all these 5 markers, yes, we can diagnose early onset preeclampsia by 81%, but still late onset preeclampsia remains the diagnosis only as much as 45%. So what is the present universal consensus? That universal screening is recommended, but there is no single effective screening test. None of the tests proposed till date to predict the at-risk population for preeclampsia qualify to be recommended for the general population screening. And that is why at World Organization Gestosis, we have come up with this Gestosis score. The Gestosis score mainly is dependent on the detailed clinical history as well as primary clinical assessment, which makes it easy to use anywhere, even at the primary health center. What it entails is that, what we did while we were creating this, that we went through all these available material, available task force criteria of United States, ACOG, NICE, Australian guidelines. And after a lot of deliberation and going to plenty of research, we identified the various risk factors and then created this particular score. Now, don't worry about, this score is available on Google Play Store for free. And you can diagnose it right in front of when the patient is there. You can diagnose, download it and use it even in your daily practice. So we have considered every single factor, as you can see: age, gravidity, short duration of paternity, the woman herself by bone as small for date, then MAP and chronic vascular diseases. And here, if this is there in the history, then the patient is given score of 1. But there are more high risk factors which are more significant, and for that we give a score of 2. That is maternal hypothyroidism, family history of preeclampsia, obesity more than BMI 35, then pre-gestational diabetes. These, the final 8 or 9, you will realize that are given score of 3 because there is a very high chance of having preeclampsia even if this single condition exists in the patient, for example, autoimmune disease and so on. Right. So how do we calculate this, gestosis score? It's very simple. That points, as I said, 1 to 3 are allotted as per the association of risk factor and development of preeclampsia. If the total is more than or equal to 3, the patient should be marked as high risk for preeclampsia. And the preventive measure in the form of low-dose aspirin has to be started along with calcium supplementation as early as possible till 48 hours prior to labor or induction. Right? So this is very simple. See, what we are claiming here is not that we will be able to, say 100% be able to predict or, Nicoraides score and all that. What we are saying is just by the history and simplest criteria available to everyone, even at the periphery, we can identify patients as at risk for preeclampsia, and we can start our prophylactic measures, more vigilance, and the low dose aspirin, and of course the calcium supplementation. Now you'll ask me, where did we get all these points? And that's why I'm going to explain in short where this is, all these risk factors and come from. And as you can see, I'm going to just show you just some representative papers and studies that we went through to decide the weightage of this score for every condition. So as you can see here, small for gestational age, there are multiple papers who say that risk of severe but not mild preeclampsia is enhanced by having been born small for gestational age. Prematurity as well as low birth weight does matter as we diagnose the case of preeclampsia. When it comes to anemia is, every single thing is important, especially in our country. Anemia is important as a risk factor because the greater severity of anemia during pregnancy, the greater the risk of preeclampsia. Severe anemia appears to be a risk factor for preeclampsia and eclampsia. So as I said, these are only representative studies. You will see many studies on each factor that we have considered and added to the risk gestosis risk score. So maternal age and preeclampsia, we already know very young age and older age matters. Obesity, the obesity below 35 and above 35 makes a lot of difference to the the score and the prediction of preeclampsia. Then gravidity, we know that nulliparity is a risk factor for development of preeclampsia. Not only that, but cohabitation. We know when the partner is changed with a new partner, there is added risk of developing preeclampsia. So then family history of preeclampsia. These studies have been done long back by Chelsea in 1980s and 90, where he declared that family history of preeclampsia is associated up to 115% increase in preeclampsia risk. So mind you, all these, if you try and take detailed history, yes, sometimes the patient may not be able to give all this history, but a few points in the history we can elicit from the patient and the relatives. And this again emphasizes that history taking is so important. And usually what happens in any large hospital, the history taking job is given to the junior most doctors without letting them know that their history taking is so very important, and that's why they should go through this, and that's why we should have this sheet of gestosis score next to them, so they are able to ask proper questions and take history. We know that ART, particularly IVF, is associated with hypertensive diseases or pregnancy, and not only that, especially in own donor pregnancy or embryo donor pregnancy, the chances definitely increase of risk of, and that every ART specialist has seen in the practice that these chances are so high that practically 70% of these patients end up with preeclampsia. Thyroid also we tend to neglect, but hypothyroidism is an important consideration for development of preeclampsia. Gestational fibrosis, of course, we all know that. This also is an inflammatory condition. So also gestosis is an inflammatory condition. So both go hand in hand, and there is plenty of evidence telling us that gestational diabetes is important. Multiple pregnancies, of course, because the placental volume is more, and that's why we get higher chances of preeclampsia risk in these patients. And autoimmune diseases are, of course, like SLE, are very well known, where again the chances of preeclampsia are extremely high in these patients, almost to the tune of again 70 to 75%. But mental health, this is something we also were a little surprised after going through the lot of literature. But mental health, mental stress, schizophrenia, bipolar disorders, all these matter, and they can also lead to increased risk of preeclampsia. Cardiovascular factors, of course, are important. A patient having originally chronic hypertension or cardiac stress will develop preeclampsia. So many factors are there, and all these factors can be, actually decided by our history only. And what we have done is, in gestosis score, we have quantified the risk of preeclampsia according to the individual clinical risk factors. And this is the difference. We are not taken just, one risk factor and one point for that, as many other guidelines do. Here we are giving weightage. As I said, in most other studies, every single factor is considered as equal, but which is not so, as we saw in this evidence. This makes a difference as far as preventive strategies are concerned, and the Gestosis score also helps in identifying clinical risk factors that serve as potential determinants of preeclampsia. We have done a comparative study. This is the first study that we did in our hospital itself, and we found that positive predictive value was as much as 52.48% in this patient. Of course, low positive predictive values are seen because of various risk factors, which depending on your population of the study. Then high false negativity could be because the score was applied at 12 weeks. If you applied early, but the beauty of this score is you can keep on doing it again and again. You can do it at 12 weeks, you can do it at 16 weeks, and you will be getting more of sensitivity and specificity. So what we have actually found that yes, this score does actually lead to little more false positivity. That means you tend to predict the preeclampsia in a higher number of patients. But does it really matter? No, because what you are going to do is you are going to only start the low dose aspirin, calcium supplementation, and more vigilance. So this is not going to do any harm to the patient, and that's why I think this is the simplest score that we can start using in our patients. And we have seen that false positive rate increases when we make the patient simple. When we started doing the GTM diagnosis with DIPSI test, we found that yes, little bit false positivity increases, but does it do really any harm to the patient? No, in fact it benefits the patient, and that's why it's important. So the actions that we have to take is increased surveillance, prophylaxis with low dose aspirin and calcium. So when these are the only actions we are going to take, we are definitely not going to do any harm. So what are the final thoughts on this? That having discussed all about biomarkers and prediction, it is obvious that we still face frustration in preventing and predicting preeclampsia. One reason for this is preeclampsia itself is a syndrome, not a disease. So the diagnostic criteria for preeclampsia, hypertension, and proteinuria are basically non-specific, and clinical and pathological differences between early onset preeclampsia and late onset preeclampsia suggest that these are two distinct formats of the disease. So we are always going to have the problems of predicting one or the other. And so the final slide, in fact, there are several subtypes of preeclampsia: mild and severe preeclampsia, early onset and late onset preeclampsia, preeclampsia with or without fetal growth restriction, and so on. So that is why we must not expect a single biomarker to predict all subtypes. Neither can single preventive method prevent all subtypes of preeclampsia. We need to keep on our research going and maybe collaborate universally to identify various subtleties of this complex. We now know that even genetics matters, and there are genetic predisposition in these cases, and that's why we see them in many families. We have identified candidate genes which can lead to preeclampsia in a particular patients. So till all this happens, let us keep prediction simple and doable by Gestosis score, which can be done by even nurse at the primary health center, which is going to make a lot of difference in reducing mortality and morbidity. So thank you very much for your kind listening, and I hope all of us start giving due importance to the history taking in antenatal period and follow this simple Gestosis score to avoid maternal mortality and morbidity. Thank you.
Sir. In our hospitals nowadays in Tamil Nadu, they are doing Sanjay sir. Yes, Nagaratna madam.
Yes, sir. Thank you, sir. With history taking becoming an obsolete this entity, nowadays people are not stressing much on history, and with pre-eclampsia and eclampsia becoming more common and with more mortality, we need to focus on predicting pre-eclampsia and eclampsia by using this score, and I think it will go a long way in giving a good outcome to the pregnancy. Thank you, sir. Thank you very much.
Thank you. Thank you.
Thank you, sir. Thank you for sticking on to the time. I did not need to go off.
Okay.
Sorry. Now I would request Dr. Lalita Mikkan Madam to invite Dr. Shakti. Madam? Dr. Lalita Madam?
Priya, you can do it.
You are on mute, ma'am.
Okay.
Yes, ma'am.
Very good morning, all of you. I'm happy to introduce Dr. Sati MS, Additional Professor, Department of ObGyn, Medical College, Kottayam. She is the State Professor Drugs Committee. She is Faculty of National Medical Council and Model Center for Academic Committee Chairperson.
Please unmute others. Okay. Yes, Madam Lalita, Madam.
She is Academic Committee Chairperson, Kerala Federation in 2018-21 and past Secretary of Kottayam ONG Society. Over to Dr. Sadi for your talk.
Thank you, Lilabia Madam, for the introducing me. In the beginning itself, let me thank the organizers of this mega event, especially Dr. Sampath Kumari and our KFOG President, Dr. Venugopal, for having me here among this esteemed faculty, facing this esteemed audience. Let me share the screen. Hope.
Yes, ma'am, your slides are visible.
Slideshow.
Yes, ma'am.
Thank you. So the topic assigned to me today is posterior reversible encephalopathy syndrome. The press it's not a very common disorder, but it can be dangerous. And if it is identified early and treated promptly, patients can have good outcome. In the next few minutes, I will be explaining what this press is and what leads down to press and the clinical features, various differential diagnoses, how to approach the diagnosis, and the treatment outline. So press syndrome is a clinical and imaging syndrome characterized by acute headache, visual impairment, seizures, and altered sensorium caused by reversible subcortical vasogenic brain edema. So it typically presents like this. 27-year-old primary gravida, 33 weeks of gestation, referred from private peripheral hospital as a case of eclampsia. She was admitted there in the morning for the control of hypertension, which was detected during the regular antenatal checkup on that day. She was having headache since previous night and came to OP for the same complaint and was put on tab labetalol 100 milligram. And in the labor room, while she was being cared, she threw fit and a loading dose of Maxil was given and referred. On admission here at my hospital, she was drowsy, pulse rate was 90 per minute, BP was 160-100 millimeters of mercury, respiratory rate 18, CBD, the Eurobag had a clear urine of around 200 ml, and obstetric examination showed uterus was relaxed 30 weeks, slightly less than the period of gestation, cephalic presentation, Lycos seems reduced, FH was good. Antihypertensives were high, Maxil was continued. The maintenance dose was continued as loading dose was already given, monitoring the respiratory rate, knee jerk, and urine output. But urine output reduced subsequently in the couple of hours. And in 2 hours, investigations came. All were almost normal, except for the altered RFT and the increased PC ratio of 3.3. Creatinine was 1.3. She continued to be drowsy without fully regaining of consciousness. The neuromedicine consultation was done and they advised MRI and it showed press. Emergency C-section was done and delivered a preterm male baby of weight 1.12 kg. She was given an injection levetiracetam and then was tapered over 4 days. Mother slowly recovered in 2 weeks and was off antihypertensives after 3 weeks. Baby was kept in NICU for around 2 weeks and given to mother. Both got discharged after 46 weeks of hospital stay. So this is a typical presentation of press syndrome. So this is the paper that described this entity for the first time. That is, this paper is published in NEGM by Judy Hinchey, and at that time the the terminology was reversible posterior encephalopathy syndrome. And he described 15 case reports that had PRES. The terminology at that time was posterior, reversible posterior leukoencephalopathy syndrome. Later, various terminologies: reversible posterior cerebral edema syndrome, reversible cerebral parietal encephalopathy. Now it is posterior reversible encephalopathy syndrome. All these terms you have noted, there are two terms, reversible and posterior. So it is it's a bit explanatory. This PRES, this condition is not exclusive to pregnancy. This can happen in other conditions as well. That is, pregnancy-related conditions associated with PRES are eclampsia and preeclampsia. General other conditions associated with PRES that can lead on to PRES are severe hypertensive crisis, sepsis, organ, bone marrow transplantation, renal failure, malignancy, radiation, encephalopathy. Then autoimmune disorders like rheumatoid arthritis, SLE, certain cytotoxic drugs, immune suppressive medications like tacrolimus, rituximab, then other drugs like lithium, IV immunoglobulin, and even lunasodate that we use. So all these can predispose to and develop PRES. Now the incidence of PRES in eclampsia, it's very difficult actually. It's not known properly because we are not imaging all cases of eclampsia or severe preeclampsia. So looking at the various studies, in a study published in 2011, Wagner et al. Stated that incidence is 100% in eclampsia. Other studies quoted a similar like 98%, 92%, but another study as low as that is 62.5% of incidence in eclampsia. So now let's see how this PRES is developing. It's a condition that develops in brain and the cerebral circulation. In cerebral circulation, cerebral blood flow is maintained constantly, even though there is any fluctuation in the blood pressure and perfusion pressure. This is maintained by the arteriolar vasoconstriction and dilatation, which in turn is under the control of autonomic nervous system and various mediators released by endotheliums. So in women having or patients having chronic hypertension, these arteriolar blood vessels having the muscle undergo hypertrophy and is a bit resistant to increase in hypertension, increase in blood pressure. But in young women, sudden increase in blood pressure that causes increased cerebral hyperperfusion. That causes this autoregulation overcome. That is, this this autonomic nervous system, the curve shifts to right and it becomes beyond the capacity of autoregulation. So there is hyperperfusion and this disrupts the blood-brain barrier. There is vascular leakage and leading on to vasogenic edema. So there are various theories and this is the most popular theory that I have searched out, this vasogenic theory. Now, why it is occurring in the posterior aspect, that is the posterior circulation, the vertebrobasilar system, the innervation by adrenergic nervous system is sparse compared to the anterior and middle circulation. So that is why this autoregulation disruption is more in the posterior aspect, and so that is why occipital and parietal lobes are more commonly affected in PRES. Another theory is vasospasm theory. In response to the hypertension, there is reflex vasospasm that causes hypoperfusion. Hypoperfusion releases and ischemia releases mediators causing endothelial dysfunction, vascular leakage, and edema. So that is. So this is the this is a picture that explains the theories I have just explained. That is hypoperfusion injury and leakage and toxin mediated endothelial injury and leakage. Now, how this PRES presents? In eclamptic women having PRES, the cardinal symptoms are headache, seizures, altered sensorium, and visual loss. Focal neurological deficits like cortical blindness, aphasia can also be, that's infrequent. Then, in eclamptic women having PRES, concomitant metabolic abnormalities like raised serum creatinine, liver enzymes abnormalities, platelet count, higher proteinuria, all these can be seen in eclamptic women developing PRES. Seizures are usually generalized tonic-clonic, self-limiting, last for maximum of 3 to 4 minutes, and usually a woman becomes responsive within 10 to 20 minutes. But prolonged post-ictal unresponsiveness, there you have to search for metabolic abnormalities and another thing called status epilepticus, non-convulsive type of status epilepticus. Then occipital lobe seizures will have visual aura and hallucinations. Headache, it's a most often heralding symptom. It is diffuse and dull aching, unlike the thunderclap headache that is seen in hemorrhage and also in this reversible cerebrovascular constriction syndrome. Then visual symptoms, decreased acuity. Various visual symptoms can be there. Cortical blindness can be total or partial due to damage on the visual cortex, but it will be normal on fundus examination, but it's usually reversible. Altered mental status, varying severity, mild confusion to deep coma, but prolonged unconsciousness, we have to rule out. That is non-convulsive type of status epilepticus or eclampticus and severe metabolic alterations. Then comparison of eclamptic press versus press due to other causes. In press associated with eclampsia and preeclampsia, more of headache and visual complaints when compared to other causes. And in eclamptic press, the subjects are younger with more thrombocytopenia and metabolic abnormalities and higher peak systolic and diastolic blood pressure. Now, how to arrive at a diagnosis? This slide is a bit of neurological point of view. That is how a neurologic diagnosis press. That is acute neurological symptom. If it is more than one neurological symptom with more than one risk factor with the characteristic brain imaging, then that points to press. In our case, in the case of eclampsia, preeclampsia, the diagnosis is a bit straightforward if you have got a CT image or MRI imaging. Then imaging, it's a characteristic finding in imaging. That is white matter signal changes localized in the parieto-occipital regions mainly, but also can involve frontal areas and brainstem, and it will be characteristically symmetric and usually spares the calcarine and paramedian parts of occipital lobe. MRI, we have CT, MRI, but MRI is the imaging modality of choice. T1 weighted images characteristic hypointense, isointense lesions, but it has got more sensitive is the flare sequences images with that shows hyperintense lesions in the occipital parietal lobes. So this is a CT finding, that is the hypodense lesions in the parietal and occipital lobe. This is the MRI flare images with the hyperintense lesion in the occipital and parietal lobe and a bit of frontal lobe also. Angiography, there is no need for, if you are suspecting like press itself, there is no need for an angiography because it's usually normal. But if there is other conditions, like if there is focal neurological deficits and all, we have to progress with angiography also. There is one condition called reversible cerebral vasoconstriction syndrome. Multifocal segmental constriction may be there, and also various other vascular lesions we will be able to pick up by angiography. Differential diagnosis. So when a patient presents like this with seizures and all, in spite, press syndrome in with eclampsia is one comes to our mind first, but we have to think of other conditions also. The primary headaches like migraine, infective causes, metabolic abnormalities, secondary headaches, numerous intracranial hemorrhage, cerebral venous thrombosis, space occupied lesions, etc. Now, treatment outline. Prompt recognition and early treatment, we can almost hope for complete reversal of all these problems. The treatment is mainly supportive, control of hypertension, treatment of seizures, correction of dehydration, correction of metabolic abnormalities, and prompt delivery. Supportive, that is, we have to transfer the lady to ICU, then multidisciplinary team has to be involved, some may need ventilation. Continuous blood pressure monitoring is needed, intake output chart, renal failure, even ladies with renal failure may need dialysis, and general care has to be ensured. Then how to control seizures? Magnesium sulfate is the drug of choice. The regimen,
sorry to interrupt, ma'am, 2 more minutes.
Sure. Then recurrent seizures, Maxil, we can repeat Maxil or give lorazepam. Other drugs like midazolam, diazepam, levetiracetam, phenytoin can be used, depending upon the other parameters. Then we have to control hypertension. Mean arterial pressure has to be maintained between 105 to 125. Then intravenous labetalol, hydravilicin, and epinephrine are the drugs of choice. Nitroglycerin avoided because it may worsen the edema. Prompt delivery is a must, mode determined by obstetric indication. Prognosis, good rate of recovery for early initiation of treatment, complete recovery in 70% of cases in 1 to 2 weeks. Visual impairment is the most common sequelae. Non-specific white matter lesions can be seen in neuroimaging. Poor outcome predictors are severe encephalopathy, uncontrolled hypertension, hyperglycemia, delay in treatment, multiple comorbidities, presence of hemorrhage, and corpus callosum involvement. So to sum up, PRES in pregnancy is a neurological condition associated with eclampsia. MRI confirms a diagnosis which is often but not exclusively belong to posterior subcortical structures. Early recognition and treatment carries better prognosis and prevention by good obstetric care, early detection of preeclampsia, like previous speaker Sanjay Gupta sir said, just scoring, and we can employ all methods to for prediction and prediction of preeclampsia, for prevention and early treatment, judicious prophylactic and therapeutic use of magnesium sulfate. And thank you very much for the patient hearing, and thank you for the opportunity.
Thank you, madam. So, thank you, Dr. Sadi, madam. That was an excellent lecture. Dr. Lalita Ambikar, madam, can you want to give a closing comment, madam?
Given what patients, we hand over the patient to neurologist. We as obstetricians primarily responsible for the patient should be knowing all these details about the PRES, and then only will be able to detect it early and give proper reference to a neurologist and manage accordingly. Thank you, Dr. Sadi, for such an elaborate and very explanatory comments on PRES syndrome.
Thank you, madam.
Thank you, madam. Thank you for the excellent lecture. Can we have the next series, please? It gives me great pleasure to introduce Dr. Narasimha Reddy, sir. Sir is the president of TZOG Society, and sir is a past president of Warangal ObGyn Society, and is a consultant at Warangal Hospital, Warangal. So over to you, sir.
Good afternoon. Can you hear me?
Yes, sir, I can hear you, sir. Can you share your screen?
Last week only he handed over that Telangana Society presidentship to Dr. Shantakumari.
Oh, okay, nice. No, that was not mentioned in the CV, madam. Sorry.
No problem, no problem. With him only I was coordinating for our program. Only Narasimha Reddy sir gave a green signal.
Oh, very nice. Thank you, sir. Are you sharing the screen, sir?
Yes, yes, madam. There is a problem.
Sahiti, can you help?
Yes, ma'am. Sir, can you please click on share screen option? Team color screen, share screen option.
Is there a problem, sir?
Yeah, it is loading. It is in the cloud because I have come to the conference in New Delhi.
Oh, okay. Very nice. Thank you for taking time in your busy schedule and joining our conference. So thank you. You want our team to load for you, like share for you or something? You can send it through WhatsApp or something.
So you can put it in the WhatsApp group. I will share you, sir, for myself or a platform person.
Yeah, I'll try, madam. Yeah, it is on my.
So, Sambat madam, is it okay? Can I just read out the questions in the chat group by the time?
Yes, yes, you can read only one, two.
Yeah, there is a question on gestosis. Okay. So,
can
sir,
you?
In your, we
no,
can't
sir,
see.
we are not able to see.
No,
You're
sir.
not seeing your screen.
Yeah, already Sanjay sir has answered for that, definitely.
Okay.
Can you see my screen, madam?
No, sir, no, sir. You open the present point PPT in your laptop and minimize it, sir. Then you go to the share screen and click.
Yeah, that I did it.
Or else you send in the WhatsApp, Priya will share for you.
There's a common group like A to Z group. So you can just put it in that and our team will pick it up for you.
There's something wrong with my cloud loading.
You have it in your mail, sir?
No. Can I close and I will...
Yes, sir.
Yes, sir. Yes. If it's difficult, you can even leave the meeting, open it there so that it like, you can prevent the Zoom also. Then join that. There is a question which is it cost effective to do echo in all antenatal patients for screening? So any of the seniors in the panel can just give their views.
Another?
Is it cost effective to do echo in all antenatal patients for screening?
In Tamil Nadu, in our state, it is made mandatory by the government itself. I don't think it will be a cost effective. We can do it. Others can tell the view.
Dr. Tapas Kumari, at what gestation? Hi. At
Yes,
what gestation do you do this routine?
20 weeks, 20 to 24 weeks.
You cannot. Routinely for everybody it is done.
Yes,
Yes.
everybody, even in government setup.
Government setup also it is done.
Dr. Bharti has logged in from Dubai.
Congratulations on this excellent session. It is spellbounding and so informative. I am enjoying every moment, Dr. Sampath. You have done an excellent job.
Thank you. So if Reddy sir is not joining, shall we go with afternoon session? Time is 1 o'clock. All of you
Yeah,
can
maybe
have
you
your lunch in your house.
Yes.
Yes.
It's a walking lunch. We are not going to break for lunch. So whoever feels like you can just switch off your video, have it on the, like during the session. We don't mind that.
I have a long time for lunch still. The time is just 11:30 here.
Yes, for you.
Okay, ma'am. So can I call the next chairpersons, madam, if that's okay?
Priya, Reddy sir, what happened? அது வந்து phone பண்ணி சொல்லிறியா? அதுக்கப்புறம்
Shri Priya, madam. Shri Priya, கேட்டீங்களா?
Yes, ma'am. Phone பண்றேன் ma'am. அவர் mail
அவ்வளவுதான் நினைக்கிறேன் டாக்கர். ஃப்ரீ டாக்கர்.
அந்த செஷன்ல அவரது மட்டும் தான் மேடம் இருக்காது. அடுத்த செஷன் சேர் வேணா இன்வைட் பண்ணிட்டு அவர்
சார் வந்துட்டாரு. சார் வந்துட்டாரு.
வந்துட்டாங்க. ஓகே, பெர்ஃபெக்ட். Do you do MRI before TOLAC? Another question.
Sir, Korean sir, but I don't think he's doing. We have to do it. I don't think so.
No, probably a good 3D scan and Doppler studies can assist the placental position and placental pathology.
Placenta, creta, per creta, we can do it. Yes. Not for all.
Yes, ma'am.
Can you see, madam?
Sharing.
Yes,
sir. We can see your slide. Yes.
Yeah, sorry for the inconvenience, madam.
No, sir, you can start.
No, sir, it's always worth the wait.
Good afternoon. Good afternoon, ladies and gentlemen.
Can we go for view slide? View slideshow.
And on the top, you have inserted designer animations next to animation slideshow.
Yeah.
You click that slideshow and from beginning.
From beginning.
On the left
on
side.
The left side. Yeah, that is also good enough. Yes.
Yeah.
Yes, that's all. Okay, sir.
Can you hear me clearly? Yeah. My job has been done by Professor Sanjay Gupta sir and Satya madam. I will be speaking on fetal growth restriction No more we are calling it as an intrauterine growth restriction. It is refers to a fetus that has failed to achieve its genetically determined growth potential. What is this growth potential? That has to be decided. Whether the individual baby's growth potential can be estimated or the community potential of the babies is estimated. This is a $1 million question. But on the whole, it affects 5 to 10% of the pregnancies. The definitions, it's the FEGR is estimated fetal weight less than 10th centile for that gestational is the standard definition. SGA, newborn birth weight less than 10th centile gestational age. But Society for Fetal Medicine, Maternal and Fetal Medicine FGR definition supports the ACOG definitions. That is, includes AC less than 10th centile for gestational age for FGR babies, and screening performance similar between the estimated fetal weight and AC. The term IGR should no longer be used. No more we are using symmetric and asymmetric IUGR for our clinical purposes. Classified mainly into early onset FGR, that is less than 32 weeks of gestational age, which is seen in more severe disease course and more likely to be associated with placental insufficiency, hypertensive disorders, genetic conditions, maternal hypertension, and Doppler abnormalities. Late onset is, of course, after 32 weeks of gestational age, accounts to major share, 70 to 80% of the cases. They are mild clinical course and without flow abnormalities. Whereas severe FGR, fetal weight less than 3rd centile, consistent more severe form of FGR. How do we going to work up? Detailed ultrasound comes first. Strong association with fetal anomalies and chromosomal disorders, 20% of them can be diagnosed with ultrasound. And detailed ultrasound in the form of doing biometry and Doppler studies. Genetics in the form of doing chromosomal microarrays. If the FGR is less than 32 weeks, and FGR and polyhydramnias and fetal malformations are associated with, regardless of the gestational age, one has to do genetic studies. As far as the first trimester screening for major pregnancy complications is concerned, as of all of us are doing aneuploidy screening in the first trimester, that is what we call it as a combined test. But first trimester part, and which can be done to predict the preeclampsia as well as the IUGR and the prematurity also by doing bilateral uterine artery, PI, and the biochemical markers which are used are the PAPA, free beta SCG, PLGF, and PP13. So when we are doing first trimester screening, we are supposed to do structural malformation study and preeclampsia estimation. And most of us are following the FMF algorithm. And I suggest all the gynecologists who are doing ultrasound on their own, and every gynecologist should have at least one ultrasound machine in their OPD room so that they can do and they can predict as early as possible all these cases. Screening for preeclampsia and IUGR. This is at the first trimester, 11 to 14 weeks is highly predictive, and for early PI and IUGR, detection rate is around 60 to 90%. False positive rate is only 10%. But as far as the screening for preeclampsia at first trimester is concerned, it is limited for late onset PE. It cannot detect because the detection rate of the late onset PE is only 20 to 60% with a false positive rate of 10%. Then viral workup. Of course, CMV testing is not recommended because it is not very common. The routine screening is not recommended, toxoplasmosis, rubella, and herpes and as far as FGR is concerned. Dating. The importance of dating, I need not have to emphasize. Whatever may be the correct date of gestational age or the patient knows about the LMP correctly, but routine first trimester ultrasound has to be done, and at that time it has to be calculated, the gestational age has to be calculated, and it has to be assigned. Suppose the estimated gestational age goes beyond 5 days, plus or minus 5 days by ultrasound, that has to be assigned irrespective of her LMP. As far as the pathogenesis is concerned, many of us know about that it is placental insufficiency. This is suboptimal remodeling of uterine spiral arteries, or otherwise we call it as placentation in early pregnancy. It is otherwise termed as maternal vascular malperfusion. This is MVM. This is the whole pathogenesis beyond the development of FGR. This vascular malformation, the antenatal detection of placental insufficiency, MVM, can be detected by using the Doppler ultrasound to measure the blood flow pattern both in maternal as well as the fetal arteries. This is what we are going to have in the next few slides. Fetal vascular malformation. Other well-described FGR-related placenta lesions include vascular malperfusion. Otherwise, we call it as a villitis of unknown etiology. The thrombosis or other lesions like a hypercoagulability with or without thrombosis could be the reason for this. These are the patients who may be benefited by aspirin and the low molecular weight heparin. Coming to the Doppler study of the body. Just I wanted to spend 1 minute over here. Here it is, as far as the uterine artery is concerned, either high resistance flow in the first trimester or non-pregnant uterus. But as far as the pregnancy advances, it goes into least resistance. So if the high resistance flow starts in the first trimester, that continues as the pregnancy advances. These are the patients who are prone to develop FGR. As far as the umbilical artery is concerned, it is a normal good diastolic flow. If the pregnancy is advances, the diastolic flow continues and the diastolic flow increases. That's the least resistance flow in the umbilical artery. Whereas in FGR, the diastolic flow goes down, or otherwise it will be found in the form of elevated PI, as shown in the diagram right side of the screen. Then coming to the middle cerebral artery, it is a brain sparing effect. Usually the middle cerebral arteries have the high resistance flow in the normal pregnancy. But whereas in a FGR, as the brain sparing effect is set in, there is a vasodilatation of the cerebral arteries, which will be seen in the form of rise of diastolic flow. Whereas in this case, there is a decrease in PI. It is almost reversal to the umbilical artery. As far as the venous system is concerned, it is a atrial contraction that will be seen in the form of a wave when we insonate the ductus venosus. If the waveform is shortened or decreased or it is reversed, will show that there is a compromise or the load in the right heart or the right atrium overload or right ventricular overload. So vessels which should be interrogated are uterine artery. When the uterine artery PI is more than 95th centile, the risk for stratification for development of P and IUGR is ascertained. Similarly, umbilical artery PI more than 95th centile, very early onset IUGR is suspected, as well as the absent end diastolic flow and reversal of end diastolic flow. Whereas the middle cerebral artery, as I said, it is in a reversal to the umbilical artery flow, because as it is in a preferential flow, it comes to less than 5th centile. Whereas in the uterine umbilical artery, it is more than 95th centile. So coming to the ratio, it is a peak systolic value velocity usually we will estimate in fetal anemias. Cerebroplacental ratio less than 5th centile, it is indicates that there is a fetal distribution of the oxygenation. So coming to the peak velocity for veins, which will be seen in cases of ductus venosus, where there is a reversal of A wave, but that indicates the fetal cardiac compromise. Coming to the Doppler measurements, normal measurements, UA Dopplers every 1 to 2 weeks. If you suspect that there is an UGR, if the normal uterine artery Dopplers, do uterine artery Dopplers every 1 to 2 weeks. Whenever you find the end diastolic flow abnormality, we have to do weekly Dopplers. Whereas absent end diastolic flow, you have to do it 2 to 3 times per week. And if the reversal of end diastolic flow has been observed, hospitalize, administer steroids, and perform NST twice a day. And all said and done, SMFM recommends against routine use of ductus venosus Dopplers and middle cerebral artery Dopplers or uterine return. It is a boon for us as a practicing gynecologist. We are very well versed insinuating the umbilical artery. You follow the umbilical artery is more than enough for the follow-up. Coming to the management. NST, weekly NST after viability. SFM addresses BPP in the statement and finds that the further studies are required to prove usefulness of biophysical profile. Biophysical profile is only if it is you are convenient, you can do it, but it's usefulness is questioned. Then coming to the therapeutic strategies. Why, how, why should we treat these patients? Because it is strategy is to supply endothelial nitric oxide supplementation. So which that influence the uteroplacenta vascular function through the endothelial nitric oxide pathway and vasodilatation. The drugs which supply the nitric oxide donors are the ones which should be used, which functions at the endothelial level. This is the pathway. I'm skipping this 2 slides. Prevention. Due to lack of evidence, SFM recommends against the use of the following prevention of drugs. No more we are using aspirin and low molecular weight heparin, except where you have the evidence of the hypercoagulability situations. As far as the treatment is concerned, it is Fetal Medicine Society recommends against the use of treatment of FGR, that is the sildenafil and activity restriction. No more we are using sildenafil and activity restriction. Coming to the, I wanted to say a few words about sildenafil, though I have said that it should not be used. Early evaluations of this sildenafil, early onset severe IUGR with risk of fetal demise appeared promising, especially in those patients who are on the borderline of 26 weeks or 27 weeks, somewhere around, whether you are in a dilemma to postpone for a week or so, or you wanted to give corticosteroids. Probably there is a role in giving sildenafil vaginally, 325 milligrams 3 times a day, may be a good option. But of course, the literature, majority of the literature is against it. Coming to the antioxidants. So the most used one is arginine. Arginine and nitrogen carbonyl glutamate.
Sorry to interrupt, sir. We have just, 2 more minutes for you to finish.
Yeah. Okay. Growth and improves the fetal growth and complicate the pregnancies. Then gene therapy. A promising and more radical approach is a vascular endothelial growth factor gene therapy, in which adenoviral encoding for the proteins such as VEGF are introduced through the maternal uterus. This is a new form of treating, but it is a promising one. But we have to it has to be injected into the femoral catheterization, and it has to be injected into the uterine artery. But the cost is very high. Once a FGR is diagnosed, what next? Once the viability is what next? For FGR delivery, that I would like to finish with by saying few words. Timing. With oligohydramnios, 34 weeks to 37 weeks, it has to be delivered. Normal uterine artery Doppler and fetal weight less than 3 to 10th centile. If the fetus is 38 to 39 weeks, should be delivered. If it is less than 3rd centile, severe FGR should be delivered at 37 weeks. Decreased uterine artery flow, PI is more than 95th centile at 36 weeks. But on all the cases of AEDV, absent end diastolic flow, 32-34 weeks. And if there is a reversal of end diastolic flow, it should be can be delivered before 32 weeks. And always take a decision on the individual risk approach. Mode of delivery, should be determined on a case by case basis. FGR and TM, when to give antepartum corticosteroids at below 33 weeks, 6 days. And if 34 weeks and 36 days in the late preterm, if risk is there, no previous corticosteroids were not administered. And when you are anticipating to deliver within 7 days. But as far as the corticosteroids is concerned, I prefer to use dexamethasone rather than the betamethasone. Dexamethasone can be given 6 milligrams, 12th hourly for two doses. Consider magnesium sulfate as a neuroprotective agent if you have decided to deliver before 32 weeks of death. Then future pregnancies, counsel as far as regarding the 20% recurrence risk is there, and a review history to identify modifiable factors and maternal diseases and in subsequent pregnancies. In future pregnancy, it may be reasonable to perform serial ultrasonography for growth assessment, although optimal surveillance regime has not been determined. Maternal
Sorry to interrupt, sir. Time up, sir. Can you give your closing comments, sir?
Thank you for patient hearing.
Chairpersons,
yeah. Yeah, shall we continue with the afternoon session? Hope all of them have their lunch back.
Yes, so we are not breaking for lunch. So, I mean, you're free to have your lunch during the sessions. So I would like to invite Dr. Kalpana. Can we have the CVs, please? Okay. So Dr. Kalpana is the secretary of MOGS and she's the founder secretary of MCOT, and she's been course director for doctoral fellowship, and she's been having modes of presentations in national and international journals, and she's been awarded with many awards as well. So she will be the next coordinator for the post-lunch session. Over to you, Dr. Kalpana.
Thank you, Priya.
Thank you, ma'am. Thank you. Thank you, Dr. Sambat ma'am, for the opportunity. Thank you, Dr. Andalakshi madam. And thank you for the whole team. It was a wonderful conference and a very good experience for me. Thank you, madam. Thank you. Thank you for the opportunity. Dr. Kalpana, are you there?
Yeah. Thank you, Priya, for the kind words. It's my pleasure to welcome you all for this wonderful All Southern Federation Congress A to Z in Obstetrics and Gynaecology. A great initiative by Sampath Kumari ma'am, who is the dynamic secretary of TNFOG and also vice president-elect FOGSY, to unite all the 5 federations and also 79 societies to organize such a wonderful webinar for the 2 days. And we started this program with the blessings of our chief guest, FOGSY President Shanta Kumari ma'am, and also guest of honor, Vice President FOGSY, Facey Louis, and also other guest of honor, Cynthia Alexander ma'am, Madhuri ma'am, Sarina Gilbas, who is president of Kerala Federation, and Ganga ma'am, president of Andra Federation of OG Societies, Kasturi ma'am, who is the president of Kasoga. This has been successful with almost 1,700 registration with the support of all the federations, starting from Telangana, Andhra, Kerala, Karnataka, and Tamil Nadu. Obviously, with very good national and international speakers. So moving on to the sessions, it's my pleasure to invite Madam doesn't know any introduction. She is the dynamic secretary of TNF4G and vice president-elect FOGSI. She is the chief and HOD of Muthukumaran Medical College Research Institute, Chennai. National correspondent editor Jogi 21 to 24, Senate member of MGR University 21 to 24, chairperson FOGSI Adolescent Committee 16 to 18, deputy director professor, retired professor from Madras Medical College, president board of studies Tamil Nadu MGR Medical University 15 to 90. Member Board of Studies, OG Meenakshi Medical University. Madam has received various awards from IMA, Durusha Award from FOGSI, Yaman Pandit Award, Mrs. Shailaja Pandit Award, Karmavir Chakra, 15 national awards from adolescent for her active adolescent activities. Welcome, ma'am. Our next chairperson is dynamic secretary of Kerala Federation, Dr. Venugopal, who is an ART consultant, ARMC IVF Fertility Center, Thrissur, Palakkad, and also Salem, secretary of Kerala Chapter IFS, convener of Andrology SIG IFS. Welcome, Dr. Venugopal.
Thank you.
Dr. Venugopal? Yes.
Yeah, thank you, madam. Thank you. And I didn't get a chance to congratulate Sampath Kumari, madam, and for this huge and wonderful effort to unite all our conferences.
With all support. Now we will start with the keynote address. First, we will have Dr. Prasanna Kumari CV. Venugopal sir, you introduce Dr. Hema Dibakar, and I will introduce Dr. Prasanna. CV of Dr. Prasanna Kumari. Dr. Prasanna Kumari is a senior consultant obstetrician and gynecologist, head of the department Adur Lifeline Hospital, senior consultant obstetrician and gynecologist, SU2 Hospital, Trivandrum, former professor of Trivandrum and Calicut Medical College, author of the book Postgraduate Gynecology, awarded WHO Fellowship in 91, past president of Kerala Federation. Welcome, Dr. Prasanna Kumari, madam, for the keynote address. Yes, madam.
Shall I?
Yes, you
at
can.
At the outset, I would like to thank Sampath Kumari for inviting me. It's a good opportunity to meet all of you. Thank you so much. Shall I share my screen?
Yes.
First, thank to Dr. Venugopal. He only suggested your name.
Thanks to.
Thank you. Yes, ma'am. Go to slideshow.
So, coming to teenage pregnancy, it is a real health problem across all nations and all societies. So, there are so many nutritional and health problems involved in when a teenage girl becomes pregnant. Let us go through what exactly it is. And what is teenage pregnancy? UNICEF defines teenage pregnancy as conception happening between the ages of 13 and 19. I have seen 12-year-old girl becoming pregnant. And she became pregnant even she attained menarche. I had to terminate it. She was evaluated for hyperemesis by neurologists, vomiting by neurologists. So teenage pregnancy in developed countries is usually outside marriage. And in developing countries, it may also be a result of early marriages. In developed countries, sex is allowed when a girl is 16 years of age. So she can become pregnant. And coming to the world statistics, according to the WHO statistics, about 16 million girls aged between 15 and 19 years and 2 million girls under the age of 15 years give birth every year. So that is the magnitude of the problem. 1 in 5 girls may give birth at the age of 15 years. And most of the incidence is noted in the low socioeconomic countries. And teenage sexual activity, in the international perspective, the teenage sexual activity and associated outcomes are affected by a combination of so many factors, biological as well as cultural. There will be spread of sexually transmitted diseases, unsafe motherhood and the accompanied problems, and abortion have become a challenging factors. In England, the teenage pregnancy has been reduced drastically, about 51% because of the programs, the national programs. It was set up by the National Department of Government to address soaring rates of pregnancy in England. In England, as everybody knows, sex is allowed after the age of 16 years, so that there is chance that she can become pregnant. And it has been reduced by the strategy adopted by the government. And according to WHO, it's a very good program which had such a good success. And these are the components of the strategies in the program. By the use of data for monitoring progress, support teenage pregnant women and preventing subsequent pregnancies, and constant message and service publicity to young people and parents, and advice and access to contraception. And this has been given much importance in the UK. Access to contraception, so that primary prevention, training on relationship and sexual health, support for parents to discuss relationship risk, and targeted prevention of young people at risk. What about the Indian scenario? In India also, teenage pregnancy is reducing, but not much. It is still high. It has been reduced from 7.9%, according to the National Family Health Survey, to only 6.8%. It's still high. What are the circumstances in which adolescent pregnancy occurs?
Please others unmute. Yes, madam.
It could be sex within marriage or sex outside marriage, resulting in intended pregnancy. Sex within marriage in India, several states encourage sex within marriage and marriage before maturity, before maybe some 16 or 14, and then the pregnancy becomes an intended pregnancy when she is not actually mature enough to bear a child. Or it could be a consensual sex outside recognized union. Then the pregnancy is an unintended one, in which case there will not be any antenatal care. What are the risk factors involved in the adolescent pregnancy? Of course, social deprivation, and these pregnancies occur among the lower socioeconomic group, and poor education, apart from socioeconomic status, is a factor which promotes adolescent pregnancy. And these children are born to teenage parents. That's also another factor. And social service, not being under social service care, and it could be sexual abuse. Again, all these are contribute to sexual abuse. Poor education, low socioeconomic group, social deprivation, all these contribute to sexual abuse also. And there will be mental health problems. They'll be involved in crime, and they'll be using illicit drugs and smoking, etc. And their curiosity for experimentation and peer pressure. The peer group may be involved in sex. and family-related problems. Then it may be a broken family where the parents will not be in good relation, and those type of families will have this type of children. And lack of information. That is why giving information about sex is very, very important. And the influence of liberal views on sex. What are the obstetric risks involved when a teenage becomes pregnant? They are more prone for preterm delivery, small SGA babies, IUTR, and they have the higher risk of molar pregnancy and pregnancy-induced hypertension. They may be anemic because of the nutritional deficiency of the adolescent. They may have food fads. They may not take the adequate food because they want to become lean and beautiful, or they will not take adequate fruits and vegetables. And their children are at increased risk of morbidity, and they have more postnatal depression. And because of the sex relations, they can be sexually transmitted infections. In labor, they can be prolonged labor, obstructed labor, birth injuries, PPH, puerperal sepsis, and increased maternal mortality has been reported among adolescent pregnant girls. Coming to how to reduce, there are so many factors which we have to give importance. Starting from the policymakers to the provider, to the community, the facility, the family, and the woman. So the policymakers should think of policies like what is done in UK to reduce this, and the providers should be sincere in providing all these facilities to this group, and the community also should be very friendly to them, and the facility also, they should use the facilities available, and in which case education is important, awareness about the facilities is important, especially family planning facilities, contraception, and then only it will reach the girl child. Teenage mothers require supportive care because the social deprivation they are facing, and teenage pregnancy, it's an occasion. It is an occasion to teach the teenage girl the good health habits about nutrition, and of course, along with that, proper antenatal care. And if she comes early, it's an unwanted pregnancy, of course, contraceptive advice. It's a boon that India has the law, that the law amendments, that the age of marriage should be stepped up to 21 years. That's promoting girls for education, and education as well as mental and physical development, and that will reduce the incidence of teen weddings. It has been reduced by law. Of course, after delivery, effective postnatal care counseling, particularly regarding contraception, can help prevent future pregnancies. Once you just landed up in a pregnancy, there's an occasion to teach her. And especially when it comes to teaching an adolescent, investing in an adolescent girl is like teaching the entire world, because the adolescent is the one who is going to become the wife, the mother, the grandmother, who has an influence, who has the maximum influence in a house. And when the house becomes healthy, the world becomes healthy. Coming to the offspring of teenage pregnancy, it has been reported that the offspring born to teenage mothers, they are poor in cognitive development, and they are reported to have lower educational achievement, and they have behavioral problems during childhood, and higher risk of abuse and neglect, and more frequent criminal activity. Their children become criminals later on. So how to prevent it? The primary prevention, of course, is of educating the girl, learning support for those who are struggling academically, so that she will not drop out from school, and relationship skills development, parental involvement. See, all the schools, school education is very, very important. And parents should also be taught. And work experience opportunities, volunteering and work and out of school activities. And we should support for those experiencing family breakdown and conflicts. This should be sorted out in the community and also in the schools. I know that Dr. Sampath Kumari is putting a lot of effort in teaching the adolescent and the adolescent health, and thank you so much.
Yes, ma'am.
Primary prevention, of course, is sex education, and this is from a serial about sex education where when the students ask for sex education, the teacher is not willing to give them sex education. Actually, it should be taught in schools, and what is the genital organs, and what is sex, and what is proper sex. Actually, we cannot prevent them from involving in sex, but they should practice proper sex. We cannot now prevent it completely. And of course, many countries, even in Kerala, we find that premarital sex is becoming more common. So they should definitely know what is contraceptive. So contraceptive advice should be involved, should be given in schools. It should be included in the school curriculum. And for them, I think that long-acting reversible contraceptives are better. And they have good success rates, and it can be implants, not the intrauterine devices. Injectables. I've been to Bangkok on a WHO fellowship where MTP is not legalized, and all of you know that sex is practiced. Nowadays it's different, but there are so many sex workers there, and they prevent pregnancy. They don't do MDP. It's not legalized, and they prevent pregnancy by this injectable reversible contraceptives, which is very commonly used and supplied by the non-medical, medical people, not doctors, but what about secondary prevention? Because they should know how it can be, pregnancy can be terminated. And for that, knowledge is important. They should be taught about MDP services. And because the lack of awareness and accessibility to health service, they don't go for medical termination. They will go for, they go to quacks and end up in septic abortion, even though it's much less nowadays. And they should be provided privacy and confidentiality, and they should be properly counseled. And when they approach us, we have to terminate the pregnancy. Unsafe abortion should be prevented, and the knowledge should be, awareness and accessibility to health services is the confounding factor. And termination options should be available to pregnant teenage girls, and they should be handled delicately, confidentially, and the proper advice should be given, and we have to comply to their request. So that is again giving importance to providing information and education in schools, and promote individual responsibility and protective norms, and they should be taught how to protect themselves. And the society as well as the government also should be involved in all these matters, and provide health service and products, provide contraceptives. And there are so many national programs in India for the adolescent. These are the national programs by which you reach the girls, even though they don't attend the medical care hospitals. There are so many programs by which you can reach the girls. There will be monetary benefits to the girls, and also counseling and education assistance. And of course, parents should be educated, and youth development and empowerment is very important. Secondary prevention meant for sexually active teenagers through use of contraceptives. And preventing a safety net making emergency contraceptive pills are widely available. And it may be an accidental pregnancy, in which case we can go for an emergency contraceptive. And we have to provide, as I already emphasized, safe abortion services. And give her post-abortion care and advise her about contraceptives. And break the silence against sexual coercion and fight it vigorously. Empower them to protect themselves and ask for and get help when needed. And that is why after the Delhi incident, there are so many measures to call for help. To conclude, teenage pregnancies are at a potential risk of serious physical, psychological, and social consequences. And proper counseling, sex education, very, very important, and supportive measures. And identifying risks can reduce the burden. And society, and especially gynecologists, and adolescents is a group which can go to pediatrician or a gynecologist. Sometimes, and some of them will not go either to a pediatrician or the gynecologist. Even if they don't come to the gynecologist, there should be means to, there should be a program to reach them in the periphery, in their house. So that we can reduce teenage pregnancy and its associated health problems. Thank you so much.
Thank you, Madam. Prasanna Kumari, Madam, you have covered everything. As you told, the adolescent counseling, school counseling is very, very important. It can be done by doctors, social workers, and everyone. And for this, again, Madam was telling about the abortion care. Now we have the respectful abortion care. So when you also follow the abortions, you have to be keep it in mind about the POCSO Act and MTP Act 2021. Following all the acts, and you can do the abortions. And the teenage pregnancy complications, Madam has told very well. Fantastic talk, Madam. Thank you.
Thank you so much for your excellent talk related to complications of teenage pregnancy and how to avoid that contraception to avoid teenage pregnancy. Thank you, Sampath ma'am. Now I request Venugopal sir, who is the secretary of Kerala Federation of ObGyn Society, to invite Hema Divaka ma'am, who is the dynamic past president and also vice chair of FIGO NCD committee. Over to you, Venugopal sir.
Thank you very much. Good afternoon to all of you.
Hema madam is there, no?
Yeah.
Yes, very much.
Yes, madam.
Good afternoon, and as a practicing obstetrician gynecologist, it's my big privilege to introduce Hema Divakar madam to this audience. Madam doesn't require much of introduction, but I'll complete the formality. Madam is the medical director of Divakar Specialty Hospital, senior consultant obstetrics and gynecology with over 3 decades of experience in women's healthcare in India. An opinion leader, past president FOXY 2013, vice chair of FOXY PNCD committee to 2015 till date, ambassador of the International Organization of Obstetrics at FIGO 2016 to 18, technical advisory group member for Ministry of Health and Family Welfare of the Government of India. Madam is an ardent advocate for delivering equality healthcare and
Madam has many.
Yeah, madam.
Yes, awards and recognition.
Yes, she has been recognized in different fora. FIGO Women Achievers Awards 2015, Global Asian of the Year 2018, Excellence in Women's Healthcare, Ministry of Health, Maternal Health, CME Excellence Award for Artist, Next Brands for Artist for Her, CSR Times Award, CSR Impact Award for Divakar Service Trust, and most importantly, very respected and loved by all obstetricians and gynecologists, and a role model for many of us. Over to you, madam.
Yes, Fen.
We would love to hear your Tamil words also, ma'am.
So that is Venakkam, Namaskaram Andi, Ellarigu Namaskara. This is simply South, simply superb, and as I can see, simply Sampath Kumari. Because innovative ideas everybody can give, but to actually bring it into reality is really a very, very challenging task. And thank you so much, everyone involved in this. because she's humble enough to give the credit to everybody else. I know that, but I'm sure that the team has put in tremendous amount of efforts, and we've really enjoyed the deliberation in the A to Z of ObGyn. So I start with the congratulations. Just before the session, Sampath Kumari announced, no, we are not breaking for lunch. Everybody can have lunch in their own house, do whatever you want, etc. So then my topic is think nutrition first. Think about eating only. That means it says. So it has come at the appropriate time of the peri-lunch hour, like how we say perimenopausal. These hybrid conferences has given us another array of new terminologies saying around lunchtime. So this is the right time to think that good maternal nutrition is the best start in life. So my deliberation today for the next 25 minutes or so is going to be on the window of opportunity that we have for 1,000 days. So the WHO has defined the first 1,000 days as the 280 days in pregnancy and then the next 2 years of life of infants. Total put together, they have collaged it to the first 1,000 days, to which the nutritional aspect has to be paid the utmost importance. Ricket Coleman, the makers of Dettol, who did the major campaign of Swachh Bharat, are now on to a Swasthya Bharat campaign, and they did a zero tolerance to infant deaths in the district of Amravati in Maharashtra. And dear friends, to know, just focusing on good nutrition to the mother and the first 2 years of infants, they have indeed achieved a remarkable milestone of the zero complications due to the nutritional burden. So, which means that if we actually implicate these in practice, it'll go a long, long way in setting the healthy generation next. So an opportunity for action is right here in thinking nutrition first. Why the first 1,000 days? Because the child's future, in fact, the nation's future is determined by the quality of nutrition in the first 1,000 days. Don't miss the bus. Optimal nutrition is very, very critical for cognitive and physical development at this stage, and targeting this period. See, we have hundreds and thousands of problems, and of course we have a good human resource, but everybody cannot dilute themselves on doing everything. So the key investment in the first 1,000 days is the time and efforts well spent, because this is one of the best investments to improve the health, nutrition, and economic outcomes at large. So what are the maternal changes and the key nutrients that are required to get these changes into order is what is shown on this rather busy slide. In the first trimester, the hormonal levels change, the metabolic rate changes, the oxygen demand increases, the blood volume differences are there, and nutrition demands also increase. And we have to ensure that iodine, folic acid, vitamin B12 is in place in this. So whenever adolescent care is emphasized, again, the thyroid deficiency, because though the iodine man of India, Chandrakant Panda, even today he is disappointed that the iodized salt is still not used by 30% of the people in the country. The fortification is done. It's a simple thing to do, but still so many have iodine deficiency and hypothyroid. It's a easily correctable issue. So attention should be paid utmost to it, all of these things in the first trimester. Second trimester, there are changes in the cardiac output and the insulin sensitivity. Slowly and steadily it creeps on, and the carotene, folic acid, iron, omega-3, everything comes into the picture. The last part of it, where the calcium absorption, plasma volume, the sleep patterns, etc. Again, the calcium, the carotene, choline, iodine, iron, omega-3, vitamin D, all of these play a very, very important role. And not only this, for the mother during pregnancy, but the first 1,000 days also includes the 2 years of postpartum period of the mother, where all of these nutrients have to be optimal. The breastfeeding support, peripartum psychosis, the risk of depression, the changes of the hormone which have to normalize, the increased demand in calories, etc. So all the way through. And what about the baby? The central nervous system, the major developmental defects can occur in the first few months in the womb, and the major functional and structural differences can occur. For example, we are now trying to influence the government to change the policy of Anemia Mukta Bharat, because till now our thinking was that if she doesn't build a hemoglobin by the time she delivers, this patient may lose blood and die. But now the concept has changed to she must improve her hemoglobin by mid-pregnancy. Why? Because after that, there is a peak transfer of iron to the fetus and the neural development of the fetus. If you miss the bus there, it is irreversible. You cannot get back to the gain that you would have got by optimizing the iron transfer by 22, 24, 26, maximum 28 weeks. So we are slowly shifting that instead of waiting as late as third trimester, please make sure that the women is anemia free by mid-trimester itself. So the synaptogenesis and the refinement during the early development phase, all of these, there is a wonderful opportunity if you optimize the nutrition inclusive of the iron and all the other simple things that we said. So on the cover of the Time magazine, how the first 9 months shape the rest of your life. The programming, the in utero programming, which we focus so much, malnutrition and other adverse environmental exposures during the development will alter the gene expression and program the baby. Actually, the Abhimanyu effect, the horoscope of the child, the health horoscope is written when it's in the mother's womb. Okay, the adverse exposures also result in the slow growth and the small body size. The epigenetic modifications of the fetal gene expression, the placental gene expression, and the fetal development is entirely dependent on the nutritional programming. And therefore, let's all get sensitized and remember that maternal diet is one of the main players in this context, as the macro and the micronutrients are direct regulators of DNA stability and phenotypic adoption, and they do influence the availability of methyl donors and mechanisms promoting the DNA stability. These are molecular mechanisms, but look at how simple it is to offer, think nutrition first, take a dietary recall of what she is doing. Many simple advices can be given, not necessarily by the higher end practitioner, but by anybody in the team of the frontline healthcare providers. What is the Asian scenario? Where we are triple burden. One is underweight, one is overweight, and one is micronutrient deficiency. Everything possible is existence in abundance in countries which are still developing. So 1 in 5 underweight, short-statured, anemic. Needless to say that we've been talking about it for many, many years. It's time to walk the talk. And prevalence of overweight, certainly 37% increase is very, very alarming. Frequently, the malnourished women will have poor pregnancy outcome. Large proportion of the reproductive years is in the multiparity. The pregnancy, the lactation, again they're getting pregnant or lactating. This vicious cycle is going on and on and on, which we need to influence the sex education, contraception, as Madam just spoke about it now. The frequencies of pregnancies followed by lactation really increase the health risk. What can the first 1,000 days care do? It's a make or break time, because by making sure that you use this opportunity to build the nutritional component of the mother and baby complex, then 40% reduction in stunted growth, 50% reduction in anemia, 30% reduction in low birth weight babies, and you ensure the exclusive breastfeeding for 6 months, and lo and behold, the healthcare scenario is going to change. Where are we figuring? Just look at us. Amidst the developing countries, India really ranks highest, and the number game, if you play, many millions of Indians, the stunting is prevalent. The stunting on one side, too short, underweight, anemic, the percentage keeps increasing, height, weight, bone mass, and the mental development also is greatly influenced. And unless you start looking into these things early, the PCO, which is the new era buzzword, as you may call it, the obesity, which is 10 times more in the adolescents in the present era compared to the previous. So adolescent time, again, dedicated to few of the champions in Foxy who are doing a phenomenal work around this area, is the right time to catch them and see to it that they improve. The health risks of being overweight and obese, needless to say, that every other major system is affected, and long-term healthcare really goes for a very adverse situation. And also we emphasize that let us not presume that we as a country are not in the bracket to face this tsunami of obesity. It's coming, not in slow motion, but rather in a fast track. So we need to act upon this. So the action point where we have said preconception, pregnancy stage, at childbirth, first 2 years, spilling over to the adolescence. So essentially the first 1,000 days are really crucial for us to act. Pre-pregnancy, during pregnancy, and postpartum. Again, a busy slide. I will send this slide on the group as well, because it is very important to stick this slide somewhere where it's visible to everybody, and so that even the frontline can very easily see and follow this. What is needed in pregnancy, what is needed in adolescent, what the neonate needs first, what do we need to do? Delayed cord clamping, early establishment of breastfeeding, vitamin K administration, then nutritional support and advice, and the kangaroo care if the baby is tiny. Simple, doable things. And I'm sure that all our Manyata champions have seen a world of difference with just a delayed cord clamping and initiation of breastfeeding within 1 hour. Goes miles to avoid many of the adversity. Again, the central colored strips which I have put, which explains the gist of what is written, in many lines, because the policymakers always have long documents, but the essence is from iron folic acid alone, we should change to MMS, that is multiple micronutrient supplementation. That's what is the recommendation by WHO in the recent past. Delayed cord clamping, so easily doable. Please sensitize every frontline healthcare providers, everybody in the staff who is delivering babies, to please initiate this simple step. Think breastfeeding first and initiate it within the first 1 hour, because we have no reason to claim the statistics that 40% do not initiate in the first 1 hour. Maybe because of myths, misconception, nobody is telling them, whatever. But it is so easy to do it. Again, another busy slide, which will be important to put it as a chart, because not only reduced morbidity and mortality in childhood by just taking care of the nutritional components, but also improved cognitive motor behavior and the socio-emotional development, then the benefits during the life course, including school performance and learning capacity, and the adult stature, obesity and NCDs, which will definitely decrease, improved work capacity and productivity. All this is happening due to what? Because you have paid attention to the first 1,000 days. And isn't that delightful, fruits that you can bear with just some simple initiatives that you can take? Well, with the FIGO Pregnancy and NCD Committee, where I was the vice chair, we recognize that there is a global obesity pandemic, and the FIGO Pregnancy and Obesity Nutrition Initiative, called the PONI, put out a lot of recommendation for pre-pregnancy, pregnancy, and post-pregnancy period on nutrition alone. At the moment, I'm the chair of the Well Women Healthcare of FIGO, and we are toying with the idea of bringing out some infographics, some short 1-minute videos in variety of languages, just to create the buzz in the social platform, because it is so simple for everybody to understand. Just because we don't have the time to tell, or we don't have the inclination or the conviction to tell, we are not telling, and that's crying shame. So the FIGO PONI group has the vision that nutrition and weight at the front line of pregnancy care for women globally. Think nutrition and weight first at every contact, developing guidelines, practice resources, advocating for this on every platform, and training the staff towards this. Because as I have said, the numbers translate into millions. Undernutrition causing 3.5 million deaths of women and children. overnutrition producing non-communicable diseases such as diabetes, hypertension, micronutrient deficiencies affecting 2 billion people worldwide because of inadequate diet and lack of vitamins. So the scenario in our country becomes more complex. But if you look at the government website on the Poshan Abhiyan, which the government has started, believe me, it is so delightful to go through that, because every region, now you go to Andhra Pradesh, Telangana, there'll be one type of cuisine, Tamil Nadu another type, Karnataka another, within Karnataka, the North and South Karnataka something else, and also the Kerala, which is a much loud cuisine, is totally something different. So you have a mix of patients from all across the country, and it may be difficult for you to guide them as to the food groups, what they should be eating. And so the simplest way of executing this is to execute the use of FIGO nutrition checklist for every woman before and during early pregnancy. Because the FIGO nutrition checklist is very, very simple. Height, weight, BMI being measured, and the dietary recall being taken, and recognition that maternal obesity leads to gestational diabetes, preeclampsia, etc. What do you do in the pre-pregnancy state? All women should have their height and weight measured, not difficult to do. Women above 30 should be advised about the effects of obesity on fertility and get them on to a lifestyle change to encourage them to lose weight. Start the folic acid. Now there is a recommendation that extra dose of folic acid is needed for obese women, and the energy needs during pregnancy are 10% higher. And we have said again and again that it all starts in utero. So you need to focus even well before pregnancy. The mother and infant group, just look at the y-axis of the risk of NCD. If you act at the right time, you will really have the blooming of NCDs, as I call it, over their life course at the very minimum. You've not missed the bus. You can still catch them at childhood and adolescence. But if you go well on to the adulthood, not even advise them then, late intervention or no intervention, zoop, the y-axis and NCD goes really, really rocketing high. And so you please do your best when the opportunity is available. The pregnancy-induced complications are already at hand. Non-communicable diseases, don't think it's out of sight, out of mind. It all starts in utero. And whether it's low birth weight or a macrosomic baby, they are at elevated risk for obesity, cardiovascular risks, and diabetes. It's an intergenerational transfer. If you haven't done well for this pregnant mother, you've lost your opportunity to build the solution for a life course approach. So the same thing is reflected on this slide here also, the Barker's and the Pedersen's hypothesis and the NCD related pregnancy complications. We are really, really trying very hard to get the Ministry of Maternal Health and Family Welfare to shake hands with the NCD ministry so that there is a continuum of care, but it has not yet happened. What does it mean for us? The mothers in many, many areas in our country are not empowered to make nutritional changes because it involves finances. The male partners are disinterested in what really she is telling now, her changed vision of the nutrition, etc. So the whole family has to be taken into confidence. The male maternal nutrition intervention should involve the male partners so that the finances, the implementation of buying those kind of food substances. We are also telling the community health workers, but what we need to do is to tell the government in the public food distribution system. We're saying less carbohydrate, but they're supplying plenty of rice. So it doesn't work out that way. So we need to guide them in a more specific, precise manner. The FIGO recommendation, pre-pregnancy, I told you about folic acid and weight. In pregnancy, again, the weight, obesity, lifestyle comes into picture, and the clinical management pathways should be meticulously followed because all of these complications to a large extent can be prevented by tuning their nutrition alone. Not to miss them in the postpartum period, because if you promote exclusive breastfeeding for a pregnancy with diabetes, for example, it also helps her lose weight. And the weight gain in pregnancy, we must be very, very serious and strict with them to help them shed their weight so that long-term follow-up as needed is done annually. And those who are hypertensive, those who are diabetic, those who are obese will definitely benefit if you continue to intervene and see to it that they reach the optimal weight post-pregnancy and also the low-carb, high-protein diet. So the call to action is in pushing the caregivers and the women themselves to the awareness of the risks and awareness of the opportunities to modulate these risks. Post-pregnancy counseling as important as the pre-pregnancy, annual follow-up, and discuss with each woman their nutritional history with your obstetric history in all checkups. This is a snapshot of the FIGO nutrition checklist, which is available on the FIGO website. It has 4 sections. The first section identifies special diet, which is not much. It just says whether you're vegan or non-vegetarian or vegetarian, so that some questions become irrelevant to vegetarians. The second section has only calculation of body mass index, so it's simple to do, height, weight, and measure. The third thing says about different food groups, whether it is meat or chicken, fruit or vegetables, fish, dairy products, whole grain carbohydrates, or packet snacks, pastries, etc. How much is the portion size? How often in a week do they eat them? And the last of it is, are they being supplied by folic acid, vitamin D, and iron? That's all. And we have done a study on this. Very simple to execute. Maybe it takes 5 to 7 minutes, but at least both the patient and the caregiver are aware. Oh, she's not taking any of these. So we have to guide her to enhance that particular food stuff. In fact, this is the chart given by the government, which says actions for maternal nutrition services during the antenatal care OPD. And poor things, they have given so much of this pictorial charts which nobody is using. So now the nutrition and mental health also they have added, but again, we are failing in building the capacity of healthcare workers to do these simple things as a part of a routine standard antenatal care. Now, the steps for the future would be to sensitize everybody that this is important, develop a toolkit or the FIGO checklist modified to the Indian context, train the healthcare providers, execute it, evaluate it, and expand the use of this pan-India to see what difference it has made before or after the use. This is the age of app. So there's an app or many apps, the healthier, many people, but they don't stick on to it for a long time. That's an issue. This is the Zuri app, which comes with a weighing scale and the measure tape. And there are many, advices there, the recipes and the calorie content and the waist hip ratio and the measures. It becomes very interesting for the community of the app users to get on to all these things in a very interesting way. And objectively, they keep on seeing what is the difference that it has made. It's not at all boring, and they get very enthused to reach the targets. And you can see in the picture here that right from their young age, they are into the app era. So this is a good thing for us to encash. And also there is data about menstrual history, bleeding, pain, mood swings, etc. So the connect to the doctors also is by virtual mode, and the dietitians are also in the contact with the patients. So many things which can be guided in a remote way. So the key messages on the disease burden due to nutritional conditions: iron and calcium deficiencies contribute substantially to maternal deaths, low birth weight babies, accustomed to household environment, the development of the child itself becomes deficient, maternal overweight and obesity, not only associated with mortality, morbidity, but also preterm birth and growth restrictions is the other side of the spectrum, inclusive of stunting and slow mental development. So there are, the numbers are mind-boggling. The summary, therefore, of the first 1,000 days of life, dear friends, are nutritional deficiencies are common and widespread in developing countries. Needless to emphasize that. The perinatal period constitutes a very critical time for nutrition effect on gene expression. The programming is done there, so don't miss the bus. There is a growing evidence that supports the understanding of proper nutritional status before, during, and after pregnancy is really the key in maintaining the maternal and offspring lifelong health. In addition to inadequate fetal weight gain, maternal micronutrient deficiencies are also associated with adverse pregnancy outcomes, not only for the short term, but also for a long term, as a long-term complications of NCDs in their life.
So adequate maternal nutrition, really essential for a healthy fetus growth and the pregnancy outcome. Neurological development, extremely rapid during the first 1,000 days. So we must pay attention to that. So 1,000 miles to go before we touch our targets on the first 1,000 days. So I do hope that this humble submission, that it is doable, it is feasible, it is simple, it is just our attitude, our will, and the mindset to execute this, just as how all the state bodies have been brought together in execution of this brilliant getting together and working together. So let's make the South the forerunner of the pillar of laying the foundation of healthy generation next. Namaskar, and thank you very much for this opportunity.
Yes, Venugopal.
Your remarks as a chairperson.
Thank you, madam. That was excellent. And I think the prevention aspect of it highlighted so much that I think a lot of take-home messages would have been taken by the audience. Thank you very much. And as always, superb.
Thank you. Thank you.
Only whatever topic given to make it interesting, only Hemo madam can do it. Thank you, ma'am.
Thank you.
Thank you, Hema ma'am, for wonderful keynote address and giving importance about the nutrition in first 1,000 days. And it is our responsibility to intervene at the earliest to avoid complication. Thank you so much for the wonderful keynote address. Thank you, ma'am. Now moving on to the next session.
Chairperson is called for.
Priya. It's my pleasure to invite Dr. Archana Ambujam, who is a fertility consultant, Omega Fertility Center, Tuticorin, Secretary, Tuticorin OG Society, EC member of TNF OG, member of various organizations, and conducted various conferences. Welcome, Dr. Archana. Dr. Banu Sri Lakshmi, who is a medical superintendent, past medical superintendent in Bodan, senior OG consultant in Bodan, present working as a FOGSI president, Nizamabad branch, trained in OG ultrasound and high-risk pregnancy. Welcome, ma'am. Our next chairperson is Dr. Shanti Rani ma'am, who is a professor HOD, Teni Medical College, president TOGS, founder treasurer of TOGS, organized various conferences, workshops, South Zone coordinator, medical disorder in pregnancy committee FOGSI, and she has received various awards: Best Women Award, Best Doctor Award from IMA, Best Service Provider for PPI UCD. Welcome, ma'am. Our next chairperson is Dr. Aarti, who is the secretary of Virudhunagar OG Society, and she's been meritorious during her MD examination and member of various organizations. Welcome, Dr. Aarti. Over to you, chairpersons. You can invite Chinmayi Radha ma'am, who is the chairperson of Perinatology Committee. Dr. Archana.
Yes, ma'am. The first talk for this session will be by Dr. Chinmayi Radha. Madam will be talking about ultrasound in early twins. I welcome you, madam. Madam is the director and lead consultant, Fetal Medicine Resolution Fetal Medicine Center at Hyderabad. And she is a Fetal Medicine Foundation approved trainer in India. She is an examiner for MRCOG examinations. And she also runs iron Donald ultrasound courses. And presently, she is the treasurer of OGSH and member representative of AICC RCOG. And she's a winner of many awards. And I take it a pleasure to invite you, ma'am, for your talk.
Thank you. Thank you so much, Dr. Archana. And it's an honor to be part of this wonderful program. Thank you, Sampath Kumari ma'am, for conceiving something called A to Z of obstetrics and gynecology. I mean, that's very ambitious, and it's been really wonderful listening to everyone, especially Hema ma'am. And she said, it all starts in utero. So I'm so happy because, I've spent all my life now in utero. So the topic I have is early ultrasound in twin pregnancy. And as we all know, twins and all the higher order multiple births are just rising in incidence for various reasons, which we will not remember now. But then the fact is we need to scan twins so often. And ultrasound has become the magic eye with a very, very crucial role in managing these pregnancies. So when you tell me early twins, what is it that we exactly want? So this is a common clinical scenario. At 12 weeks, a woman comes to scan, and then you see that there are 2 fetuses. Whereas at 6 weeks, when she had gone for a scan, she was reported as a single live fetus. And how many of you can say that you've not come across such a scenario? I mean, if you say that you've never come across such a scenario, either you're not seeing any patients or you're not telling the truth. Because it does happen. As an early pregnancy scan, whenever we do early pregnancy scan, we have to exclude twins. See, so when we look at one fetal heart, we get very happy, and we see the fetal heart, we measure the CRL and we send it off. So that is where we must remember that our job is not complete in an early pregnancy ultrasound until we establish the viability of one fetus and establish that there are nothing else either in utero or ex utero, because even heterotopic pregnancies is a possibility. So it is important in early pregnancy scan to exclude twins. And therefore, it becomes imperative that if you cannot exclude that twin, you have diagnosed the twin. So the role of early pregnancy scan itself can be diagnostic in twin pregnancy. Now, of course, there are 2 babies. So wherever there was supposed to be 1, there's more, and there's always this problem of too many now. So what do? You told me early pregnancy, but I just want to go to 19 weeks to tell you why early pregnancy is important. When you say A to Z, sometimes it's important to go to T and see back that why A is important. So 19 weeks gestation, this is a mother with 1 baby having twin pregnancy, and one of them has a very, very lethal anomaly, which is otherwise going to have a poor postnatal prognosis. And you're thinking now of reduction. How will you do this reduction? You have a major CNS anomaly in one pregnancy. This may be a 19-week scenario. This may be a 12-week scenario. How will you do a reduction? You know that you want to do a reduction, but you don't know how exactly you will do it, because there are 2 possibilities. If you want to do a reduction and the pregnancy has a communication between the twins, then there will be a different method. If it does not have a communication, then there will be a different method. So what do you need here? You need information on the chorionicity. So in fetal medicine discussions or in advanced obstetric and gynecology discussions nowadays, you should not be discussing only twins. When you say twins, it has to be characterized as either monochorionic or dichorionic. So unless chorionicity is defined, the term twins in a report is unscientific. So when you know that you've defined chorionicity, you know there are 2 different placenta for 2 different babies, then you know they don't have any in between connections, and you can use pharmacological methods for reduction that will not affect the other baby. But if it is a monochorionic pregnancy, then you have to use a non-pharmacological method. So anything that you do in pregnancy in care of twin pregnancies depends on the chorionicity. Chorionicity is the single most important prognostic factor of twin pregnancies. So the most important thing after detecting twin pregnancies is to establish chorionicity in twins, and that should be done in the early scans. Chorionicity is important because chorionicity is used as a surrogate marker for zygosity. When we have 2 fetuses, we don't know whether they originated from the same zygote or for different zygotes. So you use chorionicity as a surrogate marker for zygosity, which is not completely accurate, because if you have 2 babies which have 2 different placenta, they could also be monozygotic that has split in the first 3 days. If you have monozygotic pregnancy which splits after 3 days, then you have monochorionic pregnancies. So when the when the fetuses have only 1 placenta between them, you know they are definitely monozygotic. But if they have 2 placentas, it may be dizygotic or it may be monozygotic with early splitting. Now, zygosity we cannot make out unless we do a genetic test, but chorionicity we can. And the good news is that it doesn't matter what zygosity is. For all functional problems of the babies, it is the chorionicity which is the important prognostic factor. So very important to realize in early pregnancy how many placenta are there for every twin. So if you see the twin peak sign, which is the twin peak sign, which is the lambda sign, as you can see here, then you know that this is a dichorionic pregnancy, and it is best seen between 9 to 14 weeks and may disappear thereafter. So we do not want to wait too long to miss this sign. And hence in early scans, you must establish this sign. If you see it, it is twin peak, and you know that there are two placenta. There's a little bit of intrusion of the placental material in between the membranes, which gives that lambda kind of feeling. And this is definitely an unequivocal sign of lambda. If you see it in early pregnancy, save a picture in the notes so that for future there will be no confusion. DCDA with early twin demise of one baby. So here you see there is lambda sign. There are two sacs. One baby is nicely growing to 11, 12 weeks. The other one is a small fetal pole. But you need not worry here, because you know whatever must have happened in that sac is unlikely to affect this one, because it has a completely different circulation and everything else. The connection is not there directly between these two fetuses. But if you do not see the lambda sign and you trace the insertion of the membranes through and through the placenta, and you never see the lambda sign, then what does this look like? We are in a session of A to Z, and I said sometimes you need to go to the T. So you see the T here. So this T point tells you that this is a monochorionic placenta. It is a monochorionic diamniotic pregnancy where you have a T sign instead of the lambda sign. So when you see the T sign, you know that this is monochorionic. So lambda sign and T sign. Please get used to these two signs, because in early pregnancy for twins, this is the most important sign that you can assure and make the pregnancy safer for these twins, because you will do adequate monitoring thereafter. Monochorionic pregnancies have the same placenta and there is different cord attachment, and therefore there may be differential area allocation. There may be different circulatory assessments. We have a session on twin-to-twin transfusion. You will learn about all these complications later on. But whether it is monochorionic, whether it is dichorionic, as an obstetrician, you need to establish this as soon as you see a baby. So this is a very early pregnancy, 9-week scan, and you can see that now I know clearly this is a monochorionic pregnancy. I don't see lambda sign. I see the babies are close by and they're only separated by their gestational sacs. Wherever you see an early pregnancy scan, dating is very important, because whenever we talk about fetal growth restriction, we say dates are important. How do you date two babies who have different CRLs? So if you have two pregnancies, babies inside with different crown rump length, how do you actually date the whole pregnancy? Because you can't give twin 1 6 weeks, twin 2 7 weeks and confuse everybody, because the pregnancy has to be delivered on the same date. You can't have a different EDD for two babies. That is what happens in radiology. They give EDD for twin 1 is 27 September and EDD for twin 2 is 4th October. So what do you do between 27 September and 4th October? So that is why you have to have only one EDD. And the CRL of the larger twin is used for dating the pregnancy. There are research papers which say that average may be used at some point, but it is still not established. The guidelines as they stand today say we should be using the CRL of the larger twin to be dating the pregnancy. So in this condition, the EDD would be 27 September, not 4th October. You ignore the 4th of October. You follow the centiles as per 27 September. Then comes aneuploidy screening. Again, chorionicity is important. Aneuploidy screening can be done later, but in twins, it is better to do it in the early stages, because later you don't have many methods. We know that the biochemistry doesn't work very well in multiple pregnancies. Only in first trimester it may work, but if you want to do aneuploidy screening, you assume that monochorionic pregnancies will have the same risk for both the twins, and dichorionic pregnancies will have different risk for both the babies, because we are assuming that monochorionics are monozygotics and dichorionics are dizygotics. But then that is why you treat them as dizygotic for screening. But when it comes to diagnosis, suppose there is a high risk, you check both the babies, because you cannot rule out the possibility that there was an early splitting of a monozygotic. pregnancy. So what do you do here? Each fetus has its own chromosomal composition, and you need to allocate risk to each fetus. So again, monochorionic or dichorionic, you need to know. And once you know that, you do the first trimester scan, just like you do for singletons. But you use the nuchal translucency in a special way in twins. So if you have a monochorionic diamniotic pregnancy with discordant NT, that is one NT is 1.8 and the other NT is 4.2. How do you allocate? Now this is monochorionic. Monochorionics are monozygotic. So how can you allocate two different risks to these two babies? Because they have originated from the same zygote. So here what you do is you take a average of the two NTs, take it as 3 and allocate the risk based on 3 NT for both of them. So both the fetuses have a common risk in monochorionic pregnancies. Whereas if it is a dichorionic pregnancy and the same type of discordance exists in the NT, you can allocate different risks to different babies. The one with the normal NT will have low risk, the one with the increased NT will have high risk. So DCDA twins have individual risks, MCDA twins have the same risk for aneuploidy. Because in DC and monochorionic, we take the average, and in polychorionic, we use individual NTs. Biochemistry, we don't use in second trimester, so that I'm not covering today. Systematic labeling of twins is very important, and that also has to be done in early pregnancy, because in later pregnancy, it's very difficult to, look at the relationship of the placenta to the cervix, to the fundus. The cord insertions are not that clearly seen as the pregnancy advances. So when you see early twins, just see how they are arranged inside. Which one is closer to the cervix? Where is the cord attached? Where is the placenta? So placental position, membrane direction, proximity to fundus, all these can be used to describe twins, so that you know which one is twin 1 and which one is twin 2. Because suppose they develop differential growth or they develop some other problems, every time you will know that you are comparing the growth of twin 1 with twin 1 in the next setting. Because pregnancies, as they grow, the orientation may change. So you have a systematic labeling so that you don't get confused between these babies. So whether 1, 2, or 3 babies, labeling in early pregnancy is very, very important. And this is how your reports will be: twin 1, anterior high, lower cord insertion; twin 2, anterior placenta fundal fetus with higher cord insertion, so that every time you are comparing the same baby with the same baby. And sometimes you don't see the intertwin membrane. When you don't see an intertwin membrane, you know that this is a monochorionic, monoamniotic pregnancy. That is a higher grade of monochorionicity, where they don't even have an intertwin membrane. So there is a risk of cord entanglement, and you have to explain these things to the parents. Sometimes you may have one baby seen there, the other sac does not develop a baby, it develops molar changes like this, and that is also important, seen very well in early pregnancy. And therefore in early scans you may see a twin coexisting with a molar sac, and that requires special arrangements for monitoring, and that will be done. In dichorionic diamniotic twins, you sometimes may see a particular placenta which is very, very low lying and shows signs of early morbid adherence there. So this will again change the pathway of management. It's difficult to go through the entire concepts of how we can manage this, because there is a session on management as well. But the early scans for twins should include even the early picturization of the placenta, its location and its relationship to the cervix, any signs of morbid adherence, because many of these women who develop multiple pregnancies are women who've had problems which are otherwise risk factors for morbid adherence. So whenever we have such situations, we do image as much as possible and establish the risk factor. And sometimes you may even consider doing a reduction in case you think of a morbid adherence of the lower twin, just to reduce the morbidity of the entire pregnancy, because sometimes these are atypical cases, but you may face them. Some of the early pregnancies may show one baby which is completely normal and the other one which looks like an IUD to the untrained eye, and then you see on subsequent scans that the IUD is also growing. That is how we get a lot of referrals where they say that the other baby is not viable, madam, but it is still growing. So that is actually not a complete baby, but a twin reversed arterial perfusion sequence where you see an acardiac mass, and this is also detectable if you have done a good early pregnancy pregnancy scan in twins. So you can have one normal baby and one amorphous mass. So defining the structure as much as possible in early pregnancy is also possible. And by any chance, if you need to do a reduction in a twin pregnancy, then chorionicity is very important. The only indications which are justified for reduction in twin pregnancies are when there is a justified anomaly in one of the fetuses. Otherwise, elective reduction in twin pregnancies is not really recommended, and very rarely we have to do them for maternal request. Suppose somebody already has a child and then comes and says that I can't. And the other indication we should sometimes think about is if the mother has heart disease or some other problem like epilepsy or something where you feel that it may be more dangerous for her to carry a twin pregnancy as compared to a singleton pregnancy. So all this will depend on the chorionicity, and therefore that is very, very important. I think in summary, all you need to do in an early pregnancy scan for twin pregnancies, number one, diagnose that they are twins, not miss twins in early pregnancy. When you see one fetus, look for the other one. How many fetuses you are seeing, number of fetuses, location, viability, chorionicity, chorionicity, chorionicity. That has to be the most important thing in any twin pregnancy scan. Amnionicity, if you can locate it in early pregnancy, and placental issues, and look for some of those unique complications that I showed you. So do your best until you know better, and when you know better, do better. Thank you very much for a very patient here.
Thank you, madam. It was an excellent talk, and you've clearly explained all that has to be looked for in ultrasound in the first trimester. And you definitely highlighted about chorionicity and how to identify it on ultrasound and its importance. Thank you very much, madam.
Thank you, Chinmay madam, for the excellent talk and elaborate lecture on twins. It has been appreciated by our delegates also in the chat box. Thank you so much, ma'am. Moving on to the next topic, management of twins. I request Banu Sri Lakshmi ma'am. Do we have Banu Sri Lakshmi ma'am?
Rajeshwari.
Dr. Aarti, you can invite Rajeshwari.
Fantastic talk.
Shanti, are you there?
Hello. Hello.
Okay.
Madam, audible?
Yes, yes.
Rajeshwari, no one has introduced.
Madam, you can put the CV of Rajeshwari, madam. I can introduce her.
Yes.
Thank you, Kalpana, madam, for this nice introduction of mine. And thank you, Sambat, madam, for the opportunity. And the topic is management of twins. The speaker, Dr. Rajeshwari, madam, is the senior assistant professor in OG, Thuthukudi Medical College Hospital, Thuthukudi. And she did her undergraduation in Tirunelveli Medical College. She did her post-graduation in Coimbatore Medical College. She is an UG PG teacher and service in Tamil Nadu government for 16 years. Current treasurer of Thuthukudi ObGyn Society 2022. Had publications in index journals, and her field of interest is high risk confidence. Over to you, madam, for your topic, management of twins.
Thank you, madam, for this opportunity. And ma'am, can you see the slide?
Yes, Dr. Rajeshwari.
Madam. Thank you, ma'am. Today's topic is twin pregnancy management. And we all know multiple pregnancy occurs when more than one fetus simultaneously develop in the uterus. Although rare, development of 3 fetus, 4, 5, 6 may also occur. So commonest variety of multiple pregnancy is twin pregnancy, and it is of 2 types, dizygotic and monozygotic. And the commonest one is dizygotic. It results from fertilization of 2 ovum leading to fraternal twin, and monozygotic results from fertilization of 1 ovum. Dizygotic twins are mostly dichorionic, diamniotic, and they are non-identical. The placenta may be separate or fused. Monozygotic twins are monochorionic diamniotic in 70% of cases and dichorionic diamniotic in 30% of cases. And the risk of twin pregnancy complication always varies with zygosity and chorionicity. So determining chorionicity is more important for twin pregnancy outcome. In monochorionic diamniotic twin, the risk of fetal complications are high, but in monochorionic monoamniotic twin, there is very high risk of perinatal loss and more commonly before 28 weeks. So diagnosis of twin pregnancy, most of the twin mother gives history of either using ovulation inducing drugs or there may be a history of twinning in the family. And all the pregnancy symptoms will be exaggerated in twin pregnancy. Like there will be increased nausea and vomiting. Patient may present with shortness of breath and palpitation. And there will be pressure symptoms like leg swelling, varicose veins and hemorrhoids. And over distension of uterus and increased fetal movements may also be noticed. On general examination, anemia is more common in twin pregnancy, obesity may occur, and there will be exaggerated signs of preeclampsia, that is fluid overload signs may be there. On abdominal examination, height of the uterus will be more than the period of amenorrhea, and multiple fetal parts will be palpable. At least 3 poles of the fetus should be palpable, and 2 fetal heart sounds at 2 different spots located by 2 different persons should be there. So the prenatal care management goals is close observation of mother and fetus to prevent, predict, and treat complications. All twin pregnant mothers need frequent antenatal visits, and 2 weekly visits are needed in monochorionic twin. And we should monitor the signs and symptoms of preterm delivery, and we should screen for unique fetal complications. And in monochorionic twin, 2 to 3 weekly scans should be done from 16 weeks of amenorrhea. And for dichorionic twin, it is advisable to do ultrasound 4th weekly from once in 4 weeks from 20 weeks of gestation. And the goal is preterm delivery should be prevented, early identification of growth restriction should be done, and the fetal trauma during delivery should be avoided, and expert neonatal care should be available. Management of dichorionic diamniotic twin, more or less a singleton pregnancy. And from the booking visit, patient should visit obstetrician once in 4 weeks till 28 weeks and once in 2 weeks till 36 weeks, and then up to delivery weekly once visit is advised. For monochorionic diamniotic twin, she should visit obstetrician once in 4 weeks till 16 weeks, and from 16 weeks she should visit obstetrician once in 2 weeks, and till delivery weekly once. In monochorionic monoamniotic twin, from 16 weeks, once in 2 weeks she should visit, and some patient may need inpatient management and close fetal surveillance from 28 weeks of gestation. And diagnosis is by ultrasound. Dating scan is must in all pregnancies, and it should be ideally done in 7 to 10 weeks of pregnancy. And apart from measuring crown rump length, determination of chorionicity should be done because management varies based on the chorionicity. And the first trimester chorionicity assessment is high accurate. And NT scan should be done on 10 to 13 weeks of pregnancy because there is increased risk of aneuploidy. And TTTS, that is twin transmission syndrome, is mostly identified during early weeks or during NT scan. And anomaly scan is advised from 18 to 22 weeks of pregnancy. But in ultrasound, fetuses in twin pregnancy should be assigned nomenclature, that is upper twin or lower twin or left or right twin. And it should be clearly documented in the woman's case notes. Chorionicity should be assessed in first trimester because monochorionic twin pregnancy requires close fetal surveillance. And monochorionic twin shows T sign in ultrasound. That is, as madam told, there is thin intertwin membrane which is attached to the placental mass in a perpendicular plane. In dichorionic twin, it has lambda sign. That is thick intertwin membrane with placental masses in between, or seen as a lambda sign. And there are some unique fetal complications in twin pregnancy. And first, I'm going to discuss about single fetal demise. Single fetal demise in first trimester is otherwise known as vanishing twin. It's a term that has been used to describe the spontaneous loss of twin during the first trimester. And 23% of twin pregnancies diagnosed by ultrasound at 6 weeks will be a singleton pregnancy by 12 weeks. Patient may have mild cramping pain or minimal bleeding noticed in the first trimester, but it will not cause longer term implications for the pregnancy. Second and third trimester loss, the incidence is 3.5% in MCDA twin and 1.5% in DCDA twin. And it is a challenging thing to the obstetrician. Management varies based on chorionicity, amnionicity, and gestation age. And the etiology for DCDA twin single fetal demise is iatrogenic fetal reduction, and spontaneous fetal demise in DCDA twin may be due to growth restriction or fetal abnormality or cord accident. And in MCDA twin transfusion accounts for about 50% of single fetal demise. And other causes are selective growth restriction, fetal anomaly, and trap sequence. Complications of single fetal demise may cause death of a co-twin or a neurological sequelae, which usually may be seen from 6 days to late 6 weeks after the fetal death. And the sequelae may be periventricular leukomalacia, encephalomalacia, porencephaly, hydrancephaly, and microcephaly. And the preterm delivery may occur in single fetal demise. That is, labor often occurs spontaneously 2 to 3 weeks after fetal death. But like placental abruption condition, that may occur immediately. Management of single fetal demise, as I told you, knowledge of chorionicity is very essential in decision making. And we should give corticosteroids to promote fetal lung maturity, and magnesium sulfate infusion should be given for neuroprotection. And of course, development of coagulopathy if a dead fetus is retained for more than 4 weeks is remarkably uncommon. But we should perform weekly fibrinogen level, platelet count, and coagulation profile after 4 weeks of confirmed fetal death. A full coagulation screening should be performed before any regional anesthesia or delivery. And we should also address the psychological issues related to grieving of lost the twin. And in diamniotic twin, the delivery should be delayed until at least 34 weeks of gestation. And until this period, we should monitor the fetal growth with serial ultrasound assessment, and Doppler flow studies should also be done with regular CTG. In monochorionic diamniotic twin, delivery should be delayed as much as possible, and till then weekly ultrasound monitoring should be done. MRI should be done 3 weeks after the fetal demise, and reassure the parent if the fetal MRI and serial ultrasound remain normal for maximum weeks after the fetal death, and also inform them that the prognosis is still strongly guarded. And Doppler assessment of fetal MCA artery is advised to detect anemia. Rescue fetal transfusion can be attempted in several centers if fetal demise is of very recent origin. In MCMA twin, death in MCMA twin can cause death of both twins, and the risk of neurological sequelae in the survivor twin is extremely high. So always it is advised to deliver by 28 weeks of gestation. This is a flowchart which I have discussed so far. And mode of delivery, obviously it may be by cesarean section or vaginal delivery. If the live twin is leading and it is well grown, and if it is in cephalic presentation, vaginal delivery may be considered. But if the live twin is malpresenting or growth restricted, or if the dead twin is leading, cesarean section is a preferred mode of delivery. And the second one is discordant twin or selective growth restriction. Unequal placental sharing or marginal insertion of the placenta common in monochorionic twin, and it usually results in discordant fetal growth. Here, one fetus will be of normal size and the other will be smaller. Defined as estimated fetal weight less than the 10th centile. Discordant growth may be due to differences in genetic potential between co-twins or placental dysfunction confined to either one placenta or one placental between two twins. It is not a selective growth restriction. It approximately, the incidence is 10 to 15% of monochorionic twin. And there are 3 types in selective growth restriction. Type 1 shows growth discordance with positive diastolic velocity in both fetal umbilical arteries. Type 2, along with growth discordance, there will be absent or reversed end diastolic velocities. In type 3, there will be cyclical umbilical artery diastolic waveforms. That is absent and then reversed end diastolic flow in an acyclical pattern over several minutes. Screening for SGR should be done by ultrasound from 20 weeks of gestation at 2 weekly interval onwards. Calculate the estimated fetal weight discordance using 2 or more biometric parameters, and then calculate percentage of estimated fetal weight discordance using the following formula. That is larger twin estimated fetal weight minus smaller twin estimated fetal weight divided by larger twin estimated fetal weight into 100. This gives the percentage of EFW discordance. And Leica volume should be assessed, measured and recorded to differentiate it from twin-to-twin transfusion syndrome. In particular, those with absent or reversed end diastolic volume and cyclical umbilical artery Doppler waveforms are at increased risk of perinatal mortality and morbidity. And outcome of selective growth restriction type 1 is usually very good. In type 2 selective growth restriction, there is a high risk of intrauterine demise of the growth restricted twin, or the preterm delivery of the twin is also increased chance. In type 3 selective growth restriction, there is 10 to 20% risk of unexpected fetal demise of the smaller twin. Even if the ultrasound features are very stable and normal, and if the CTG is normal hours or days before, there is a chance of unexpected fetal demise. And there are 20% risk of neurological injury in the larger twin. Management of SGR. SGR in monochorionic twin triggers evaluation in fetal medicine center. In early onset SGR, there will be association with poor fetal growth velocity and abnormal umbilical artery Doppler assessment. Selective reduction may be considered as an option. In type 1 selective growth restriction, planned delivery should be considered at 34 to 36 weeks of gestation if there is satisfactory fetal growth velocity and normal umbilical artery Doppler form. In type 2 to 3 selective growth restriction, delivery should be planned by 32 weeks of gestation unless the fetal growth velocity is abnormal or worse Doppler assessment. For monochorionic twin SGR, where there is umbilical Doppler abnormality, delivery should be undertaken at 32 weeks of gestation. 50% of the twin may land up with preterm birth, and it could be predicted by cervical length measurement. If the length is less than or equal to 2 centimeters at 20 to 24 weeks of gestation, there is 97% chance of preterm labor, and prevention of preterm labor, bed rest, prophylactic tocolysis, IM progesterone.
You have 2 more minutes to complete. Your time is up, ma'am.
Okay, ma'am. There is no benefit in all these measures. Cervical encirclage has not been shown to improve perinatal outcome, and silicon arabine pessary is an alternative to cerclage. And treatment for preterm labor, tocolytics, glucocorticoids, and magnesium sulfate is advised. And twin-to-twin transfusion syndrome, donor twin transfusion will be from donor twin to the recipient twin, and there will be a unidirectional flow through AV anastomosis. And the donor twin will be growth restricted, oligohydramnia will be there, recipient twin will be polycythemic and polyuria will be there. And fetal brain damage can occur in both twins. And it is identified in 11 to 12 weeks of gestation alone when the CRL discrepancy is more than equal to 10 mm. And when there is abnormal DV flow patterns in one fetus, TTTS is identified. And in second trimester, there will be membrane folding at 15 to 17 weeks of gestation, and there will be absence of artery-to-artery anastomosis, and velamentous card insertion will give the clue. And TTTS will be of 5 stages, Pintero staging. Type 1 is discordant amniotic fluid volume, and type 2 there will not be urine in donor bladder, and type 3 abnormal Dopplers will be there, and type 4 ascites and demise. And stage 1 75% remains stable or regress. Stage 2 or higher, there will be perinatal loss. Intervention may be a amnio reduction. Laser ablation of individual vascular anastomosis is the best treatment modality. And after laser ablation, we should follow up the twin for weekly scan for 1 month, and then after 1 month we have to do 2 weekly scan to detect iatrogenic taps. And the bladder filling and increase in amniotic fluid in donor twin should be studied. MRI brain should be done at 30 weeks of gestation. And twin anemia polycythemia syndrome, when there is chronic and severe hemoglobin difference between donor and recipient monochorionic twin, it may be spontaneous or iatrogenic. Optimal management is unknown, but we can go for elective birth or cord occlusion or laser coagulation. The problem with this procedure, the problem in treating the TAPS is impaired visibility due to advanced gestational age. And TAPS sequence conservative management is advised when there is no hydramnios or hydrops. When there is hydramnios and failure, serial amnio drainage and tocolysis is advised. And with hydramnios or failure, 90% survival after second trimester radiofrequency ablation will be there. If it is less than 19 weeks, if it is diagnosed less than 19 weeks, 45% fetal loss will be there. More than 19 weeks, 3% fetal loss is there. Twin with molar pregnancy, if there is complete hydatiform mole associated with coexisting normal features, incidence is 1 in 22,000 pregnancy. When there is partial mole, the other twin will be having anomalous findings. Early diagnosis by ultrasound is advised. If it is less than 20 weeks, MTB should be done. In case of continuation of pregnancy with karyotypically normal and non-anomalous co-twin, there is chance of persistent heavy bleeding, severe preeclampsia, preterm delivery, and maternal mortality is high in this condition. In monoamniotic twin, targeted anomaly scan should be done at 18 to 22 weeks of pregnancy, and 2 weekly scan for growth and amniotic fluid assessment should be done. And increased antenatal surveillance should be done from 26 to 28 weeks of gestation. Steroids should be given for lung maturity. Elective preterm birth is indicated at 32 weeks of gestation. Cesarean delivery is advised to avoid cord entanglement and anticipate complications in twin delivery during labor, like uterine contractile dystonia.
Can you summarize?
Yeah, madam. Delivery twins in DCDA twin gestation 37 to 38 weeks. We should plan our delivery, because the chance of stillbirth is high in twin pregnancy. In MCDA, it should be delivered by 36 to 37 weeks. In monochorionic monoamniotic twin, the delivery should be done at 32 to 33 weeks. And in cephalic and non-cephalic presentation, optimal delivery route is controversial, but we can go deliver by cesarean delivery or vaginal with version. And cesarean delivery for second twin is also advised, but it is least desirable. And induction of delivery can also be done as like in singleton pregnancy. Analgesia, labor epidural is preferable. Induction with prostaglandin and Follis induction can be done in twin pregnancy. Success rate is similar to singleton pregnancy. In vertex presentation, vaginal delivery should be done. Interval between the delivery should not exceed 30 minutes. In vertex breech, if vaginal delivery is planned, it should be done by senior obstetrician. In breech vertex, safer to perform cesarean delivery. Stage 1 monitoring should be with electronic fetal heart rate monitoring. Adequate hydration should be done. Cross-matching samples should be available and conducted by skilled obstetrician. Anesthetist team should be ready, and pediatrician should be ready for neonatal resuscitation. Forceps can be used for first baby delivery. And always do not give methogen. Leave 8 to 10 centimeter of card for administration of drugs. And before delivering the second baby, after delivery the first baby, the live presentation should be confirmed. Do vaginal examination to rule out cord prolapse, and delivery of the second baby should be done. And delivery complications like uterine atony is common, so routine active management of third stage should be done. When there is difficult extraction in unengaged vertex during cesarean delivery, you deliver the second twin first, or instrumental delivery can be done when there is difficult in delivering the fetal head. Pediatric team should be there. When there is head entrapment, the cervix prevents delivery of the fetal head. The anesthetist should ensure the patient had good pain relief, and Droser incision can be made on the cervix using bandage scissors. This technique increases the diameter of the cervix, allowing the head to pass through. And unengaged vertex of twin B, cord and fetal hand prolapse can occur. The risk of head entrapment is too much to go for cesarean delivery. And twins with previous scar, trial of scar if twin has a first vertex. Judicious external and internal manipulations are not contraindicated, but prefer cesarean if transfers of breech. Success rate is only 30 to 75% if trial is allowed. Thank you, ma'am. Thank you for the time. Sorry for the time delay.
No, Rajeshwari, it's very big topic, I know, but we have to. Thank you. Thank you. Kalpana.
Okay, ma'am. Thank you so much.
Chairperson, do you want to conclude?
Banu madam is there. Banu Sri Lakshmi is there.
Yeah. Madam, good afternoon. Good afternoon.
You have to stop screen sharing, Dr. Rajeshwari. Yeah, madam.
Yeah, Banu ma'am.
You have to stop screen sharing.
Yes.
Banu ma'am, your remarks.
Yeah, madam. I am here.
Yes, please.
I want to introduce Malati Prasad.
Okay.
Malati, 1 minute. Let the CV come.
Yes, ma'am.
Profile of
Malati CV podunga.
Hello, good afternoon, everyone.
No, ma'am. First, you unshare the screen, then I will be able to share the screen.
Yeah, I think. Have you stopped screen sharing?
Yes, 1 minute, Malati. Your CV. Let them introduce.
No problem.
Then only
they can share your profile.
Shall I stop?
Yes,
ma'am.
Sharing.
1 minute. Yes, I've stopped.
Yes, Malati CV podunga. Yes, Dr. Banu.
Yeah, madam, audible?
Yes.
Hello?
Yes,
ma'am. Go ahead. Introduce Dr. Malati Prasad.
Yeah. Good afternoon, everyone. This is a great honor and privilege. I would like to thank to Dr. Sampati Kumari madam and organizing team. And now I introduce Dr. Malati Prasad.
You can keep it very short. No issues.
Present, she is a director of Trichy Fetal Medicine and Fertility Center, consultant in maternal and fetal medicine, TFMC, IS Hospital Trichy, FMM certification for the first trimester ultrasound, post held Secretary Trichy, Obstetrics and Gynaecology Society, executive member of Imaging and Fetal Medicine Committee, FOXY 2019 to 2022, Vice President Trichy, OBG Society, Former Secretary IMA in Trichy Society, conducted fetal medicine workshops in South India, invited faculty in AICOG, and UA Foxy. Awards won the first prize for paper on fetoscope biopsy in epidermomyolysis bullosa in national conference best paper prize in UA Foxy 2015 per paper on alpha thalassemia and immune hydro.
Yes,
I welcome Dr.
Thank you.
Malati Prasad to today CME.
Okay, ma'am. Thank you.
Thank you.
Dear speakers, please stick on to the timings so
Yes, ma'am.
that the other faculties will not be disturbed. They may have some other program. Please stick on
Can
to
you
your...
can you see the screen, ma'am?
Yes, go ahead, please.
Yeah.
Yes, Malati, we can see.
Yes, ma'am.
Thank
Thank you.
Yes.
Madam, it's okay. Okay. Thank you very much. I must take this opportunity to thank Dr. Sampath Kumari madam and Dr. Anjalakshmi madam for giving me this opportunity. And today I'll be, can you see me, ma'am? Because I'm not able to see me here.
Yes, video, audio, everything is right.
Yeah. Okay, ma'am. So today we will be talking on a very major and dreaded complication of monochorionic diamniotic twin, which is a twin-to-twin transfusion. So what is the incidence? It's about 1/3 of twin pregnancies. That is 30% of twin pregnancies are likely to be monochorionic. And what happens in a monochorionic twin is that the placenta contains a lot of vascular anastomosis. It could be arterioarterial, arteriovenous, which can cause a lot of hyperdynamic circulation in one twin and less dynamic circulation in other twin, causing a lot of complications. So angio architecture of these vascular anastomosis is very, very important, which I'll be coming up in the various slides. So this vascular anastomosis between the two twins can cause unequal hemodynamic and amniotic fluid balance, causing hydramnios in one twin or oligoamnios in the other twin. So what happens if you don't treat? If you don't treat TTTS, about 90% of them will result in fetal demise in about 2 weeks' time, with morbidity in survivors of over 50%. So what are the quintero staging? I think already mentioned by the previous speaker. Stage 1, poly in one twin, oligo another twin. Both the donors, the bladder, as you can see in both, you can only find an oligo-poly sequence in stage 1. In stage 2, what happens is that the bladder of the donor twin disappears. But when you do not see the bladder of the donor twin, we call it as stage 2. What is stage 3? Stage 3 is a condition where you have a lot of Doppler abnormalities, like absent diastolic flow or reduced diastolic flow in one of the twins, with pulsatile umbilical venous flow in the either twin. Stage 4 is when you have hydrops in one twin, and stage 5 is death of one or more twins. So as Dr. Chinmay said, it's very important as is a chorionostomy in the first trimester. Because if it is a monochorionic twin, the patient needs to come to you for follow-up every 2 weeks from 16 weeks of gestation. If you miss out on the monochorionic, you will end up in a twin transfusion at about 20 weeks of gestation. And I said 1/3 of the monochorionic twin are likely to have twin transfusion. And you need to remember that this staging does not represent the progression. It does not mean that stage 1 will go to 2, 3, 4, and 5. No. Stage 1, when you see today, you would have asked for laser ablation. Within a week's time, you will find that the fetus has gone for stage 4. So this particular staging has not gained so much of significance because it does not, it prognosticates, of course, but it is not representative or progression of the disease. So most importantly, which is coming up is the recipient. You have to look at a complete echo of both twins, especially the echo of the recipient twin, because there could be an increased cardiac afterload and preload. It's important to look for tricuspid regurgitation. This particular patient at stage 2 had a tricuspid regurgitation, explaining that the recipient twin has got some sorts of cardiac morbidity, and I'll tell you how to do the CHOP score in the later scenes. So it's important to do a biometry. As you can see, this fetus has got a discordancy ratio of more than 56%, which is a stage 2 TTTS, which is very, very significant, saying that one of the fetus is going in for a selective FGR due to the twin transfusion. So what do? We know that stage 1 is oligopoly. So it's very simple, less than 2, more than 8. When you have a monochorionic pregnancy with the amniotic fluid discordance, which is atypical. For example, as you can see in the slide, fetus 1 has got a single vertical pocket of 8, whereas fetus 2 has got a single vertical pocket of 2.8. So can you label it as twin transfusion? See, this patient is referred to us from Madurai, asking for laser because it has twin transfusion stage 1. But when we saw, it was the single vertical pocket was 2.5 and the bladder was still visible. As you can see, the bladder of the
donor twin is still visible. So we could not put it as stage 1 or any type of TTTS. So this patient was asked to come every week because this has got an overall good survival rate. But still, 14% of these fetuses could go for severe TTS. So always keep a watch on these fetuses, even though it does not fit into that typical discordance of amniotic fluid. So pathophysiology, it could be arteriovenous anastomosis, veno-arterial anastomosis, arterio-arterial, or a veno-veno anastomosis. We're not very concerned about the arterio-arterial veno-venous because of the fact that they're usually bidirectional, and what happens is that there's equal flow of blood across the donor and the recipient does not cause TTS, whereas we're only concerned about the AV and veno-arterial anastomosis. And when you have larger arteriovenous than veno-anastomosis, that is AV anastomosis in the donor and lesser veno-anastomosis in the recipient, these are the fetuses which can go in for TTTS. So unbalanced anastomosis will cause twin-to-twin transfusion. There's a net transfer of fluid from the donor to the recipient causing oligopoly. And another pathophysiology is vasoactive mediators, which has not been dealt in detail. So these are the things which we usually pick up in ultrasound, so it becomes easy for us to justify. So as I said, this is the bidirectional, the superficial ones, which are not very significant, whereas the deeper ones are the ones which are very significant because they can cause unidirectional flow, and we're only concerned about the deeper anastomosis. And coming to a simple CHOP score, which has been formed the Philadelphia group, where you have to do an echo of the donor and the recipient, and look for cardiomegaly, ventricular systolic function, MV regurgitation, tricuspid regurgitation, and ductus venosus, do the umbilical vein, pulmonary regurgitation. There are about 11 points in the CHOP score, based on which we are able to prognosticate better. So a score of 0 to 5 is considered stage 1, 5 to 10 is stage 2, 10 to 15 is considered as stage 3 and 4. So we do a combination of CHOP score and the routine ultrasound scoring of Quintero staging, and talk to the patient regarding the prognosis of this particular pregnancy. So how do we start screening? As already enumerated with the previous speaker, chorionicity, very important, do an NT and CR. When you find an NT discrepancy of more than 20%, which is given by the software, nowadays we have good softwares which give you the discrepancy very, very clearly. If it is more than 20%, think of TTTS and always call back the patient at 16 weeks and do an ultrasound every 2 weeks. When you find an NT more than 95th centile in one or both fetuses, in one fetus or both, again think of this patient going in for TTTS. When you find a CRL discrepancy of more than 10%, again, this patient is likely to go in for TTTS. And when you find an abnormal Doppler, so this was a case, cystic hygroma in one, a normal fetus, and this patient went in for a interstitial laser ablation at 16 weeks of gestation. So once you've started, you need to start screening from 16 weeks of gestation every 2 weeks. Very, very meticulous. Tell the patient that you have to come every 2 weeks, because if you land up in TTS, nothing much can be done. So when she comes to you for a routine ultrasound, look at the Leica volume, look at of both the fetus, look at the bladders here, nicely seen. It was only stage 1 TTTS, which is in the you have a polyhydramnias, you have an oligo set in here, and measure the single vertical pocket of both the fetuses, bladder of both the fetus, very important. And do not forget, do the Doppler and umbilical, MC, and the ductus venosus. So because based on these 4 parameters, you're going to do a staging, whether it's stage 1, 2, 3, 4, or 5. So expectant, what is the role? Stage 1, can you do a expectant management? This is regarding the counseling. Counseling takes almost close to 45 minutes to 1 hour. You have to talk to the patient in detail, saying that if you do not treat, the risk of mortality is 90%. When you treat, you will have 70 to 80%, one fetus surviving. Both surviving is only about 40 to 50%. So always tell them that we're not going to do magic. Both the fetus not going to come out fine. Only 50%, that 2 fetuses are going to come out fine. Risk of miscarriage is 50%, preterm labor 30%, IUD you can have 30 to 40% after 2 weeks, and post-procedure TAPS is about 1 to 3%, recurrence again is 1%. So treatment. So how do you treat the one you have diagnosed? You put it as stage 1, 2, 3, 4, or 5. Stage 1, if it is less than 26 weeks of gestation, what do? Is there a role for conservative management? Yes, there is a role for conservative management. When you find oligopoly and bladder still seen, always do a conservative management. Call her back every week and wait for it to settle down, because very often we have seen that stage 1 have settled down and become normal. There has been a normalization of the Leica volume. So do not rush into a laser for stage 1. But of course, in stage 2, 3, 4, and 5, laser ablation is a treatment of choice. So in stage 1, what are the indications? Suppose it belongs to stage 1, I said you don't have to do a laser, you can do a conservative management. So when you have a worsening poly, that is, for example, when you have a 8 or 9, 10 of polyhydramnias causing a lot of discomfort, maternal discomfort. We've seen patients coming in like that, very difficult for them to lie down. Even for 10 to 15 minutes of ultrasound can be very, very difficult, because they go in for supine hypertension, they go for breathlessness. So such a things, when there's a shortening of the cervical length also, you're justified in doing a laser. So in a systematic review of stage 1, the overall survival was about 85% when compared to conservative 86, almost the same. So I think we are justified in doing a conservative in the absence of the risk factors which was mentioned. So what happens to stage 2 to 4? What do you do? Stage 2 to 4, the only choice is fetoscopic laser ablation. When the gestation age is more than 26 weeks, suppose you find it is still about 28 weeks, and do an amnio reduction. You don't have to do a laser ablation. Why? Because after 26 weeks, there is a lot of difficulty because there's a lot of vernix in the amniotic fluid. So visualization of the arteriovenous anastomosis becomes very difficult, and there are vessels very large. So when you go ahead and do a laser coagulation, you can have profuse bleeding from one of the vessels causing fetal exsanguination. And there's a larger in utero distance. By the time you reach the AV anastomosis, the fetoscope is designed in such a way that it can only progress to a particular distance. So these are the disadvantages of doing laser after 26 weeks. So after 26 weeks, always amnio reduction, but some centers still do a laser ablation. But beyond 26, 27, we do not do a laser ablation. We just manage the patient conservatively, try to pull the pregnancy till about 32 to 34 weeks of gestation and deliver, maybe do an amnio reduction for the maternal discomfort. So how it's very important that patient comes to you, you've done a complete staging, and intra-op assessment is very, very important, because it's not that you just post a patient for surgery and without have a proper this thing. So you have to localize the placenta. So this placenta is posterior, and identify the cord insertions. For example, so this is a placenta, the oligoamniotic twin. You have to identify the cord insertions. And once you have identified the cord insertions, you have to make an entry between the cord insertion, because this is where you will find the anastomosis, which I'll be showing you in the future slides. So always do a cord, and we mark it in the abdomen. We mark it with the right iliac fossa, right hypochondrium, or left iliac fossa. Make a marker with a marker pen so that you know where the cord is. And you make an entry in between the cord insertions so that you reach the anastomotic site. So this is the equipment, which is a fetoscope. We use a 2 to 3 mm fetoscope for posterior placenta. This is a curved fetoscope for an anterior placenta. And these are the routine instruments which you would otherwise use in a laparoscopy, or light source, cable, and a video monitor, and which I think any lab equipment would be enough for this. So entry plan, as I said, locate the placenta. You've located the placenta. You identify the cord insertion which is here, and one cord insertion is here. So this is the placental equator, and always you have the membranous equator, which is parallel to the severe oligoamniotic, that is the donor twin. So you have to identify the vascular equator, you have to identify the membranous equator, which is usually parallel to the twin. And once you've identified, you know that you have to make an entry here, because there is one cord insertion here, one cord insertion here. So your point of entry will be in this row. Only then you will find the anastomosis. Always go through the polyhydramnionitic twin, and always find the intersection difference. So once you know where exactly the cord insertion is, you will be able to map the vascular equator and the membranous equator. So these are the few videos where this is ultrasound guided. We usually do under local anesthesia, but always have an anesthetist at the head end for maternal monitoring, because the patient is very uncomfortable with a lot of hydramnias. And some we have now done at a regional. We just give the patient something to allay the apprehension and infiltrate a local anesthesia. And the equipment should be in front of you. So suppose you're going from the left of the patient, keep the equipment in front of you, to the right on the opposite side. So once you've done, okay. So what are the different techniques? We introduce first a 18G needle, and through which the guide wire is passed. And once you pass a guide wire, the 2 to 3 mm fetoscope will be passed inside briskly into the polyhydramnionic twin. You cannot get into the anhydramnionic twin. Go through the polyhydramnionic twin. Always use the selecting the technique. Previously, we used a selective technique where we used to select that wherever you find AV anastomosis, you have to go on laser coagulate, because risk of recurrence is very low. So maternal position will be supine depending on the posture. Madam, how many more minutes?
2 more minutes, ma'am.
1 minute. I'll just show you the video. So once you get inside, you will see, you very nicely see the recipient cord insertion and all these vessels, AV anastomosis under bridging across the membranes. So locate the placental edge and the membranous equator. Once you've done it, you have to have a study. You can see the membranes here. Underneath the membranes, you will see the AV anastomosis. Map the entire, go from one end to the other, map the entire AV anastomosis by a fetoscopic technique, which is visible on the camera. And once you have seen which vessel to anastomose, you will do a laser coagulation. Keep about 1 centimeter distance from the vessels, And you will find that as you do an anastomose, you can see the blanching of the vessels. Once you see the blanching of the vessels, do not leave it alone. Come back after you preserve, because we've seen many vessels bleeding after the procedure is over. So do a complete laser coagulation under the membranous equator, starting from one end to the other. So you can see the blanching, and once you've finished, always have a look at the placental edge, because sometimes inadvertently we injure the placenta. So have a look at the placental edge you see on the right of the screen. And once you've seen, once again, go through the blanching sites, as I told you, because you could have some bleeding afterwards. This is still few anastomoses left we are just planning to do, because they're all huge vessels. Sometimes when you touch a huge vessel, but this is already done, so you have a blanching and you're safe. There's no bleeding at all from the site. 1 minute. So once you've done the procedure, always do an amnio reduction so that patient feels absolutely fine after the procedure. And you have to remove about 2 to 3 liters of amniotic fluid so that the patient is comfortable. Always do a post-procedure Doppler of both the fetuses, the donor and the recipient fetus. And 1 minute. So AV, we have done a complete AV, VA anastomosis. Complete blanching is done. Look for any bleeding from the site. Recurrence is about 14% because of anastomosis missed at the time. Because when we use a selective, we have had recurrence of TTA. So once we use a Seldinger technique, the recurrence is less. How do you decrease the risk? By using of the Solomon technique. So this is stage 4 or 5, where the patient is not very comfortable with the TTS. We do a bipolar diathermy of the anhydrometry. You can see the cord being coagulated with the bipolar diathermy, which can be used in any theater. So once you've done it, amnio drainage is about 1 to 2 liters. Endpoint is 5 to 8 centimeters. Causes instant relief to the mother. And a lot of studies saying that post laser coagulation, 8.6 severe morbidity was a 6.7%. But everything depends on the GA delivery. Suppose you deliver a fetus at 30 weeks, you're likely to have a severe morbidity. So try to push the pregnancy till about 34 weeks of gestation. So weekly ultrasound with the first 2 weeks post laser IUD is very common. Brain imaging 4 to 6 weeks later, and neurodevelopmental assessment should take place at 2 years. And post TTS do a complete biometry, the single vertical pocket, umbilical artery Dopplers. 8% both recipient donors may have pulmonary artery stenosis. Keep a close watch on these. And follow up detailed examination of the brain, heart, and the limbs, and functional heart problems may occur in the third trimester. Do not forget to do an MRI if you have an IUD. When you time the delivery, I think once you've done a post laser, we usually follow the pregnancy every 2 weeks, try to deliver 34 weeks of gestation after course of steroids. If you find that you're comfortable that the Dopplers are fine, you can even wait till about 36 weeks. The optimal route of delivery following laser therapy has not been determined. I think it depends upon the choice of the obstetrician and the choice of the patient. So always stage 1, conservative management. Stage 2, 3, 4, go for laser. And when she's stage 4, for example, you have a high drops, you don't want to do a laser therapy on this patient. I think ideally we do a radiofrequency ablation or a cord coagulation by diathermy. Thank you. Thank you very much for your patient hearing.
Fantastic, Malti.
Sorry, I think I exceeded my time.
No,
Did I exceed
time only. Thank you, Malti.
Okay, ma'am. Thank you. Thank you very much.
Thank you for the
introduce Dr. Chitra.
Dr. Chitra.
Malti, if any questions in the chat box, please answer.
No questions, ma'am.
Okay.
Dr. Aarti.
Thank you, ma'am. Thank you very much.
Thank you, Malti. Thank you.
Good afternoon, everyone. I'm very happy to be a part of this session. Very happy to introduce Dr. Chitra. She needs no introduction. She's a professor and unit chief of OG department of PhD Institute, Coimbatore, and she's a past president of OG Society. She's a scientific committee member of UA Foxy, a member of IUGA and ISOG. She has special interest in urogynecology and high-risk pregnancy. She is honored by Teaching Excellence Award in 2015 by the institution. Postgraduate teacher and examiner from 1998.
Make it short, Aarti.
Yeah. Over to you, ma'am, for immunization and pregnancy, ma'am.
Thank you. Thank you. Aarti, also let me thank Sampath Kumari Madam for having given me this opportunity. It's really a wonderful thing because you tried to include the entire South, Madam. So hats off to you. Lots of people have registered. Congratulations, Madam. Can I share my screen?
Yes, Madam. Chitra, Madam. Thank you.
Yes, ma'am. Is it seen, ma'am?
Yes, yes.
Moving?
Yes, Chitra,
Yes.
madam.
Okay, okay, fine. Now, also the topic given to me was vaccination in pregnancy. It's an extremely simple topic, but I think the simple ones are the ones which we've gone requiring reinforcement because we need to know what is right and what is not right. So why is vaccination necessary in pregnancy? We know that pregnancy is an immunocompromised state. The immune status of the patient comes down and patients is at risk of developing any infections. It is easy to acquire any infections. And of course, I'm sure all of us will know that COVID and H1N1, SARS, all of them, we lost a lot of mothers to these infections. This is a chart which is showing that COVID was the largest killer of maternal mortality. The maternal mortality rose because of COVID. I'm sure all of us know the same thing, especially after the first week, we lost a lot of normal mothers simply because they had COVID infection. And even when the H1N1 came also, we lost quite a few mothers there. The sickness was very serious. If only we had vaccinated those mothers and they were prevented against this, they would not have died. And it's not only important for the mother also, but it is important for the baby also. Have you not heard of congenital rubella syndrome? Now, this congenital rubella syndrome is a condition where once a mother has a rubella infection, then she's going to give rise to a baby which has a microcephaly, which has cardiac disease, and also, in addition, cataract. So, if the mother had immunity, then she would not have transmitted it to these individuals and have a baby which had a congenital rubella syndrome. So, it's important, it's not only for her, but also it is important that she has every right to protect the baby also from acquiring these infections. So pregnancy is an important time when patients will be able to come to us. They will listen to all what we tell them because their main interest is not only themselves but also the baby. Every pregnancy is precious to every individual. So you want to do the best for the baby. So that is the time when we'll be able to tap their resources and give advice. They'll be willing to accept all those advices. So pregnancy, pre-pregnancy and the postpartum period is a golden opportunity where we could utilize that window of opportunity and then help these individuals to understand what is the importance of vaccination and try to give them the maximum things which are available. Because once pregnancy is over, our women will not come to the doctor at all. When we ask them, did you ever see a doctor? The last time they would have seen a doctor is only during the delivery. So after that, we're just going to limit the entire population. So that is the best time when we can have them in our hands and then do what is necessary. So whenever we give vaccination during pregnancy, it boosts immunity. And also in addition, it is important for the baby. And also it helps to curtail outbreaks. That is the importance. We should try to give whatever is maximum during this pregnancy period. Now, this is a chart which is showing how by vaccination, all the infectious diseases like tetanus, pertussis, etc. has come down dramatically. So vaccination will prevent infection. That is all that all of us know, that vaccination prevents and curtails the diseases. Now, just a few minutes about the types of vaccine, because we are so scared. Why are we not giving the vaccine? Because we are so scared that if we give vaccination, will some reactions happen and will the baby be affected? Will the mother, will something happen to the mother? Will she develop the infection? There are so many things which come across our mind, and that is why we refrain from giving these vaccines. So just let us know about the basics about the vaccines. We have two main types of vaccines. One is a live attenuated vaccines and the other one is a inactivated vaccines. Now, what is this live attenuated vaccines? Now, these are vaccines which are obtained from patients who have had these infections, and the vaccine, the virus is attenuated. So it passes through many cultures and then they become less and less virulent with every passage. So these are live attenuated vaccines. When you give these vaccines, the patient will have she will not have the disease. However, the antigenic stimulus is sufficient enough for her to develop antibodies, which will stimulate her getting a natural infection. That is the use of these live attenuated vaccines. When you give inactivated vaccines, all of them are dead vaccines. So you can have whole cell inactivated vaccines, you can have recombinant vaccines. All these names must be very familiar. Like hepatitis is a recombinant vaccine. You can have toxoids. You can have various subunits of one particular type of vaccine. So like influenza. So all these are inactivated vaccines. Now, what is the difference between these live attenuated and inactivated vaccines? The main difference is when you give live vaccines, it produces an immune response which closely resembles a natural infection. So you don't get the infection, but the immunity which is produce is almost similar to that which would happen if you had the infection. And the other important thing is it also produces cellular immunity. So the antibody titer is lifelong. Once you have this live vaccines, you are not going to get the infection lifelong. That is the most important advantage of giving a live vaccine. Whereas we give a kill vaccine, they do not have these cellular immunity, and you require to go on giving these repeated doses or booster doses may be required. Similarly, like in tetanus is a toxoid. So when you give tetanus, we go on repeating because the immunity will come down. We have to give a booster dose or we have to give the entire dose. So that is important. So that's the main difference. When you give a live attenuated vaccine, it has a lifelong immunity, whereas we give a kill vaccine, you may have to require additional doses. So when all can vaccines be administered during pregnancy? Of course, we give it during pregnancy, but there is a period where you can also try to give it pre-pregnancy and after delivery. What are the pre-pregnancy vaccines which are available? I'm sure, like I said, one of the most important things is a congenital rubella syndrome. So this ideal time, patients will not come and ask us, can I have these vaccines? Most of them will come and say, my wedding is fixed or I have irregular periods. What can I do? So that is the time for us to utilize these individuals to see what is the immune status. And then if the immune status, if they don't have these two antibodies against measles, or if they don't have antibodies against varicella, that will be the time when you try to vaccinate them. These are two important diseases because congenital anomalies can happen whenever a mother has a rubella infection. So how do you identify whether she's had the rubella infection? You do a rubella IgG. If IgG is positive, that means she's had an rubella infection earlier. You don't have to give her the rubella vaccine. However, if the rubella antibody IgG is negative, these are individuals for whom you will definitely advise a rubella vaccine. So same rubella vaccine, MMR vaccine can be given. You also have a specific rubella vaccine also which could be given. But it is important that when you give the vaccine, you tell them you should not get pregnant for a period of at least 1 month. So before pregnancy, that will be the ideal time when you give this vaccines. Because by giving these vaccines, antibodies are produced and the mother will not, even if she develops a rubella infection later on during pregnancy, she will not transmit it to the fetus. The other one, of course, is the varicella vaccine. Now, varicella vaccine, we know that India is an epidemic for chickenpox. I'm sure everybody would be seeing in a year at least 2 or 3 patients with chickenpox. And the complications of chickenpox will depend upon at what gestation age the mother gets the chickenpox. She herself is at risk because she can develop pneumonia. The baby is at risk of developing congenital rubella syndrome. Plus, the baby can be born with neonatal varicella syndrome. So it's a very common infection. So why don't we use the opportunity to find out whether she has immune against chickenpox? If she's not immune, it will be worthwhile to give her the varicella vaccine. So remember, both these vaccines are live vaccines, and once these vaccines are given, pregnancy should be avoided for at least a period of 1 month. Only then she can try to get pregnant. Now, of course, the other one which is coming up in a long way is vaccination against HPV virus. So ideally, in other Western countries, the age till vaccine is given is to 21 years, and from 21 to 45 is only a catch-up vaccine. Now, so before she embarks on sexual activity, that will be the best time for her to get the vaccines. And if she has sufficient time, you can ask her to take these vaccines. It's just like your hepatitis, you give 3 doses, 0, 2, and 6 months. So supposing she has the time is very short, she's going to get married in another 4 months, then you give her 2 doses, and then the 3rd dose can also be skipped, because now the latest, there are a lot of studies which say that it's sufficient if we just give them 2 doses. You really don't have to give them 3 doses. So it will be better to give them the Gardasil. In fact, with teenagers, that will be the best time when these vaccines are administered. If not, if they come for pre-pregnancy counseling, you can try to convince them and give them these vaccines. So now, what about pregnancy? I'm sure everybody knows, even patients themselves know, when they get pregnant, they should have 2 doses of TT. Is TT the only vaccine which is available in pregnancy? That means we are not well versed. We have fear, though we might know that many things can be given, we are having the fear what to give during pregnancy, and we are not, there are some lacunae. We are very concerned about the safety, and we do not know how well the vaccine is going to happen, what is going to happen to the patient. And that is why many of us don't use many vaccines, which we should. Now, this is the ACOG recommendation in 2018, which gives a summary of the maternal immunization schedule. So it says 4 things. What are the vaccines which are indicated during pregnancy, which may be given during pregnancy, which should not be given in pregnancy, and which can be given postpartum. So let us take up one by one. So what are the vaccines which are indicated during pregnancy? There are 2 things. One is the influenza vaccine and the other one is the tetanus. Now, initially we were all giving only tetanus, but then the government has changed TT to TD, means tetanus and diphtheria. So why was that done? But however, I must tell you that many people outside private practice will still continue to give TT. So it's important that we change over from TT to TD. Why is this TD? TD is tetanus and diphtheria. Now, when we are giving tetanus, the incidence of tetanus came down markedly. In fact, many countries don't even give TT because they are globally 80% of all countries they've eradicated tetanus. Only in a few countries tetanus is still there. And it is important to give, wherever the prevalent is there, it's important to give them tetanus. But however, TD will not only prevent against tetanus, it will also prevent against diphtheria, because they found that the incidence of tetanus has gone down, whereas the case of diphtheria is increasing. In 2016, there was an outbreak in Kerala with diphtheria. And so they said, it's important that there's a graph showing that tetanus is the immunity is coming down after diphtheria. More cases of diphtheria we're seeing, whereas tetanus the incidence is really coming down. So the schedule is for TD. As soon as the patient comes, you give the first shot, and then the second shot is given 4 weeks after the first shot. But if she has another pregnancy within 3 years, it is enough if we just give her 1 single dose. So TD is the dose, is the vaccine which is to be given. It is not TT. Now, this is another change which many of us have switched over. They say just like how diphtheria is common, pertussis is also common, because we normally administer TPT injection to the baby only after 6 weeks. So the first 6 weeks, these babies are highly immune to pertussis. So they say 1 dose at least should be given, which has tetanus, diphtheria, and pertussis. And this dose should be given ideally around the 28th to the 30th week. That is the best time to give this Tdap injection, because when you give them within 4 to 6 weeks, there is a lot of antibodies which are produced, and they will get across to the mother, to the baby, and the baby will be protected against pertussis. In fact, they also say pertussis is mainly, the baby develops pertussis from the mother or from household contacts. In fact, they go to another extent saying that all the household contacts, whoever is going to come in contact with the baby, should also have this pertussis, is what they say. Now, the next one is about influenza vaccine. Now, influenza vaccine also, there's a study which said, which studied about influenza illness in pregnant women. And they say that whenever a person is pregnant and she has this respiratory infection, there's a significant proportion causing morbidity and mortality. And they said you must try to reduce this mortality and morbidity by vaccinating all these individuals with influenza. This is a study which has come out in India, in the northern India. So the WHO also says that during these seasonal times when flu occurs, that is the time when you must administer influenza vaccine, and you give them the latest vaccine which is available, because the strain will go on changing. So whatever the best vaccine, that is the time when you give. I'm sure many of us don't give this vaccine, but it's important that you give them the vaccine. We should give these 2 vaccines. Tdap should be given. We should also give this influenza vaccine. This should be given for all pregnant individuals. Now the third, I'm sure the third one is COVID. I'm sure everybody, that is one vaccine that all of us have given, have taken, and we also advise our patients. Okay. So, now the next one is, what are the other vaccines which can be given in certain populations? Now, if you see as a person with some high risk, then for these individuals, they will recommend certain vaccines like meningococcal vaccine, pneumococcal vaccine, hepatitis A and B. So let us take up each one by one. Pneumococcal vaccine is a vaccine which should be given for all patients with HIV, sickle cell anemia, and patients with chronic illness. Because we do see patients with sickle cell anemia, especially in certain belts. In our place also, it's quite common. HIV also we still see. So it's not enough if we just do the routine. It's also important that we give them this pneumococcal vaccine.
Madam, 2 more minutes.
Okay, ma'am, sure. Similarly, meningococcal vaccine also should be given in all patients whenever there's an occupational hazard. The same thing hepatitis A. Now, what about hepatitis B? Whenever a person has hepatitis B, when she has a sexual partner who is hepatitis B positive, then it's important that you give them. Hepatitis B vaccine is not contraindicated during pregnancy. You can give this hepatitis B vaccine if she's hepatitis B negative. Then it is, if she does not have these antibodies, it's important that you give them. Then, of course, the other one is rabies. We can occasionally come across a person who has is bitten by a rabbit dog. What do we do? You can give them the entire schedule. It's only a live inactivated vaccine. The entire schedule can be given. Now, contraindication to pregnancy, I said you should not give MMR, you should not give varicella because both these are live vaccines. It should contraindicate it. What about postpartum? All these vaccines, if you've missed it during pregnancy, you can give all these vaccines. Your Tdap also, suppose you've not given it the 28 to 32 weeks, you can give it during immediately after delivery because still antibodies will be there and will protect the baby during breastfeeding. Influenza vaccine will not given, you can still give it. Similarly, all this meningococcal vaccine, hepatitis A, hepatitis B, HPV, all these are the best time because breastfeeding is not contraindicated. The baby is not going to get the infection. It will not be transmitted to the baby. So irrespective of whether it's a live vaccine or a kill vaccine, all these can be given during lactation. So to conclude, vaccination is the only most important effective way to help protect you and your loved ones against potentially life-threatening vaccines and preventable disease. This is what the WHO bulletin says in 2008. So let us not hesitate. Let us give all our patients vaccine. You must know what vaccines to give pre-pregnancy, what vaccines to give during pregnancy, what are contraindications, and what can be given postpartum. I thank the organizers for having given me this opportunity. Thank you so much.
Oh, ma'am, very nice presentation. All concepts clear. I don't think there's any room for any questions.
Thank you, Aarti. It's a pleasure to see you, Aarti.
Thank you, ma'am. Pleasure to listen to you, ma'am.
Thank you.
Thank you so much, ma'am, for the wonderful talk. It was very clear. So with that, we move on to the next interesting panel discussion because we are late by 30 minutes. It's my pleasure to introduce and invite our panel moderator, Girija Bagh, ma'am, who is a professor, Department of ObGyn, Bharati Vidyapath Medical College, Pune, senior consultant, Cloud9 and Apollo Hospital, Pune, faculty professor, and expert general coordinator 2016, chairman medical disorder in pregnancy committee 2012 to 16, vice president India chapter justosis since 2014, member of governing council member 2011 to 14, joint national secretary for ObGyn 2010, assistant coordinator national eclampsia registry since 2008, member central supervisory board of PCPNDT Act 2010 to 14, national mentor Lakshaya and various projects. Welcome you, ma'am.
You can read the panelist also.
Yes.
Introduce the panel. What is the question in the chat box, ma'am? Do you want me to take it now or after the session?
Yeah, you put it in the chat box itself, Karmalti.
Okay, ma'am. Okay, ma'am.
It's my pleasure to welcome our panelist, Dr. Karpagambal Sairam, who is a consultant and fertility specialist. Her interest is fertility, high-risk pregnancy, EC member of ObGyn. Welcome, ma'am.
Thank you.
Bharti Rajshekar, who is a medical director, ObGyn consultant, Secure Hospital, Hasan, honorary secretary of Kazoga 20 to 22, and also KPMEA state vice president, IMA state past vice president. She has worked in ObGyn food, medical equipment, drug committee, preventive oncology committee, trainer of various ObGyn programs, recipient of various awards. Welcome, ma'am. Dr. Shesha Sai, who is a professor, HOD in Apollo Medical College, Chittoor. Welcome, sir. Dr. Kiranmai Devyani, who is a professor in Telangana, chairperson elect for Violence Against Women Committee, coordinator of ObGyn Dhira Initiative, Vice President Secretary, past Vice President and Secretary of Hyderabad Society. Welcome, Dr. Kiranmai. Dr. Meka Krishna Kumar, ma'am, who is Professor in Apollo Hospital, Hyderabad, Senior Consultant in Hyderabad, National Corresponding Editor, Jogi, National Coordinator of MEDA, Member of Research and Good Clinical Practices, SAFOG, Vice President, Telangana Congress of OG Society, Governing Council Member, 18 to 21, President of OG Society, Hyderabad Society. Welcome, ma'am. Dr. Somalata, who is a consultant in Vijayawada, AP. She has been a faculty in various conferences, national and international conference. Welcome, ma'am. Dr. Vaishnavi, who is a senior resident at Muthukumaran Medical College, currently assistant professor there. Welcome, Dr. Vaishnavi. Over to you, ma'am, for your interesting panel discussion. Girija, ma'am.
Can I have the permission to share my screen, please?
Please, ma'am.
Yeah. So I'm sure the screen is visible, and we are now going to deal in the next 1 hour on the challenges at cesarean section. And I'm definitely extremely grateful to Dr. Sampath Kumari and the organizers for giving us this wonderful opportunity, because we all know that C-sections are on the rise, and therefore we have to come up and discuss these issues, and especially from the expert panelists that have been, given this opportunity. And the focus points of this discussion today are going to be non-engaged and deeply engaged heads, incision extensions, dry delivery, and crash cesarean section. And welcome to the discussion, and I'm sure the experts are going to give us a lot of insights into things. Now, we all know that C-sections are necessary for various reasons, and especially in case of specific pregnancy and delivery complications, as have been displayed on this chart. And also sometimes now a lot of them are rising because of the maternal request. And categorically, we have decided not to include any kind of MAP or morbidly adherent placenta issues, because the organizers have given us LSCS. So we have decided to stick to only lower segment cesarean section and not get into any other kind of varieties. And we all know the use of section has been increased across the world during the last 2 decades, and it's associated with significant reductions in maternal and neonatal mortality, and that is definitely an advantage. While the WHO keeps on saying that the incidence is 15%, the potential overuse of C-section procedures places an additional burden on weak health systems in less developing countries with limited resources. And therefore, we have to be looking at doing them properly so that we avoid the consequences. And if you look at the India C-section conundrum, there are too many or too few, and it's both. And that is something that we are really trying to balance ourselves. So my first question goes to Dr. Karpagambal Sairam, madam. Overall, C-sections are on the rise, and optimization of the operative procedure and minimize complications has become the need of the hour. So before we embark upon difficulties, let's look at how to prevent them and how to be on guard. So therefore, what are the gross checklist pointers that must be considered before a cesarean delivery?
Yeah, good afternoon, everyone. Basically, we have this protocols for all surgeries, but cesarean being the most common surgery, I think there's no scope for missing out any point. So first of all, apart from the WHO checklist that we follow for all routine procedures, I think it's imperative and very important to focus on the points specific for the cesarean section. First is always the patient profile, which is the ID check, which I would definitely emphasize that it has been read out loud and clear in the operation theater. And then we have the patient has allergies, the blood group, the name, age, everything is confirmed, the registration number, the LMP, the gestational age, that's also very important. And all the other details, the personal details are actually confirmed, like whether LDPD, the obstetric score. So this is the most important thing for patient profile. And then we have to determine what are the risks involved, whether it's a preterm baby, whether it's a risk for the mother or the baby, and whether the indication for cesarean section has been documented, and then whether it's a type of cesarean section, whether it's an emergency or elective. And we are going to have case scenarios about crash cesarean sections as well. And what is the modified Robson scoring? Actually, this is actually missed out in most of the cesarean sections, but I think it's very important for all of us to identify where we stand in terms of this modified, what is the modified score in this situation. Then we have the routine preoperative checklists, all the checklists that, as Madam had put it has to be mentioned and it has to be checked. We have to put a tick box, but it's very important to read it clearly, loud and clear, and then tick it. Then we have counseling and consenting, where the anesthetist has been informed whether the preoperative preparation has been done, the nil per oral about at least 8 hours, 6 to 8 hours for an elective cesarean section has been followed, and the patient's preparation, the skin incision has been planned, the placental position. Madam was telling about, we're not going to talk about placenta MAP, but still I think it's all doing so. We don't have undiagnosed situations and undiagnosed breaches in case of and surprises during the surgery. So preoperative preparation, and then intraoperatively is also very important, like how we are going to go about, what are we going to do in terms of adhesions and all the other things that we routinely do. What if in case there is an angle extension, in case there is a postpartum hemorrhage, and what is the routine protocol that we use in terms of third stage management. And in the pre-op also we have checked about the NICU setup, whether the pediatrician is ready, NICU staff nurse is ready, and after intraoperative checklist, then post-operative also we have to make sure the patient is followed up very closely. At least the vitals are checked every 15 minutes for the first 1 hour, then at least every half an hour for the next 1 hour, and then at least every 2 hours till the first 24 hours. The first 24 hours is very critical because we don't want to have these surprises, postpartum hemorrhages and any complications. And this is very, very important. I mean, this is the most salient points that I would have said, but the checklist is quite exhaustive, and it is very important that we follow the checklist. And post-op intraoperative also have this instrument counts. I always make sure that is counted at least twice or thrice, and we are convinced, the entire theatre team is convinced, including the scrub nurse, the floor nurse, everybody is convinced with the counts before we close the abdomen. And these are the basic things. We assume that cesarean section could be a very common surgery, but one thing I want to tell is we should never take things for granted. We should never take this cesarean, okay, it's only cesarean section. No. But we should not land up in any complications because it's the most common surgery. And however senior, however experienced we are, how many ever times we have done, I think every cesarean is different.
Absolutely. That was such a wonderful message that you gave, that each and every cesarean section is not only different, it is unique. And therefore, each one of us, we have to look at them very, very uniquely. And thank you for bringing this out. And most importantly, I also want to draw your attention to the fact that the Foxy has its checklist on the website. So please go and refer to them, and they'll make you easy reckoners. You don't have to break your brains, and you can use them on a day-to-day practice. So coming to my next expert is Dr. Bharati Rajsekhar. And we have Nikita, who is Gravida 4A2, conceived with pre-pregnancy weight optimization, post-septum resection, has reached 39 weeks and has requested for elective C-section for a sonography finding of 2 loops of cord around the neck. She has had weight gain of 17 kgs during pregnancy from 72 to 99 kgs and late onset of GDM. Expected baby weight is 3957 grams by ultrasound, and clinical also baby looks big. She has a cephalic presentation. Head is floating and the placenta is fundoposterior. As Dr. Sairam told us that we have to look at checklisting of various things. So where is the placenta positioned and all. Now we all are foreseeing, again, checklist tells us that yes, probably there is going to be a difficulty in delivering this big baby, especially with the floating head. So what would be your suggestion, tips and tricks to deliver such a baby so that we avoid challenges at the time of delivering this baby? Because you can see that this baby is a precious baby, and therefore we will have to plan ahead of time.
Thank you, Dr. Girija, for having me on this panel, and I thank Dr. Sampath Kumari for this excellent webinar that is going on for the next 1.5 days, and it is really expanding the academic points in clinical practice. Very well taken. Well, Dr. Girija, at the outset, the checklist has been done by Dr. Karpagam. And once the checklist, we know that there is a high risk, there's obesity, there's a floating head, there's GDM. So what am I going to expect? She has cord around the neck, 2 loops of cord around the neck, and there is a floating head. So initially, the access opening the laparotomy, that is opening the abdomen in a case of obesity, I should see that it should not be just above the pubic symphysis. I would go about 2 finger breadths above the pubic symphysis. And of course, according to the checklist, the blood loss, the hypoglycemia, and the neonatology support is already in place, I would say. So when we put the incision, try to have a wider incision because the abdominal fat may be making it a little difficult for you to access the head in this obese lady. And then the mobile head is another point. So when you have a mobile head, you make when you open the hysterotomy, you make a small incision, hysterotomy, keep it a little on the higher side and rupture the membranes and let the fluid flow out slowly and give a little lateral support so the head comes down and gets almost fixed at the lower segment. So that would make it a little easier for you to maneuver the head in maintaining the position of complete flexion. You put your 4 fingers and you could deliver the baby. But in case you have difficulties in delivering the baby because of the mobile head, you could always use either a vacuum or a forceps, depending on the protocol in your setup or on what you are used to. So I generally, in my practice, use the vacuum cup, which is specially made for the cesarean. I do not use the routine cup, which is used in the vaginal deliveries. We have another smaller cup, which is available for the cesarean section. And you have to see that you fix the cup on the exact mento-anterior diameter has to be there. You have to fix the vacuum on the occiput and maintain a position of universal flexion and try to deliver the head. Or if you're used to using the forceps, you use the first plate which goes posteriorly just between the head and the pelvic curve. You apply that and then you apply the other blade and gently maintain the position of universal flexion and deliver the head. So these are the 3 options I think I would suggest in delivering this woman who has a mobile head and she is obese also.
Absolutely, Dr. Bharti. Thank you so much. But I'm sure that when you're planning this, you would have kept all these things in mind, that I would need an instrumentation, yes, and you'll be speaking to the anesthetist when exactly to give the oxytocin and also the assistant when you're going to rupture the membranes. Right-wise, I am a little in preference of a forceps, but before that, I think these are personal preferences. Only the thing is that you have to perform them safely. I just wanted to draw your attention to this particular contraption here.
All around the neck.
No. This one, where the upper flap of the abdomen is quite holding forceps, and you retract them with a gauze, length gauze, so that, your assistant's hands are free, as you said, to manipulate the fundus of the uterus to keep it straightened so that the baby doesn't suddenly move. Because sometimes when women have a very lax abdomen, the baby may suddenly turn, and therefore you gave us a wonderful tip that just slowly try to reduce the liquor and straighten by the lateral support, and that will help in that. Now, and also you mentioned the flexion point and the pivot point, which would apply even when you are doing a vacuum application at the cesarean section delivery. Now, how many times have you required to do this kind of a podalic extraction or version in a floating head? Because this patient, Bharti, I must confess to you, this is my real-time patient. In this patient, we had to do this. Suddenly, the baby's head became oblique, despite all kind of planning, and I had to take her by a breech delivery. So yes, you can guide us there.
Dr. Girija, it has happened to me in many scenarios also. And the first thing is, don't panic. If the head just moves away from the center and you're not able to catch a good grip of the head and you're not able to deliver, I think here skill is of utmost importance, and don't be in a hurry because you will be causing more damage. Be gentle. And if you're not able to catch hold of the head and bring it out, you can gently slide your hand along the back or along the front and catch hold of the baby's 2 feet like you do in an assisted breech delivery, and gently bring it down and deliver the baby as a breech using the MSV technique. So I think this should come with proper drills. We need to see that our youngsters are performing drills, because these scenarios just pop out of the blue. And that time there's a lot of panic in the operation theater. Instead of that, you just go down gently, hold the hands and bring it down and gently deliver as you would deliver a breech baby.
Thank you so much, Dr. Sheshasai. Now we are coming to you with Praveena. who is a gravida 2 para 1 at 40 weeks of gestation with an expected baby weight of 3.4 kgs in spontaneous labor. She had an optimal progress, a spontaneous rupture of membrane at 7 centimeters, full dilated for the past 40 minutes now. CTG started showing late deceleration, station is 0, and we diagnosed her to be a right occipital posterior position, first degree molding, and an emergency C-section has been decided. So we are going to encounter quite a few difficulties, and these are something which are happening very commonly nowadays. I don't know if I can ask Dr. Sairam or Dr. Bharti to share with us why this is happening, why so much of OP positions are happening to our lives today. Is it something to do with increased size of the baby or the reduced size of the pelvis? But I think, do you agree to this?
Yeah, I do agree. Probably one is because of the lack of physical activity of it. I don't, it's just an observation, and maternal obesity as well as fetal, bigger babies we are seeing. And probably earlier days, we saw women sitting down cross-legged, that maybe the pelvic diameters were a little larger at those days. I mean, this is not, just an observational study. I could not give you any evidence on this.
Yeah.
But it is very common.
It's quite common. So Dr. Sheshasai, what would you now plan for this baby? Because we are looking at a baby who has molded head, posterior position, impacted deep into the pelvis. In the second stage, nearly going towards the second stage. First stage has come to an end. In the second stage, fully dilated for 40 minutes. And we have to deliver this baby.
It's deeply engaged.
Yeah.
And impacted. So there is no space. So very difficult, because negative pressure also a lot, it won't allow. So when it is there, usually in occipital posterior, deep transverse arrest or POP, persistent occipital posterior, these are the most common. And when we are doing trial labor in a slight CPD suspicion, then also these things are occurring. So when it is occurring, then there are so many methods. Number one, when you pass your hand, spade the web, so the air enters inside, clears, and sometimes the delivery is possible. Another is push technique, and somebody junior will be pushing and we will be pulling from above. That is another method. So third one method is Barton's forceps, which we use as a hinge joint. We'll push it as a hinge, as a shoe horn we are removed. Like that we'll do. With that also we can do. And another one we are doing with a Patwardhan technique. And in that also, as if there is a dry labor or liquor is adequate. If liquor is adequate, then you can give incision at the level of shoulders and hold the shoulder, deliver that one. Later, both hands delivered, then buttocks, then complete head is delivered from below. Or if it is dry labor or obstructed labor with a constriction ring or bandage ring, slightly cut that one, it gives way. Then we will hold the lower limbs, foot, and gradually will drag down, then deliver. And whenever any abnormal incision, we have to straighten instead of T shape. So straightening will cause less complication in future.
Absolutely. So sir has given us an overview of what are the options that are available, and these options cannot just work in the mind of the surgeon, because everybody has to be there, and therefore we have to have a quick recce to all concerned and talk to them. So I would go back to Dr. Sairam to tell us certain pitfalls which we can avoid, while we are taking the incision. Dr. Bharti did tell us in the large baby that you take the incision up. And would you also try to follow the same thing when we are talking of in a patient who has come to us with a deep transverse arrest or an impacted head? So, because many times you must have seen, being a postgraduate teacher, I have experienced this, that they will go and deliver the baby and they said everything is bleeding. We don't know what is bleeding. Many times the incision has been taken very low down, and we want some tips from you to avoid these challenges in the second stage C-sections.
To unmute. Dr. Karpagan, please unmute.
Doctor, you unmute yourself, please. You're muted.
Yeah,
please.
yes, sorry. So basically, I know, as Madam said, the learning curve is very important. And first thing is, whenever we know that there is a deeply impacted head, I think when you open the UV fold, nicely push the bladder down and make sure you have adequate space for the incision, and make sure the incision is very visible within the field. That I would always do. So that, because whenever you put your hand on, obviously the lower segment will tear away like a paper and just go. Your hands will also go when your hands goes down. So best is to have the incision well within the vision eyes in the field, and then we can, as sir was telling about Patvan, modified Patvan, those maneuvers can be done. So the incision has to be visible according to me, because many times we think we'll have nicely put a lower segment, but finally when you put a hand, we'll have a transverse incision extending into the lower segment, or very little lower segment, sometimes into the fornix and also into the bladder. And that becomes very, very tricky to suture and very, very challenging. So I think to avoid, we can definitely have incision slightly higher up.
Slightly higher up and the widest part of the lower.
Girija, don't mistake. Yeah, please finish by 4:20.
Yeah. We'll do it earlier. Don't worry, we'll do it earlier. Okay. Anybody has had an experience of using this fetal pillow among the panelists?
No.
The fetal pillow. That's something which has been spoken of, which can be put in the vagina to elevate the baby up. Now, coming to Dr. Kiran Mai, Sheila at 36 weeks presented with PROM 6 hours as per history. Expected birth weight is 2.8 kgs, AFI is 1 centimeter, augmented with oxytocin, progressed as per the partogram till 8 centimeters, station -1. When had variable decelerations which persisted for an hour despite resuscitation and was taken for emergency C-section. On table, FHR confirmed to be 120 beats per minute. Uterus was full of baby with negligible liquor. So how are we going to now deal with this?
Yeah, basically it's a case of PROM with oligoamnios. The liquor has drained out. So again, ma'am, first of all is preparation, anticipation from our side, and also counseling to the patient attendants. I prefer to tell to a certain extent what are all there are some difficulties expected in such deliveries, because we have faced one very unpleasant situation in such a case. So what I expect technically is the lower segment is not probably well formed, because then the myometrium is thick, and the baby, it is full of the baby, and adequate amount of liquor is essential to act as a lubricant in facilitating a smooth delivery of the baby. So either more liquor or less liquor or absent liquor is going to cause us a lot of problem. So incision, it is not flexible, we cannot stretch it well. So again, the delivery of the head, if it is vertex, to some extent it may be little simpler or easier, because we can use forceps or we can deliver head better, and the rest of the baby is smaller when compared to a preterm baby's head. Whereas if it is a breech, the difficulties are going to be even more. In this case, it is cephalic, so it is we are more lucky. So as you have told, bowels can come and interfere with the operative field. So we should have a good anesthesia. We have to, tell the anesthetist also that we need a good relaxation. Your assistant should be good, and if necessary, fundal pressure, instrumentation, and there can be, fetal injuries. We have had faced with a breech delivery, oligoamnios. Baby had a shoulder dislocation or a fracture, which, because it was not explained prior, the father of the baby had gone ahead and he had put a case on the obstetrician. So the obstetrician had to, though it was in the public sector, she had to face almost 1 year of nuisance and court case, because he told, I was never told about this point that baby will be injured or anything like that. You have injured the baby. So the tissue injury, baby injury is very, very important. The counseling part is important, and involving the pediatrician also is important. Again, this is only 6 hours of PROM. If it is more, again, I would be more cautious about atonic PPH, chorioamnitis, and uterus will not be retracted easily. So that is rarely seen, but once, if it is seen, it is very difficult to handle the PPH.
Absolutely. Thank you, Dr. Kiran Mai, and especially an important message that it will be not only asphyxial injuries to the baby, but it can also be physical injuries, and you have to therefore be on guard. Dr. Krishna Kumari, Meka Madam, Veena, Primi Gravida with GHT diagnosed at 28 weeks and GDM detected at 32 weeks is now at 37 weeks in the ICU. For severe COVID infection, now on the ventilator day 6, with high D-dimers, fetal vigilance with NST daily and handheld Doppler, 2,900 grams baby, reactive NST. Mother has developed multi-organ failure and the decision of crash C has been taken. What are the prerequisites of a crash cesarean section?
Good evening, Dr. Girija and everyone. It's nice meeting you here. So I think when we are talking about a crash cesarean section, it is that you have decided that it is going to be risky for the mother or the fetus, then we have to finish the cesarean section in the next 30 minutes. That is what. And when we are actually looking at the categories, it belongs to the category 1. Here, but then the fetal circulation is still maintained. That's what I see, because the fetal heart is still going good. So now we have decided to take the patient to the theater for an immediate cesarean section. In the very beginning, we had a huge checklist which was described for the routine cesarean section. Somewhere down the lane, I think we have to cut short the checklist, make a quick assessment of what is already been fitted into when we are looking at a crash cesarean section. And the technique of doing the cesarean section also has to be, usually we go by the Joel Cohen incision and then try to finish it as fast as possible. And prior to that, I think we are also it is very important that we, two things which we are going to take up in this particular patient is the counseling as well as the consent. So as far as the consent is concerned, I think much before she has been ventilated, she's already been on the ventilator for the last 6 days. So before the ventilator itself, now the patient consent cannot be taken. So if proxy consent, if the consent has not been taken before, then we may have to take a proxy consent by one of the close relatives. But the consent which is taken before ventilator cannot be a blanket consent. So it has to be very specific consent which we are taking when we are going ahead. And for the consent to be given, we need to have a very thorough counseling. And of course, when we decide for a crash section, again, there is a time restraint on the amount of counseling that we can give to them. So I think these things should go parallel with each other. One person takes care of the C-section, somebody else takes care of the counseling. So it's a whole teamwork.
Absolutely.
Including the intensives, the nurses who can even start the green code, who will and keep everything ready. Everything has to go parallel hand, including the administrative staff of the hospital have to be involved, and if possible a video counseling to the attenders. You can make them sit together and then take a proxy consent. And then as far as the outcome is concerned, I think it's very difficult to say. If we have a SOFA score with us, then probably based on the SOFA score, we can give a prognosis for the mother. Her situation might be better once we do the C-section, because we can put her in the prone position, the drugs, the medication, the resuscitation, everything could be made much easier when we are going ahead with the, and the response to a multi-organ failure can be good or bad. It is depends again on the the prognosis depends on how the patient is responding to your treatment further. Then as far as the fetus is concerned, yes, the neonatologist is the one who is going to talk to the attenders and see the umbilical cord pH has to be done, and then probably they will take care of the baby from there. And as far as anesthesia is concerned, the anesthesiologist also should be the one to take a separate consent. Although the patient is on ventilator, there is a slight difference in their drugs which they are going to give, and then how we go about it. And of course, the rest of the precautions which we do for a routine cesarean section is to be taken care of.
Thank you so much, Dr. Krishna Kumari. And we can see that, like crash cesarean sections can act as marriage in haste and repent at leisure. So what she's given us a wonderful recap that we have to do a proper checklisting and counseling parallelly, not forget our responsibilities of doing, because we may invite a lot of air and the whole likelihood of things not going right in this particular situation. So coming to Dr. Somalata, Seema is in labor 39 weeks with GDM GHT, admitted in spontaneous labor, progressed to active phase, and at 6 centimeters ARM was done, which revealed thick MSL. Emergency C-section was taken, baby of 3,500 grams delivered, swiftly placenta delivered. The pelvis was filling up with blood and the incision margins were caught with Alice to reveal the active spurter on the left side, which was held with a green armitage forceps, and the right side showed a hematoma, which was increasing beyond the angle of the incision. The edge was held with Alice's forceps. What next? And how to tackle this, and could this have been prevented?
Thank you, Girija ma'am. Actually, this is a clear-cut case of the extension of the angles, and the section is done for the second stage section and done for thick meconium stain like. First, immediately we should call for help, inform the anesthetist, any senior colleague, vascular surgeon, and blood bank also to arrange the blood, and just better to exteriorize the uterus to see the angles well, and we should also look for the
think
retracted.
you lost Somalata, or have I lost her only? Yeah, your voice, Dr. Somalata.
She's audible.
Can you hear me, ma'am?
She is audible, madam.
You're audible.
Yeah.
You're audible,
Yeah.
Somalata.
Can you hear me, ma'am?
Yeah,
Yes?
yeah, yeah.
Okay,
Yes,
okay,
yes.
yeah. So after alerting the whole team, meanwhile, we should try to exteriorize the uterus and see the angles first. And sometimes the blood vessels are also retracted, and try to catch them. And after exteriorization, we should cover the fundus with the wet sponge, which are the basic things. And we will see whether the hematoma is extending. And in case of any try to ligate the vessels. In case of any retroperitoneal hematomas, go for uterine artery ligation. This is the next step we are going to do, and meanwhile alerting the other vascular surgeon.
Can you give us any tips of how to do the uterine artery ligation here? Because she's bleeding now. There's a hematoma. So one, you told us that exteriorize the uterus, but then how do you actually take the uterine artery incision?
Yeah, in the means like just the lateral part of the incision, we will take a bite, and we will come out and tie that side, madam. Again, again we will take one more bite at the round ligament region.
Round ligament would be the ovarian artery.
Lower down.
Yeah, yeah.
Lower down.
First,
The lower
most
down.
lower down.
Lower down.
Anybody would want to add to this? Any of the panelists would like to add?
Well, when see in an alarming situation like this, the first thing is you try to exteriorize along with some sort of an aortic compression you could ask your assistant to give to reduce the blood flow, and then an aortic tamponade, and then when you exteriorize the uterus, go down to the cervicovaginal junction and first immediately try to compress the bleeding, to stop the bleeding first, and then you try to put your green armitage forceps and then take the bite posteriorly, come to the avascular area on the other side and try to ligate the bleeders there.
Absolutely.
So if you compress the bleeding first, your panic and the patient is stable,
the green
you don't panic.
Yeah. Anybody else would like to comment on this? Additional info? Because this is something very common. Recently, today morning, we had 2 sides uterines, flying off. So
And
basically,
also
till anybody says it, I think the most important thing which all our PG teachers have taught us is put your fingers behind the broad ligament and elevate it, because you are elevating the uterosacral so that it becomes visible, and then you take the thing through and through the body of the cervix or the lower uterine segment, whatever that is, and tie it off. Immediately you do that, the uterine artery gets tied, because when it's bleeding and when a hematoma is forming, you may not be able to locate it correctly. And if the hematoma is increasing, despite what Madam Bharti told us, then you may have to go in and do an internal iliac ligation. Or maybe, you have to dissect the hematoma and actually class the spurters and then take care. So these are the 2 very important things. Yes, anybody is wanting to say something?
No, it's somebody else.
Okay, we come to Vaishnavi. Vaishnavi, G4P3, while performing the 4th cesarean delivery, the abdominal and the uterine incisions go well and the delivery is uneventful. As we prepare to close the uterus, we notice that there is a rent in the bladder 5 centimeters long, and you realize that the injury likely occurred before you made the uterine incision at the time you mobilized the bladder from the lower uterine segment. Now, how do we repair this? A bladder injury is a very common thing nowadays happening because of many repetitive C-sections. So how do you tackle this? Dr. Vaishnavi?
Yes, ma'am. First of all, thank you for this opportunity to be able to speak here. And regarding this case, this is a case of bladder injury during a cesarean section. And fortunate that it has been recognized on table. So that's a good thing. And as obstetricians, we should be ready to tackle such situations because it is very common, and bladder is something that can get injured so frequently, like around 0.3% in a primary section and 0.6% of incidence of bladder injuries in repeat cesarean section. And this being a gravida 4 para 3, so the likelihood of a bladder injury is even more, as the number of previous cesarean sections are also high. And regarding the repair of this particular injury, this is like 5 centimeter at the dome. So it should be repaired in 2 layers using an absorbable suture material, preferably 2.0 or 3.0 vicryl. And the integrity of the repair after closure should be checked by inflating the bladder through the Foley's with some kind of a contrast dye, or saline at least. And then if the integrity is not, if there is a little seepage or leak, something like that, we can put another layer of sutures. And the Foley's catheter after closure, after abdominal closure, should be left in situ for around 14 days. And every 3 days, like around 72 hours, the urine culture for sensitivity should be sent. And regarding the, is that okay, madam? Can I go to the preventive part of it?
Yeah, go to the preventive part.
Yes, ma'am. Like how it can be prevented is, first of all, like bladder injuries are something that should be anticipated, and proper planning of our site of incision. Like if the bladder is adherent to the lower uterine segment, probably we can go to the upper uterine segment and make an incision and proceed with the delivery of the baby. And if we feel that the dissection of bladder is still feasible, then we should make gentle traction on the tissues and find the cleavage plane and make sharp dissection instead of bluntly or pushing the bladder down. So that will send the bladder safely to the safer zone. And next thing is identifying the injury intraoperatively. Like if we visualize an injury, we should repair it. And if we suspect an injury, then we have to assess like what kind of injury it is. If it is in the dome, it is probably feasible for ourselves to repair. If it is going to be extending posteriorly or into the base involving the trigone, or we suspect a ureteric injury, then we should be calling for help. Like we will need the assistance of an expert, like a urologist or someone to tackle the injury and get it done on the table.
Absolutely. So are there any controversies to what Dr. Vaishnavi said, like catheterization for 14 days? Yes, Dr. Bharti, want to
Dr.
It can be 7 days,
is,
madam. It can be reduced
whenever
to 7 days.
Whenever there is a bladder injury, first thing is don't get worried. The bladder is the most easy organ which is going to heal if repaired properly. And I think as obstetricians, when we all know hysteroscopy, we should also learn the art of a cystoscopy. That's what I do in case there's a bladder injury. Even when we are doing our non-descent vaginal hysterectomies, we try to put a cystoscope and verify, even though it is in the dome, just make sure that you're nowhere near the trigone when you're closing the bladder in 2 layers so that there's integrity. And I think with the technology in the Foley's catheter and doing the cultures every 3 days, I do not follow that protocol. That's one thing. The second thing is I think 7 to 10 days is an adequate time. You could remove the catheter.
Yeah. Absolutely. Maybe if it's in the trigone area, naturally it's going to be the urologist who is going to be involved, and we will follow the protocols as per. Now, sometimes you would have this kind of an incision, you'll have a bladder flap hematoma, and this would be presented with pelvic pain shortly after undergoing a C-section. And therefore, I think hematomas, whether they are in the bladder, UV fold, or in the muscle layer, we have to be very careful. Anybody would like to give us a quick recce on this as to how do we tackle the hematomas? What are the 3 sites? I would say that because this is not put in our pre-questionnaire and discussion. One is the UV fold. Second thing is we've already finished the broad ligament hematoma, the muscle hematoma, and the incision hematoma, especially the phalansteal incision at the right angles. I think these 3 hematomas we should be all aware of. So can anybody just talk about how do we go about checklisting after you've done the C-section to check these things? Because this particular patient which you're seeing here has gone through a lot of agony for 8 months after C-section with that hematoma, waiting for it to resolve and giving her a lot of dysuria and, mental discomfort also, because all of us are worried. And Anybody?
Well,
yeah.
Can I take the question?
Yes,
Well,
yes.
thank you, Dr.
Well, we
Girija.
don't have time.
First thing is, I think we can prevent hematomas by taking the protocol of giving injection tranexamic acid prophylactically in all your cesarean sections, more so when she is in a prolonged labor. That may prevent some amount of hemorrhage. The second thing is, don't go for blunt dissection when you're dividing the blood, pushing the bladder down. That can tear the vessels and lead to these hematomas, which may be appearing later. And then the third is, when you are closed, before you close the abdomen, you just do a clean check and see if there are hematomas in the bladder, in between the UV folds. I think we need to pay attention to that. Small bleeders can be, if you're confident with the electrocautery, you can cauterize them and leave them. And of course, sometimes I do use an abgel. If there are small oozings, I do place an abgel there. And the other thing I have noted is, when you do not close the UV fold, your incidence of these adhesions and hematomas are comparatively less. So you should refrain from closing the UV fold.
Yeah.
And so when you come to the phalansteal incision, if you have done a muscle cutting, I think you'll have to spend a few moments to see if there are any bleeders, isolate them and ligate them.
Absolutely.
Just don't give a cursory look and say it is going to stop. Don't worry, it will stop.
Absolutely. So the lateral angles of the phalansteal incision can be extended bluntly, and do not use scissors blindly. I think that is another thing which I would like to add. And while you're separating the muscles, don't separate the muscles. Open the peritoneum, and from inside the peritoneum, open the muscles, especially in
together.
Put
them together.
So that you don't injure the muscle bed from inside, which may cause hematomas. So there
and it reduces a lot of pain also. When you do that, there's no postoperative pain.
Absolutely. So we are having just two evidences, which I'll share at the end. These are reviews on techniques for assisting difficult delivery at C-section. And they have mentioned, the authors have said that there are limited evidences, and therefore we have to be careful and be aware all the time, and maybe extrapolate and collate our own data to come up with what's going to be really right. But as our experts have displayed here, all situations are unique, and therefore we have to be always with guard. And maybe, as Dr. Bharati said, we must always have the drills. And then the second question was, is duration of passive second stage associated with a risk of hysterotomy extension during cesarean section? And the risk of a hysterotomy extension does not appear to be associated with second stage obstetric characteristics, including the duration of passive phase of this stage. In the center that it was studied, they said that delayed pushing, prolonging this passive phase beyond 2 hours, does not increase the risk of hysterotomy extension in the second stage evidences. So these were the two last evidences that I felt. And I want to thank the doctor who shared this difficult cesarean section, a literature review, and this can be your take home here for all the delegates. You can take a picture of the screen and please go and read this, because they have summarized a review on difficult cesarean sections. With this, we close this panel, and with all the gratitude to this is Dr. Sheshashai who had shared this with us, and I request all of you to please refer to it. And we have to remember that usually it can be a technical difficult situation, and therefore don't be complacent, and always be on guard, and always have your checklisting and planning in the mind to be able to overcome these difficulties. And they can be well overcome by foreseeing, and therefore constantly updating your knowledge and reviewing is important. And I take this opportunity to thank each one of you for helping me win my Vice President Foxy elections with stupendous votes. And I also put my hands across to all my panelists, and I wish all of you please clap to them virtually for giving us such wonderful disposition on the difficulties in C-section. And thank you, Dr. Sampath Kumari, Madam, and I hope that I have done justice to the topic that you requested me to take.
Thank you, Dr. Girija and Dr. Sampath, and all my co-panelists.
Thank you so much, madam, for the opportunity. Thank you so much, madam, and all the panelists.
Thank you. Thank you, Girija.
Thank you, madam.
Thank you, sir.
Thank you, Dr. Sampath and Dr. Girija and all the panelists. Thank you so much.
Connecting to all of you. Very happy to connect with you all.
Thank you.
Thank you.
Thank you, Girija ma'am, for the wonderful cases, and the panelist interaction was also really, really wonderful. Thank you so much. We move on to the next session. It's my pleasure to invite our chairpersons, Dr. Pramila Menon ma'am, who is a professor in Amala Institute of Medical Science, Thrissur, Secretary Society, and past editor of Kerala Federation of ObGyn Society. She has received various awards. Welcome, ma'am.
Hello, good evening.
It's my pleasure to welcome Palniappan sir, who is a professor and unit head of Ramachandra Medical College, Chennai, and sir has received various awards: Indumati Javeri Award, A.L. Mudalia Traveling Fellowship, Senior Overseas Fellow, Sydney. He was a Kamnira orator, young gynecologist awardee from AFOG, invited speaker in many national and international conferences, a joint secretary of AACOG 2015. Welcome, sir. Our next chairperson is Dr. Ganga ma'am, who is the president of
Madam Kalale introduce Panta Kalpana.
Okay.
Dr. Palniappan.
Thank you very much, Dr. Kalpana, for those lovely words. And thank you, Dr. Sampath Kumari and Dr. Anjalakshi for putting us and connecting us through the 79 societies of Southern India. And without wasting time, I'm sure everybody is waiting to listen to the Dawn or the Doyen speak on. And so over to the next speaker, and that will be none other than Professor Sir Arul Kumaran. He is a Professor Emeritus of ONG St. George's University of London, Foundation Professor of ONG University of Nicosia, Visiting Professor Institute of Global Health Policy Innovations College London, and past President of the FIGO, the British Medical Association, and the RCOG. And he was appointed the Knight Bachelor by Her Majesty the Queen. And apart from these 4-5 lines written over here, he is an absolutely humble human being, and that's the most important message which all of us need to take. And he is accessible to anybody and everybody, and he's been absolutely kind enough to the Indian subcontinent, or he's probably half Indian, and that's what should I say. And I should not comment on his age, but I should comment on his wisdom. The thing is that any paper which was released yesterday, that could have been updated by Prof. Arul, and that would have come to today's slides, you know, and that is how his updation of knowledge is. And he's truly an inspiration for any of us at any age and from any part of the world. And I take immense pleasure in inviting Professor Arul Kumaran to give this keynote address. Over to you, sir.
Thank you. Thank you very much, Professor Palniappan and Professor Sampath Kumari and the other chairpersons. It's a great pleasure to be here. And thank you, Palani, for the kind words. I've known him for 30, 40 years now. So he has matured quite a lot and not changed. Thank you, Palani, for the kind introduction. So when Sampath Kumari wrote to me, I thought I'll just take a topic which is coming into current context in the UK, and that is actually to do with whether we should test people on CTG knowledge or competence before they are put on the labor ward to monitor patients. So this is something which is worrying. The reason it is worrying is the Royal College of Obstetricians and Gynaecologists spent a lot of money for 4 years, 2017, 18, 19, and 2020, looking at babies born either stillborn at birth or early neonatal death within 24 to 48 hours, or had cerebral injury with HIE and subsequent injury. So this is called the Each Baby Counts program, and this is the final report in 2020. And just to take as an example, there were 651,000 cases born in the UK in 2018. And of these 651,000 babies, 1,145 babies had some injury of some sort, and 687 had detailed inquiries. This is the detail from 2018, for example. 11% were intrapartum stillbirths, 14% were early neonatal death, and 75% had brain injury in the form of HIE. So out of the total number of nearly 600,000 babies, 1,145 babies had some problem due to birth asphyxia. Now, when they analyzed these things in detail, there was a complexity of reasons. And if I may show you by the arrow, you can see the overshadowing things, problem with CTG and blood sampling, risk recognition, whether babies were growth restricted or not, team communication, education and training issues, and individual human factors. Now, this lightly colored graph shows it's a complexity, one mixing with the other. For example, if you take education and training, there were purely 11, but in addition to CTG misunderstanding, it was 4. And if you take the other human factors, it is 5 and so on. So it's a complexity of these 5 factors: risk recognition, whether a baby is post-term, has meconium, bleeding, etc., whether the CTG can be interpreted properly, and whether we are doing the education and training. But the most important thing is whether we are doing any assessment. So following this, there's a surge of activities in the hospitals, in the NHS, National Health Service, to do CTG testing. Now at St. George's, where I work, we have introduced the CTG testing for a long time. We have 3 components. One is whether the midwives and doctors are able to recognize patterns, whether it's normal, suspicious, or abnormal. Secondly, whether they understand the pathophysiology behind it. Why is the change? And thirdly, given a clinical case scenario, how are they going to act? So taking the risk factors and the CTG, how can they plan the management? So normally this is the answer sheet. They are allowed to give the name, the position, date of the test, and we tell them to read the CTG NICE guidelines. And as we mentioned, we always tell them that section A will be pattern recognition, section B will be understanding the pathophysiology, and section C is situational analysis with the CTG. And we give them 8 questions in each of those. So I'm going to go through with them one by one. So the idea is actually in your own hospital to devise these tests yourself. So we give a test like this and say the above CTG is normal, suspicious, or pathological. As you know, it has good accelerations, good variability, no deceleration. So it has to be normal. So it's a very straightforward question, straightforward answer. If somebody says suspicious or pathological, then that's worrying. So you have to know first. The second is saying the above decelerations are early, typical variable, or atypical variable. So here what happens is the typical variable has shouldering, as you can see. And also if you draw a vertical line from the beginning of the contraction, end of the contraction, it'll fall within those 2 lines. And it's a precipitous fall and rise. And there is no rise in the baseline rate, and the variability looks okay. So these are typical variable deceleration. So given that, if they continue for more than 90 minutes, would you classify as normal, suspicious, or pathological? We will classify as suspicious or non-reassuring, because if there is no shift in the baseline rate, and if the decelerations don't get prolonged beyond the end of the vertical line here, then it is suspicious. So that's the answer we expect. If that is given in a diagrammatic way, so variable decelerations initially, typical will fall within these 2 lines at the beginning, at the end of the contraction. As time goes on, if the baby is getting hypoxic, there's a rise in the baseline rate slowly, and there is a increase in depth and duration of the deceleration. So the deceleration falls outside the vertical line of the contraction, and the interdeceleration intervals get shorter. And finally, the variability gets absent. So that's the principle. So based on that, the next question is the deceleration above early, typical, or atypical. So as you draw a line from the beginning of this contraction to the end of this contraction, the deceleration is outlasting the contraction end. So these are atypical variable deceleration. And if they're atypical, then the chances are the interdeceleration interval will get shorter and shorter, and the baseline rate will go up. So this is pathological trace, and we have to observe. And once the variability is absent for 1 hour, we have to take action. So they have to know it's a pathological trace. Next question is, how would you classify these decelerations? Reassuring, non-reassuring, abnormal? Very obviously abnormal. If you draw a line at the beginning, at the end, the decelerations are lasting a long time, and the baby is spending more time under the water, so as to speak. So the cardiac output during a period of 10 minutes is reduced so much, the baby is going to run into trouble. So we'll classify that as pathological trace. Now, there are some confusing traces. For example, these as accelerations, and variability is reduced, but accelerations, they are present, then it is not a pathological or suspicious trace. It's classified as normal, so they should identify it as normal. And these are called early, late, or atypical. So you draw a line from the beginning of the contraction and the end of the contraction, and these fall within those lines as shallow deceleration, 40 beats less than the baseline. So these are early decelerations and should occur in the first stage, late first stage, or second stage. So these are normal for this pattern. If it is late first stage and second stage, these are early. Now, this is called a pre-terminal, where there's absent variability and very shallow decelerations. So they should recognize immediately that this is a pre-terminal trace. And this is late decelerations, as you could see. If you draw two vertical lines, the deceleration is falling outside this line. So they should recognize this as late, and they should make it as pathological. So this is what we mean by pattern recognition. So these are the 8 questions, but you can pose any other CTGs and ask similar questions. Now, the second section is whether they understand the pathophysiology. So this they have to write in written form. And please explain the significance of accelerations and the meaning of a reactive trace. So accelerations are corresponding to the somatic nervous system activity of fetal movements. And reactive means there should be 2 decelerations in a period of 15 minutes. And each deceleration should be 15 beats above the baseline for 15 seconds. So that's the answer they should give. And what causes variable deceleration, and how would you respond when there are such decelerations? Well, variable decelerations are thought to be due to cord compression, and you have to alter the position of the individual to see whether we can get rid of the variable deceleration. Put on the side or sit her up to see whether the... Third is, what does cycling in a CTG trace mean? So that means the segment of accelerations and good variability followed by a sleep phase, then again a segment of accelerations and good variability. So they should be able to explain that. What does that mean? And that means the baby's brain is working well. The behavioral state of the brain is good because of the sleep active cycle. Fourth is, what are atypical decelerations and what is the significance in interpreting a CTG? Atypical means the ascending limb of the deceleration outlasts the end of the contraction. That means as time goes on, the interdeceleration interval is getting shorter, and you have to observe a rise in baseline rate and reduction in variability. What are late decelerations and what is the significance of interpreting? So they indicate placental insufficiency, and that means you have to observe, and once the absent variability starts, within 1 hour, you should be able to deliver. Unless she is only 3 or 4 centimeter, primary gravity, you don't want to wait too long, or if there's meconium, you take action immediately. What is prolonged deceleration? How do you act? That means less than 80 beats for more than 3 minutes, and you have to divide that into irreversible and reversible. Irreversible is abruption, scar rupture, and cord prolapse. Reversible is due to hyperstimulation, and when you encounter, you will act according to the underlying pathology. Give 4 reasons to reduce variability, less than 5, then you have to say absent variability or reduced can be due to fetal sleep state, pethidine, or some medication. Corticosteroids can reduce the variability, magnesium sulfate to some degree, so they should be able to give that reason, as well as hypoxia if it is associated with decelerations. And the 8th question on pathophysiology is, what's the significance of continuously rising baseline rate on auscultation, and how would you respond? So that means it is a catecholamine which is driving the baseline rate up. And how would you respond is to put on a fetal monitor to find out the other features of the CTG. So the third phase of the test is like this. You give a trace and give a clinical scenario. A woman with the previous section in labor is 6 centimeters dilated. She's on oxytocin and continuous EFM. Please see the CTG above. What do you see and how would you respond? So that means there's a sudden bradycardia. Most likely, it's a scar rupture. So you have to do a category 1 section. Question 2 is, there are variable decelerations with the heart rate nearly 160. So it says 32-year primary gravity, 6 centimeters dilated, not on oxytocin. She's in spontaneous labor. Baseline fetal heart rate at the beginning was 130, and she had no decelerations. Now she has plenty of decelerations. Describe the CTG and action you would take. So you'll describe baseline 150, 150, 60, absent variability, and atypical variable decelerations. And This is a pathological CTG, and since she's a primi-gravid and 6 centimeters, she needs to have a cesarean section done because she's on spontaneous labor. The next one is a 28-day gravida 2, spontaneous normal labor, active second stage of labor, monitored for audible abnormality of the heart rate and converted it to electronic fetal monitoring, and describe the CTG and explain how would you act. So you had to explain the CTG has a tachycardia of 160, has atypical variable decelerations, little interdeceleration interval, likely to be a cord problem, expedite by instrumental vaginal delivery. There's one or two small questions. 30-year primary gravid on oxytocin for poor progress. She is 5 centimeters dilated. Her maternal observations are normal. Describe the CTG and describe action you would take. CTG has variable decelerations, but has too many contractions. So the answer is to stop the oxytocin and observe, and the further decision has to be made on subsequent trace and management based on contractions and the fetal heart rate. And this has hardly any variability with the tachycardia, but it's in a 28-year-old mother with history of gestational diabetes controlled on diet, comes at 37 weeks with a history of reduced fetal movements. CTG was performed and is shown above. Please describe CTG and what action. So tachycardia with reduced variability may be due to poor blood sugar control. So you have to check and correct blood sugars, and the CTG might revert to normal. If it doesn't, if the blood sugars are normal, then you might have to do an amniotic fluid and also a Doppler to see what else is going on when the CTG is abnormal. And this one shows what is called accelerations, but is coinciding with the contractions. So the clinical story is the gravida 3 para 2 with a history of raised blood pressure in the active second stage. Head is seen at distance when she is pushing. About race was witnessed. Please describe the CTG and state what actions you would take. So here the actions you would take is actually accelerations coinciding with the contractions in the second stage, likely to be maternal heart rate, because in the second stage, if it is accelerations coinciding with the contractions, it is most likely maternal heart rate. So you have to really check whether it's maternal heart rate. Otherwise, you might be monitoring the mother and not the baby. And this one shows prolonged deceleration with an exaggerated variability in a gravida 3 para 2 in the second stage. Head is in OP position. She's actively pushing in the second stage. Describe the CTG and what actions should you take. So this is a subacute hypoxic pattern. It is spending a lot of time below the baseline, very briefly, less than 1/3 the time at the baseline. So the pH will drop at 0.01 every 2 to 3 minutes. And most likely it's due to occult cord compression or cord around the neck and cord getting stretched as the baby descends down. So here the acidosis will develop rapidly and you have to expedite delivery. And here the baseline is 110 with accelerations and good variability in a 28-year gravida 1 gestational diabetes controlled with diet. Describe the CTG. Well, the baseline rate shows moderate baseline bradycardia, but accelerations and variability are normal. So it is a non-hypoxic fetus. The only thing you have to do is to make sure that this is the fetal heart rate and not the maternal heart rate. So in concluding, the tests are done in 3 sections. One is pattern recognition, second is pathophysiology, third is clinical situation escalation, and practitioners should achieve at least more than 80% of the marks. If less than 80%, then they should be directed for further reading or e-learning package or master classes. They can resit the test and have till that time, they have to have a senior person to help interpretation in the labor ward. If it is a normal CTG, they can call somebody to check it every hour. If it is suspicious, every 30 minutes. If it's a pathological, every 15 minutes, because the patient should not be jeopardized by the lack of knowledge of an individual. Maybe in certain areas there is weakness, and this can be cleared by one-to-one attention and tutoring, because sometimes they might make the same mistake again and again. By clearly explaining, they get the marks better. And usually if you have a central screen in the labor ward, all the traces can be seen in one screen. That'll help. So the test CTG cases and questions should be changed every 6 months. And it is ideal to have a dedicated midwife or a doctor to teach and conduct the test and identify the newcomers. So as the newcomers come, You give them a tutorial and ask them to do the test. Repeat test 6 monthly and new questions they should achieve 80% in the new test. So like pilots, they go for a testing every 6 months. So why should the doctors and midwives not have a test on a thing which they do on a regular basis and they can do better? So that's all I had to share. I'm happy to answer any questions. This can be done electronically, these tests, or can be in a classroom situation. Thank you very much.
Thank you, Prof. Arul, and that was fantastic. And I'm sure all of you would rejoice the way of the presentation which Prof. Arul did. Just like how we have idlis every day and bread and butter every day. Anytime we listen to Prof. Arul on CTG, we come out with new points, and we always come out very happy to ask questions and have a interaction with Prof. Arul, and it has been fantastic, sir, and having you with us. And thank you very much for that lovely lecture, because every time you come out to the CTG, you put something new, and we are extremely happy that the way how you put on to. And I'm sure we'll have questions for Prof. Arul. Dr. Kalpana, we take questions now, or we move to the next?
Later. Now, at present, there is no question. Thank you, Arul Kumaran, sir.
Thank you, sir. Thank you
we
very
will be
much.
like a pilot.
Thank you. Fantastic. And we're all passengers sitting on your shoulders.
Thank you.
Thank you very much. And now I would call Dr. Pramila Menon to introduce the next international speaker, Dr. Ravichandran. Dr. Pramila, I'm so jealous of you that you're going to introduce Dr. Ravichandran, who's been my friend for a very long time. Over to you, Dr. Pramila.
Thank you, Palniappan sir, and thank you, Sampath Kumari madam, for hosting, for calling me, giving me this opportunity, and congratulations to the whole team for putting up such a good show. And as sir said, Ravichandran sir is somebody close to our heart also. He's a speaker in our Toxicon usually. And I still remember his talk on dengue in pregnancy, I think in the pre-COVID area where we had the Toxicon. It's still green in my mind. He gives such a clear cut concepts regarding each and every topic which he deals with. And I think he needs no further introduction. He's the National Head of Obstetrics and Gynecological Services and Fetal Medicine, and he's the renowned speaker in this field. And today he's going to clear our doubts regarding hypothyroidism in pregnancy. I think there are lots of confusion still going on, whether to test, if to test, what should be the cutoff. And I am sure at the end of his talk, we will have a crystal clear idea regarding what to do. Over to you, sir.
Ravichandran, sir.
Yes, I'm here.
Yes. Welcome.
Right. Can you see my slides?
Yes. Parkalam. Parka mudiyudu.
Very good. Vanakkam, and thank you very much for inviting me again. And I must say I have developed withdrawal symptoms of not visiting India. I hope this is put to rest soon. Thank you very much, Dr. Palniappan, Dr. Pramila, and Prof. Sampath for inviting me. A very good evening to Prof. Arul. Good to see you again. Now, it's raining very heavily in my city now, so there may be some connection issues. So if I'm a bit hypothyroid, it's not because I'm hypothyroid, it's because of the connection. All right, with that, we will start. Okay, I was given the task to talk about hypothyroidism in pregnancy. And I thought the best thing was to first let you know and remind you where I stay. I stay in Johor Bahru, just north of Singapore, all right? And of course, this is the beautiful hospital where I work. This was the first hospital where Zika came into Malaysia, and this is also the first hospital where COVID came into Malaysia. This is a very historic hospital. You all should come and visit. And I thought before we go into the whole topic of hypothyroidism, we all can be a little hypothyroid, and let's just revise and recap very quickly, all right? So basically this is the thyroid gland, and in the thyroid gland, there are colloids and there are follicles and there are parafollicle cells. And basically the mechanism by which the whole thyroid hormone is stimulated, it starts from the hypothalamus, the TRH, and then it goes to the anterior pituitary and it moves around. Okay, now the important thing that you need to realize here is that there is also a negative feedback mechanism, and that is the one that influences TSH secretion. So that is important to be reminded of. So the whole process of thyroid synthesis is, I put here in a very big way, but just remember this: iodine uptake, the oxidative process, iodination, conjugation, and then the production and storage. So all this will occur before we can have this hormone available for us to be used. Now, and you must also remember that this thyroid needs a vehicle, okay, needs a vehicle to move. So the common ones is the thyroxine binding globulin, and then we have the thyroxine binding prealbumin, you have albumin, and then the unbound, there's the free ones. The free ones you will notice is actually very little, and the majority of them is bound to the thyroid binding globulin. So in utero, what happens? Okay, now the origin of the thyroid gland is and by 12 weeks, actually the fetal thyroid is matured. Okay, or rather it's already formed, and slowly the maturation process occurs. So if you look into this chart here, you will see initially the mother has to support, then the fetus takes over, but nevertheless, the iodine still has to come from the mother. So this is where at about 36 weeks, the Wolff-Chaikoff mechanism comes into place, whereby the amount of iodine that the fetus is going to take on board will be stopped and controlled so that there's no excessive production of thyroxine in the fetus. So the physiological changes of thyroid is something that I think we must remind ourselves again. Now we must remember HCG does stimulate the thyroid, and that is the reason why when patients come with molar pregnancy or partial mole, we tend to look for thyrotoxicosis because of the effect of HCG on the thyroid hormone. The other thing that we need to know, and particularly be wary of, is the role of estrogen. Estrogen increases the amount of thyroid hormone binding properties. So hence, this can actually increase the total thyroid hormone levels, but fortunately, the free thyroid hormone levels usually remains within norm. So if you're looking at the metabolism of T4, it's raised in the second and third trimesters due to the deiodinases that are present in the placenta. And this affects the conversion of T4 to T3 and T3 to T2. Now, these plasma iodide levels also increase because of the increased thyroxine metabolism and increased renal iodide clearance. Now, all these changes actually can lead to a rise in the thyroid gland, and hence we will always have this terminology, physiological increase of the thyroid gland in pregnancy, and about 15% of the pregnant women actually can have this condition. So now if you look into the terms of the fetus itself, you will find that I told you by 12 weeks the gland is formed and the thyroid begins to function. So if you look at it, you will find at conception, it's only the maternal thyroid that provides the hormone. And by 12 weeks, the fetus begins to generate its own. And then from about 24 to term, the maternal and fetal thyroid hormones tend to work together. So this graph, you must basically remember how the fetal free T4 is, and then the maternal free T4. And remember this, the maternal TSH, because that is one of the hormones that you and I can monitor. So what are the action of thyroid hormones? Basically, it involves in a lot of processes for the fetus. So any impairment of this thyroid hormone is definitely going to impact on the development of the fetus, because you can see brain maturation, bone maturation, growth, thermogenesis, myocardial contractility, hepatic maturation, and skin maturation. This happens in the extrauterine life, but this happens in the intrauterine life. So why does hypothyroidism occur? It can be primary, and the primary one, of course, can be autoimmune, postpartum thyroiditis, iodine deficiency, thyroid surgery, radiation, and drugs. This should be around here at autoimmune. Now, in hypothyroid pregnancy, the percentage may seem not to be very significant, 0.3 to 4.8%. It varies globally. But the majority of the cause is due to the autoimmune destruction of the thyroid glands. Okay. And Hashimoto's is one of the ones that commonly point a finger to. Of course, we can have iatrogenic, radioactive iodine, and patients on lithium for their psychiatric issues and things like that. Partial thyroidectomy is a total thyroidectomy can, iron deficiency, and the list just continues. So basically, I'm going to use as a reference our Malaysian CPG on thyroid disease, because maybe we can compare later and see what's happening. Okay. So our definition in the Malaysian CPG is how we define maternal thyroidism, hypothyroidism is elevated serum TSH during pregnancy, beyond the upper limit of pregnancy specific range. Okay, so overt is when there's a decreased serum free T4, and subclinical is isolated high TSH with the free T4 within the accepted range. Okay, so this is where we have to be very, very clear. We cannot afford to be hypothyroid when we are managing our patients. We have to be alert, because the subclinical hypothyroidism is the one that you and I commonly miss. So basically, if you look at this definition by Mirhani, hypothyroidism in pregnancy can be divided into pre-existing, that means underlying, or primary maternal hypothyroidism that we detect in pregnancy. It can be overt, it can be subclinical, it can be isolated hypothyroxemia, and euthyroidism, which the that we encounter is this too. So what are the risk factors for maternal hypothyroidism? So who are the people who can actually develop maternal hypothyroidism? Those who have history of thyroid disease, those who have a goiter, so you must check. Known with previous history of thyroid antibody being positive, 30 years old, type 1 diabetes or any other underlying autoimmune disease, history of pregnancy loss or preterm deliveries, history of infertility, morbid obesity, use of certain psychiatric drugs and antiarrhythmic drugs like lithium or amiodarone, using of identical radiological contrast, iron deficiency, families of thyroid, 2 or more prior pregnancies, and of course head and neck surgery that may have compromised the thyroid blood flow. So the clinical presentations are many, but the main problem is it many a time mimics what the patient will complain when she is pregnant. So if you and I are not sensitive and not alert, we may actually pass it off as a symptom of pregnancy rather than an emerging hypothyroid condition. So the complications are more likely to occur in women with severe hypothyroidism, although some appear to be higher in women with antibodies against thyroid peroxidase, in those who develop thyroid peroxidase antibodies. And women with mild hypothyroidism may have no symptoms or attribute symptoms to the pregnancy, and then we miss that window of opportunity and we end up with complications. So what are the investigations that you and I can do? Now, the evidence for universal screening is still out there. I know some facilities do that, but in the Malaysian practice, we don't, okay? And I think it's more appropriate that we target our screening so that it becomes more cost effective, and at the same time, we become more alert in picking up these patients rather than just waiting for a universal screening and missing them, yeah? So the main story of how we can diagnose is basically through laboratory assessment. And I told you, this is one of the hormones that you have to keep in remember, and of course the free T4 and the free T3. Now, in overt hypothyroidism, I think it's quite easy because the signs and symptoms will be there, the blood results will be quite evident to us, and there must be a high degree of suspicion that is this due to antibodies being present. So you have to be alert to that. And the subclinical disease is when the TSH can be elevated, but the T3 and T4 can be normal. Now, these are the patients you have to keep a close watch on. Now, the cutoff level for diagnosis is very difficult. Some will say 2 standard deviations. Depends on which method of assay, because from the early 1930s to now, so many methods of assay has come about. And the reference value is very much usually institution decided. Now, a thyroid function test, okay, these are the things that we do. But I think what I want to let you know is to realize that the changes in thyroid function test in pregnancy, the norms can vary. So when you're looking and testing patients in the various trimesters, please make sure that you know what the normal values are within your facility or within a normal range for you to make sure you're not overdiagnosing or missing the diagnosis. And likewise, I think it's important to know from this chart that free T4 low or normal, with T3 normal, with a high TSH, think of subclinical hypothyroidism. A low T4, normal or low T3, with high TSH, think of hypothyroid. So the key here is still your TSH levels. Okay, so you must always make sure that you have access to do that one investigation if you have limited resources. Okay. Now the thyroid antibodies, basically we're looking at 2, the thyroid peroxidase antibody and the thyroglobulin antibody. The thyroglobulin antibody is like a goblin, try to make life very difficult. But it's also important to know that if you have a positive antibody, of course it's very easy, but there are 20 to 30% of the population and it should not be used in isolation, meaning if you do not have these antibody results available to you, it does not mean they may not have the antibodies at all. It is just that you and I have not been able to detect it. Now, there's a Danish study which actually associated TSH levels to IQ. So if you look at here, a cutoff of about 2.5, anyone who had a cut less than that actually had issues with their intelligence quotient. Now, excuse me, I think this is something that you and I must be aware of when we have an opportunity to make a difference in the child's future. Of course, we can do the thyroid ultrasound, and of course, we can do a detailed scan for mother with thyroid disease, and we may find actually a fetal goiter. Now, what are the effects of hypothyroidism to the mother? I think the obstetric part of it we can see is that increase of miscarriage and preeclampsia, this increases the incidence of preeclampsia with mother who have hypothyroidism, increased incidence of abruptio as well, and of course postpartum hemorrhage. And all these outcomes seems to be more in patients who have actually antibodies, thyroid peroxidase antibody positive. Now, the effects of hypothyroidism to the baby, I think you and I know all these things happen, and we have a window of opportunity between 3 to 5 days to detect hypothyroidism in the newborn and to initiate treatment to prevent them from ending up as cretins. I think this is very sad if we do that. And in Malaysia, we have already started a nationwide program where every newborn will be tested for their thyroid levels before the 5th day of life. Now, we always have take-home messages, but I think there are a few take-home questions this time that you should ask yourself every time you face a patient and you suspect she or may be having a thyroid disease. Is maternal overt hypothyroidism or subclinical hypothyroidism associated with adverse maternal and fetal outcomes? Okay, and these are the 4 questions that I think you should look at. Okay, so the first question: is there adverse maternal and fetal outcomes? Meta-analysis of 9 cohort studies comparing the prevalence of miscarriage, and so there was an increase in the increase of miscarriage in those who had thyroid autoimmunity. There was a 2.5% increase. I think this is something that we must remember. Whenever our patients come with miscarriage, let's see whether we actually routinely are testing them for their thyroid status as well as the antibodies. The next thing is, another study showed that they had 7 times risk of intrauterine death in patients who had overt hypothyroidism. And a study in China said that they had almost 13 times increase of fetal loss. Okay, this was an Indian study. This is a Chinese study. But nevertheless, both of them indicate significant fetal loss in patients who have overt hypothyroidism. And maternal overt hypothyroidism is associated with all these complications. But also in the maternal subclinical hypothyroid also have increased incidence of pregnancy loss as well as preterm deliveries. So there are adverse obstetric outcomes even with those who are having subclinical hypothyroidism. And most of them have a more adverse outcome when there's association with thyroid peroxidase antibodies, right? Now, the second question: what is the impact of thyroid peroxidase antibodies positivity on euthyroid women or women with subclinical hypothyroidism? So the presence of thyroid antibodies is associated with pregnancy loss and preterm delivery independent of maternal thyroid function. That means even if the thyroid functions will be okay, but the presence of the antibodies itself has an effect on the obstetric outcome. And this is predominantly driven by the presence of the thyroxine peroxidase antibody positivity. And the risk is exacerbated in the presence of a TSH of more than 2.5 milli-international units. Now, does treatment improve outcomes? So all pregnant women with hypothyroidism should be treated with levothyroxine. And subclinical treatment is recommended in the following situations to reduce. One is if the TSH level is less than 10, we may consider, we should consider in the negative, those who do not have antibodies, but their TSH is in the region of more than 10, we should consider supplementing with levothyroxine. And if because the TSH is above the pregnancy specific range or 4.0 units, that means I told you that the values vary according to the gestational age. So if you're doing it, base it on the gestational age and then decide. And likewise, in women who are positive, levothyroxine is indicated. Okay. And if it's the TSH is more than 2.5, we should also consider. So basically, we should consider using levothyroxine if we are suspecting subclinical. Overt, of course, it goes without a doubt. Now, does treatment with levothyroxine improve adverse outcomes? There is at this present moment insufficient evidence, but in the euthyroid woman with positive thyroxine peroxidase, but those who have who are not euthyroid, definitely there is a significant positive outcome. So you can see, you know, before and after treatment, how different it is, and I think it look at the difference. Just look at the difference. And I think we owe it to our patients to make sure that we do the right thing. So what is the take-home message? Always when you see the patients, make sure you allow all these thought processes to go through your mind. Is it overt? Is it subclinical? What are the hormones that we are going to test? Think of the antibodies. I told you there are two major ones. This number 2.5 millimole is a very important number to remember. Remember that the trimester you are dealing with the patient is important because the values vary and you may have to map it with the gestational age rather than taking absolute values. Individual lab reference is important. So know what is the reference range within the lab that you're referring or sending your samples to. Close fetal surveillance is important. And of course, always include combined care, right? And based on the recommendations of the Malaysian CPG, we have said that institutions should establish their own pregnancy-specific reference intervals for the trimester. I think this is something that you and I should try for. And remember, I said 2.5. That is the other thing that you must remember is 4. Okay, 2.5 and 4 are the two numbers that you remember. Don't get confused so much, and always map it to the gestational age. And preconception, if you want to treat, if it's less than, if the TSH is less than 2.5, we have to. During pregnancy, we have discussed this. Post, just because the patient has delivered does not mean the thyroid risk goes away. We still have to look after them and make sure they are treated appropriately and their care is transferred to the relevant people once they are out of our care, right? So remember, hypothyroidism is there lurking around. If you and I don't look for it closely, we are going to miss the diagnosis. With that, thank you very much.
Thank you, Dr. Ravichandran, sir. Fantastic.
Thank you, sir. Thank you for such an informative talk. And I think you managed to clear lots of our doubts. I would just like to ask you one thing. So if the TSH is above 2.5, would you routinely recommend TPO?
I can't hear you, please. Would you mind repeating?
Dr. Pramila, voice is not clear.
Yeah, I can't hear you.
Okay.
Sorry.
I put it in the chat box.
Okay.
Yeah, I know. I heard something about 2.5. Would I routinely?
If it is above 2.5, would you recommend TPO for everyone?
Okay. TPO is not routinely done in my center, but if there are enough risk factors and I'm worried, then we will do it. We will do it. Okay.
If we don't have any other questions, we can move on to next session. Is it okay? Thank you, sir, for the excellent talk. It was really, really informative and very clear also. I request...
1 minute, Kalpana, Dr. Arul Kumaran, sir, and Dr. Ravichandran, sir. Thanks a lot for joining from your places in spite of the time variation. Thank you so much.
Thank you very much.
It's a pleasure.
Thank you, sir. Thank you. Thank you.
Mika Nandri.
Welcome. Varaverkirom, sir. Always varaverkirom.
Thank you.
Thank you, sir. Yes, Kalpana.
I request Pramila ma'am to invite our next speaker, Premlatha ma'am.
It's a great pleasure to introduce our next speaker, Dr. Premalata R, who is the president of ObGyn for the year 2022. She's also the consultant and head of Department of Multispecialty Hospitals and at Chennai, and she's the from Madras Medical College, Chennai. She's an alumni of various Madurai Medical College, and she's an excellent teacher with various experience of 35 years of experience. And today she is going to talk to us about the wonder drug in obstetrics, that is magnesium sulfate. Over to you, ma'am.
Thank you, Dr. Pamela. Shall I share my screen now? Thank you, Dr. Sambat Kumari and the team. Really, I congratulate the whole team for the excellent work, and I'm really very happy to be part of this program to talk on magnesium sulfate in pregnancy. As we all know, magnesium sulfate is an important armamentarium in our in obstetric practice, and it's being widely used by all obstetricians, especially in preeclampsia for prevention and treatment, and for fetal neuroprotection in preterm labor, and with a doubtful value for tocolytic therapy. So I am here to talk on magnesium sulfate. As we all know, magnesium sulfate in preeclampsia, that is the most commonly used drug in preeclampsia. Eclampsia is a medical emergency and it occurs during AP, intrapartum and postpartum period, and it needs urgent intervention. And magnesium sulfate has been proven to be effective first-line management for both prevention and treatment of eclampsia. And just to recap, we all know preeclampsia is mainly due to abnormal placentation leading on to hyperperfusion and ischemia of the placenta, leading on to release of various placental factors, just imbalance between the vasoactive angiogenic and anti-angiogenic factors like SFLT, endocrine, and nitric oxide. And so this leads on to a total peripheral increase in the peripheral resistance, proteinuria, systemic hypertension. In turn, leads on to increased systemic vascular resistance in cerebral vasculature, vasospasm, cerebral edema, thereby symptoms of eclampsia like convulsions. So it is mainly caused by both cerebral edema and ischemia. It can be generalized or localized, such as in the occipital lobes, white matter, or in watershed regions. So when should the magnesium therapy should be initiated in preeclampsia? All this started because of the MACB trial. You all know by the MACB trial, which was started in 1998 to 2001 in 33 countries, inclusive of 175 hospitals, where more than 10,000 women, 50% recruited to magnesium sulfate and 50% to placebo treatment, and then randomly allocated to receive therapy and found out. And the trial said the use of magnesium sulfate reduces the risk of developing eclampsia by 50%, lowers the maternal mortality rate without increasing the harmful effects on either the mother or the baby in a short-term effect. So since this landmark trial, the WHO has promoted the use of magnesium sulfate for prophylaxis. So when should be started in a pre-eclampsia for prevention? In all the trials, the methods were clearly described that it's always initiated once the decision is made for delivery. It is not started in active labor. Whenever you decide for delivery, you start magnesium sulfate for prevention of eclampsia in severe preeclampsia. The MACB trial all includes, they limit magnesium sulfate to over a period of 24 hours. And then after 24 hours, if delivery has not occurred, the decision for continuing the treatment is physician dependent. Because the earlier studies, they told the magnesium sulfate is having slightly increased risk of postpartum hemorrhage, pulmonary edema, and respiratory depression. So overall, the end of 3 years of the MACB trial, it was found that it was told that women with severe preeclampsia, imminent eclampsia, those with preeclampsia in high perinatal mortality rate countries, high BMR countries, they appear to benefit the most. Just like in developing countries where they have a high perinatal mortality rate, this magnesium sulfate is definitely found to be useful compared to countries with low BMR. So the efficacy of magnesium sulfate, that is mainly for prevention in severe preeclampsia,
What happens in eclampsia? We all know it has been used as an anticonvulsant effect, and how it was started, the magnesium sulfate has been proven to be effective as a first-line treatment for treatment of eclampsia, and it has been found that the mortality rate is reduced by 46%, and the risk of eclampsia was reduced by 50%, and the decreased risk of placental abruption compared to placebo and other anticonvulsant groups. So compared to women receiving magnesium phenytoin diazepam, women receiving magnesium sulfate in treatment of eclampsia had lesser complications. So what is the pharmacodynamics of magnesium sulfate? The anticonvulsant effect of magnesium sulfate acts as a central brain level, neuromuscular level, and vascular endothelium. So at the central brain, nervous system, and the vascular endothelium, it mainly acts via the NMDA receptor blockade. And at the neuromuscular junction, it decreases the calcium conductance and acetylcholine release and motor end plate excitability to the acetylcholine release. So thereby decreasing the convulsions. So after administration, what happens? The plasma magnesium is protein bound. 40% is bound to the protein, and the unbound magnesium diffuses into the extravascular, extracellular space. And the maximum, that is constant values, are reached in the 3rd or 4th hour after administration of magnesium sulfate. And is almost exclusively excreted in the urine. 90% of the dose excreted during the first 24 hours after an IV infusion of magnesium sulfate. So what is a therapeutic level? What is the level? We say either a 4 to 7 milliequivalent per liter is the therapeutic level which is needed for control of eclamptic seizures. While monitoring for toxicity, one should have either 4 to 7 milliequivalent per liter, or in millimole it is 1.8 to 3 millimole per liter. So the magnesium action act by cerebral vasodilatation, reducing the ischemia due to vasospasm. It reduces the inflammatory cytokines and oxygen-free radicals. It inhibits platelet activation, peripheral vasodilatation, decreasing the systemic vascular resistance. Also dilates the orbital vessels, increases cardiac output, renal blood flow, and uteroplacental blood flow. They are the other effects of magnesium sulfate. So we all know about various regimens of magnesium sulfate. We have a Pritchard regime and Zussman regime. To recap it, the most we were using mainly the Pritchard regime, and now people have all mainly shifted to the Zussman regime. The Pritchard regime is the intramuscular regime, which has a loading dose of 14 grams. That is 4 grams IV dose, and followed by simultaneously intramuscular dose of 10 grams, and with a maintenance dose of 5 grams into each alternate buttocks every 4 hours. Whereas the Zussman regime has a single loading dose of only 4 gram IV with a maintenance drip of an infusion of 1 to 2 gram per hour. So when you talk about both the regimes, the serum concentration of magnesium from the Pritchard regime is found to fluctuate more often compared to the Zussman regime. The Pritchard regime was more practiced in developing countries compared to the Zussman regime, where because you need an infusion pump and for monitoring. For infusion of for the Zussman regime, you have to have an IV infusion regimen. Magnesium toxicity, you should know about it, because the imminent first sign of magnesium toxicity is a loss of patellar reflex, and then the patient can go for respiratory depression and even cardiac arrest. So the first therapeutic level of serum magnesium is around 4 to 7 milliequivalent per liter, and once it goes more than 8 to 12 milliequivalent, goes for loss of patellar reflex, flushing, warm, somnolence, and slurred speech. And if it is more than 12, actually 15 to 17, muscular paralysis and respiratory difficulty occur. And when it's more than 17 milliequivalents, usually the cardiac conduction is altered, and when it is more than 30 to 35, almost 30 milliequivalent per liter, cardiac arrest can occur. So once we are administering magnesium sulfate, we should be very careful. We should monitor for the toxicity. Close monitoring for the deep tendon reflexes, respiratory rate, urinary output, and are mandatory. And plasma concentration are of importance. Routinely, plasma concentration of magnesium sulfate are not recommended. We have to look for the deep tendon reflexes, patellar reflex, the respiratory should be less than 16 beats per should be more than 16, and urine output should be at least 30 ml per hour. And whenever you have giving anesthesia, analgesia, followed with along with the magnesium sulfate therapy, we should be always thinking about the potentiating effects of perioperative analgesia and muscle relaxation effects on the women. That should be taken care of. So whenever you have a urine output less than 30 ml per hour, you should withhold the magnesium sulfate. Ringer lactation can be started with the 1 liter over 8 hours and monitor for pulmonary edema. If respiratory arrest occurs, you have to even go for ventilator support. The antidote is mainly calcium gluconate 1 gram, that is 10% of 10 ml, IV slowly over 10 minutes. Sometimes we may need repeat doses depending upon the response. Another drug which can be also used as an antidote is calcium chloride, 500 milligram in 10% calcium IV over a period of 5 to 10 minutes. The contraindication for magnesium sulfate is mainly myasthenia gravis and impaired renal function. Whenever I have previously known to have impaired renal function, magnesium sulfate is contraindicated, heart block, myocardial damage, and myasthenia gravis. Actually, drug interaction with nifedipine and anesthetic drugs should be taken. It's a relative contraindication. Whenever you use anesthesia, general anesthesia and smooth muscle relaxant, we have to be very careful, and the drug should be dose should be adjusted according to if the patient is already on magnesium sulfate therapy. What are the effect of magnesium sulfate on fetus? When they monitor the baby by the CTG, they have a small negative effect on fetal heart rate. There's a dip in fetal heart rate by 10 beats or above, and a little decrease in the basal variability, and accelerative pattern is little altered. But they are not statistically significant or sufficient clinically to warrant medical intervention. So they say even if you are giving magnesium sulfate, it is not statistically significant to affect the fetus. So in order to decrease the toxicity, various regimens have been altered in developing countries. Low dosage regimens by Bangladesh people, Dhaka regimen was started. In that, instead of 14 gram loading dose, 10 gram loading dose, followed by 2.5 gram was given every 4th hourly. Other regimens like Sokoto regimens, low dose loading regimen, all have been used to manage eclampsia. And it has been found that there is no difference in outcomes between Pritchard's regimen and low dose regimen. And also they have used only low dose regimen, loading dose only, without a maintenance regimen. In this also the results have suggested that loading dose only regimen have a non-statistically significant reduction in fetal and neonatal mortality. And so they have found that when places where they are not able to monitor closely, a single loading dose itself has been used. And another trial in PIPA's trial in 2018, they went further to find out whether a single dose regimen with a low dose Dhaka regimen, and they found that the efficacy of a single low dose regimen is found to be useful in a case of prevention of eclampsia. So the WHO has acknowledged magnesium sulfate is the safest, most efficient, cost-effective medication for treatment of eclampsia, and has been used as an essential medication.
Please unmute others.
So that is for prevention of eclampsia. For treatment of eclampsia, it has been used as early as 1906. But many times, because of the high dose 10 ml of injection which has been put into the buttocks on either side, causing lot of injection abscess, actually there was a shift towards diazepam, phenytoin. And again in 1995, because of the collaborative eclampsia trial by Lilia Dooley, it has been again come into vogue. So the collaborative eclampsia trial compared magnesium sulfate with that of phenytoin and diazepam, and they have found that both magnesium sulfate is superior to phenytoin and diazepam. A loading dose of magnesium sulfate 4 gram followed by infusion of 1 gram per hour was maintained for 24 hours. And if there is a recurrent fit, they give another, they continue the infusion for 24 hours. So when they compare diazepam with this, they have found diazepam associated with depressive effects on the infant and a low ObGyn score in a case of diazepam therapy. And they need an additive therapy in a case of diazepam therapy. Whereas in a phenytoin also, the incidence of recurrent seizures were more in a case of phenytoin therapy compared to the magnesium sulfate therapy. So magnesium sulfate is definitely found to have reduction in in development of pneumonia, recurring intubation of the mother, and ICU admission in a case of mothers who are on magnesium sulfate. And fewer infants on magnesium sulfate had low ObGyn scores. Fewer infants need intubation and admission to NIC. So the NICE guidelines say never to use diazepam, phenytoin, or other anticonvulsants as an alternative to magnesium sulfate in women with eclampsia. What is our FOXY recommendation? FOXY also recommend loading dose of magnesium sulfate to prevent all cases of severe preeclampsia. So to prevent eclampsia, they say you have to give loading dose of magnesium sulfate. And for eclampsia, you should be started on magnesium sulfate and stabilize and deliver the mother. It is the safest drug which has been recommended by FOXY. FOXY does not recommend routine serum magnesium monitoring. It is not routinely required, but the regimen which is recommended by FOXY is only the Pritchard regimen. Maybe because in India we have more people who are able to give intramuscular regimen. That is a regimen which has been used, advised. So we all, I'm not going to tell about how to administer. We all know the ampoules are coming in 50% ampoule. Each ampoule contains 2 ml of 1 gram. So that should be made into 20% by adding 8 ml of normal saline. So that we have to have 4 ampoules of 4 gram. When you are added to 4 ampoules with 12 ml, it will become 20%. So one should know how to make the 20% solution. So whenever we give intravenous infusion, we give 20% of 4 gram slow IV, followed by 50% solution of 10 gram, 5 gram in each buttocks and 5 gram alternate buttocks. And using an infusion pump, we have to use in a Zusfan regime. So this is why NHM, National Health Mission, also have a checklist for administering magnesium sulfate. They also tell about what is the Pritchard regime, how carefully we have to use magnesium sulfates and intramuscular. That is in the National Health Mission, NHM, it has been given. So there is no disagreement. We all use magnesium sulfate for both for prevention of eclampsia and for treatment of eclampsia. And magnesium sulfate with anesthesia, what is it said? Neuromuscular blocking agent to facilitate endotracheal tubation and relax abdominal musculature are given. And whenever we give magnesium sulfate, it potentiates and prolongs the action of the depolarizing
Sorry
agent.
to interrupt, ma'am. You have 1 more minute to complete.
So you have need lower doses in a case of anesthesia. So magnesium sulfate, when you use for lactation, during lactation, they say, though magnesium secreted in the maternal milk, it is very minimal. It does not affect the breastfed infant serum magnesium. But the onset of initiation of lactation may be prolonged if a woman is on magnesium sulfate. And next is the neuroprotection preterm level. It has been definitely proven to reduce cerebral palsy and motor dysfunction in offspring whenever we give for established preterm labor or women who are having a planned preterm labor within 24 hours. Especially within less than 30 weeks of pregnancy. So between 24 to 30 weeks of pregnancy, magnesium sulfate is mainly given for neuroprotection. After 30 weeks, up to 34, it can be considered for neuroprotection. So same level, the ACOG guideline also says MRI detected cerebral hemorrhage in preterm infants are reduced, and the combined risk of fetal infant death is decreased due to cerebral palsy. So it is inexpensive and easy to use, especially in case of premature babies, to protect the immature brain. So it should, WHO says it should be given for all women at risk of preterm labor less than 32 weeks. So how do we give? Only loading dose is been told by the ACOG 6 gram IV, and we can give 2 gram IV maintenance until birth. So initially 6 gram IV over 30 minutes, and you give 2 gram maintenance. If the delivery does not occur within 12 hours, you can stop the infusion. And then if the patient resumes a contraction, again, if it is within 6 hours, you can start the maintenance drip. But if it is more than 6 hours, again, a loading dose should be done. This is the ACOG guideline. And coming to tocolytic therapy, we all know, so various tocolytic agents are there, and magnesium acts at the level of calcium induction. So meta-analysis, it decreases the calcium intracellular concentration, inhibits contraction. But the meta-analysis says compared to placebo, the highest thing is mainly prostaglandin inhibitors and calcium channel blockers and magnesium sulfate. But the side effects are more in a case of beta, more with the magnesium sulfate, similar to that of a beta emetics. So it has been found that whenever you use for tocolytic, magnesium sulfate is not the first drug of choice. The drug of choice is mainly prostaglandin inhibitors and calcium channel blockers. And we should be very careful whenever we combine with nifedipine. So magnesium sulfate as a tocolytic therapy is not given. To conclude, magnesium sulfate has been shown to be effective treatment for prevention of eclampsia, and its mechanism of action is multifactorial, both vascular and neurological mechanisms. It acts centrally to inhibit NMDA inhibitor receptors, providing anticonvulsant activity. And whenever we anticipate early preterm birth, It reduces the risk of cerebral palsy in surviving infants, and it's useful. So it is mainly used for neuroprotective effect and not for chocolate. Thank you.
Thank you so much, Premlata ma'am, for the extensive and
Premlata, there was a question in the chat box. Levitril. Levitril used in eclampsia. There was a question in the chat box.
That's portal, madam. Chat box la poda sollilla. We will go with the keynote address.
It's a great honor that it's a great honor that we have Rishikesh Pai sir, President-elect FOGSY, had joined us for this wonderful Southern Federation conference with 2,000 participants, registered participants in this program. Welcome, sir. It is our pleasure and privilege to invite and introduce you in this conference. Actually, sir doesn't need any introduction. He is the President-elect FOGSY 22 to 23. He is a person and who can guide each and everyone in the next tenure. He has got many innovative ideas to go ahead. We are eagerly waiting to work under your leadership, sir. To introduce you formally, sir is the Medical Director, Bloom Group of IVF Centers, Administrator of FOGSY Manyata Initiative, Director, Corporate Affairs, International Federation of Fertility Societies, Adjunct Professor, Virginia Medical School, USA. And he has been a very good teacher for DNB examination, visiting Professor, Manipal University, India. And he has been awarded prestigious fellowship from RCOG. He was the past president, ISAR, IAGE, and MOGS, has been awarded 30+ awards and prestigious Lifetime Achievement Award from Reproductive Health by ISSRF and various reputed organizations. Delivered many oration, editor of 16+ books, written more than 50 chapters. It is a great honor that you are here to give a keynote address on artificial intelligence in IVF. Over to you, sir.
Okay, let me first, I have forgotten how to operate the Zoom.
Welcome, Rishikesh, sir.
I think I have to the share screen, okay? Because I am opening the Zoom after many days. So.
What happened, sir? Presentation?
No.
It is seen, sir.
No. Can you see the screen?
Yes.
Okay, great.
Dr. Rishikesh, it's in the slideshow mode. Put it in the slideshow.
Yes.
Now it is seen, sir.
Yeah. Okay, great. I know. I suddenly forgot how it looks. Okay. So basically, I would like to thank Dr. all of you, Sampath Kumari, of course, my Vice President, and Fessy Louis, my friend and Vice President, and Dr. Shanta, our President of FOGSY. And you have got the 5 organizations, that is the TCOG, APOGS, KASOGA, KFOG, and TNFOG. So all of you have come together, and it is I think one of the first, I think has not probably occurred before. I don't know. So as I was listening to the last talk, Dr. Sampath Kumari, one request is that whatever GCPRs we are going to make now, I want you to see that all of these are done so that the practice is uniform. We need to not only do the GCPRs, but we also need to make everyone follow those GCPRs in a uniform fashion. Then only we'll be able to achieve our goal. So I've already been introduced. So I just have come from Agra in the mornings, got up at 6 o'clock, just come here in the ISAR conference, and the managing committee meeting is going on. But I am now old, retired ISAR member, so it doesn't matter for me. This is more important. So I'm just come up to the room, and I'm going to talk to you about the artificial intelligence. So artificial intelligence is intelligence demonstrated by machines that mimic cognitive function that humans associate with the human mind, such as learning and problem solving. Machine with AI does not possess natural intelligence. So machines don't have consciousness, emotion. Machines can't cry. Machine can't have feeling. Machine can't get angry at you in case there is an argument in the managing committee meeting. Machine will be cool and calculated. And so historically, I would say that in 1997 when Gary Kasparov was defeated by IBM's Deep Blue, which was one of the oldest artificial intelligence machines. That time, the artificial intelligence suddenly came into the focus. And then, of course, there were other things and all. And in 2018, the futurist Martin Ford asked 23 leading experts, when will AI achieve artificial general intelligence? And the average answer was in 2099. Means what he was saying is that in case, when will the machine start having consciousness? When will the machine start feeling? When will the machine act like a human being? And the thought was that by 2099, that will occur. So there are different ways of the parts of artificial intelligence. One is automated reasoning. The other is called knowledge representation, automated planning. Then we have got machine ability. Then the next is we have got what is known as natural language processing, machine perception, and the final important part, which is very important for our medical fraternity, is called machine learning, which is the study of computer algorithms that improve automatically through experience. So you give the machine an algorithm and the machine starts doing all your work. And as the work is there, just like a human being, if you go and start becoming a resident in the first year, by the time you're third year resident, you have already gone and your experiences have enriched you. Similarly, the machine also starts learning. So whatever algorithm it gives, it starts modifying and improving the algorithm based on the output of that algorithm. So machine learning is a form of artificial intelligence in which a machine can learn and adapt to situations and data training. Typically, a training data set is used to train a computer program to connect objects, such as images that are described using a series of features, color, shape, and texture, with specific labels or classes. For example, in cancer and non-cancer, suppose there's a skin lesion and there's a you take a photograph of that lesion and you tell the machine, okay, this has a yellow color, the border is having spread and it is got a elevated. So all that the machine keeps on inputting. So I just wanted to go a little bit ahead to show this particular slide. So if there's an elephant, then the standard you take the photo and tell the machine that this is the elephant. But on the other hand, you can also, the machine will break up the elephant on the right hand side of the screen by making various shapes, sizes, and colors, and then conclude that it is an elephant. So there are two types of learning that machine does. One is called the supervised learning, which is you show the photo of the elephant and tell the machine that it's an elephant. And the other is that machine breaks it into its own parts by doing it on its own. And that is called unsupervised learning. And this unsupervised learning is very important for artificial intelligence. So this is what machine learning does. So you need a lot of, in the original way, we had to build a machine, but with the advancement of cloud computing, most of the data was put in the cloud. So it was no longer in the processor. That's why lot of people could start doing artificial intelligence. And now also this was in association, there were two, three other new programs that were given by various big companies free of charge to the programmers. And at the same time, there was an additional ImageNet, which is a which is a cloud where there are 14 million plus images are stored of different things. Like you can tell the ImageNet and you can take a photo of a ultrasound of a fibroid and store it and say that this is the fibroid. So using the programs that are freely available and using the images that are stored in the thousands and millions of images stored, a programmer can create his own artificial intelligence system. So the machine learning uses different types of techniques to do the unsupervised and supervised learning, such as logistic regression, random forest, naive Bayes classifier, support vector machine. But the most important thing is as far as the medical, because most of the medicine, the artificial intelligence is image based. You see an image and the machine is asked to tell what is that image, whether it's a cancer or non-cancer, whether the embryo is good or bad, whether the egg is good or bad. So more of image-based systems are there, and that needs what is known as artificial neural network and deep neural network and convoluted neural network. So these are all the same. So artificial neural network is what? It's a neural network which consists of several layers of artificial neurons fully connected to each other by edges. Each one is associated with a weight. Each neuron receives signals from the multiple neurons in the previous layer, integrates those signals and fires if the integrated signals are above a specific threshold. So basically, in short, these are not actual cells in a machine. They are in the cloud, and these are made by programs, and these programs create these cells. And depending on the number of cells that are there in each program, you can either call it a artificial neural network. If it is becomes more and more cells, you call it deep neural network. And if there are many, many cells, you call it convoluted neural network, which is normally called CNN. And this CNN is very powerful for image classification and object detection. Thus, they are widely used in biomedical imaging domains like our medicine. CT scan images there. The machine can tell you this CT scan has got an enlarged gallbladder. There is a cancer that has spread to the common bile duct, etc. So using the TensorFlow and PyTorch platform, which are open source means freely available to everyone. Sampath Kumari can do it. Fasil can do it if he wants to start an artificial intelligence program. And using these free platforms that are available in the internet and using images which are stored, which are freely available, or many people will approach you and say, "Acha, Dr. Fesi, I want to start artificial intelligence. All your images that you do on your ultrasound, you give it to me and tell me this is what, this is a hydrosalping, this is." So my machine will automatically start learning, and now next time when you have an image, machine will tell you what is the diagnosis rather than you telling the diagnosis. So this is what artificial intelligence is about. So what are the advantages of artificial intelligence? There is a lot of economic benefits, like you can improve healthcare, making diagnosis precise, enabling better prevention of disease, increasing the efficiency of farming, contribute to climate change mitigation. There are high-profile examples like autonomous vehicles, that is driverless cars, drones. So many drones can be doing so many functions nowadays. You can create art by using machines. You can play chess. You can play games. You can do advertising. You can do chatbot. Like if you go on my site, Bloom IVF, there's a chatbot. So I am not chatting. The patient goes on the chatbot and asks a question, "Dr. Pai, when can I meet you?" The machine will automatically say, "Hi, I'm Dr. Pai. I'll meet you on this day." So the machine can converse with you. All this is done by artificial intelligence. So you can also do, just now I was in United States, my daughter is in computer. So she was telling me, "Dad, if there's a new program, you just tell the machine, okay, I want Dr. Faisal Louis sitting in a nice swing in a garden in, Kumarkham." Automatically machine makes a photo in 1 minute and puts that photo in front of you. So because I was telling her that I wanted to do some recording of videos. She said, "Dad, why you are doing all that? In 1 year's time, automatic videos will be formed. You just give instruction to machine what video you want, and machine will make the video and give it to you." So this is the power of artificial intelligence. So there are different things that it can do in medicine. You can do large scale genomic data inputting. You can predict responses to therapy based on genomic features. You can leverage medical imaging to deliver more personalized medicine. ImageNet is a pre-trained database of 14 million images, which can make data training of new image source very easy to implement. You can, in the future, skin lesions, of course, we'll need the dermatologist, but the skin lesion, you just take the photo and machine will tell you what lesion it is, whether it is a fungus or whether it is a autoimmune disorder. You can do retinal scans and automatically you can see whether there is a diabetic retinopathy. Door is open. You can analyze the pathological tissue images. So another thing which we like in our city in Mumbai, there is one, I will not take the name, but she's a fantastic pathologist. There's one pathologist who, after we take the cancer, we take the slide, we send it to her for final opinion to tell us whether that is cancer or not cancer. So everyone bases their treatment on that lady, senior lady. She sits in Tata Cancer. Now she's retired, but she still gives so now that function will be taken over by the machine. Machine will tell you, "Oh, this is a cancer or it is not a cancer." So by looking at the microscope slide, the machine will automatically be able to predict whether it's a cancer or not cancer. You can diagnose disease. Radiology images are going to be easily diagnosed. Even you can, when you put a colonoscope and say that take the photo of the polyp, the machine will tell you whether it is a malignant polyp or a non-malignant polyp. Of course, you will do a polypectomy and do a histopathology, but machine can tell you. So artificial intelligence can also be applied to medical record data. From in India, for example, millions of data are there. You want to know what is the intervention, which magnesium sulfate dose, if you give better perinatal outcome and better maternal outcome, automatic data inputting will be done. And that is what is the Ayushman Bharat mission, which is of the government of India. The first part of the mission was to give treatment to all the poor people. The second part of the mission is Ayushman Digital Mission. So that is where all the data will be collected, and mostly in the next few years' time, we'll have to compulsorily put all the data of all our patients so that the digital mission will start analyzing the data on real time. And the third part of Ayushman Bharat is the Ayushman infrastructure. So a lot of new infrastructure will be created to do healthcare delivery system. So these are the three parts of the Ayushman Bharat, and a lot of artificial intelligence will be used in implementing all the three parts of Ayushman Bharat. So EMR is very important, and almost all of us will have electronic medical records. You know, in the future, everything will be paperless. Already we are in the ERT bill that has come in. I was telling all my unit people that we will do, will not buy new programs, which are not. The original programs were mechanical EMRs, but now the new programs that we will buy and implement in our units will be EMRs, which are also supported by AI. So not only it will give you the record, but it can tell you. So I had to just ask the question to the machine, okay, tell me how many of these were poor responders, what happened here, what was my dose proper or not. Just now I was in Israel, and one company has been contacted me. I have not had the time to connect with the company, but they have a new program where they can, by seeing the lining of the sonography machine, they can tell you when to do the frozen embryo transfer so that you can get the best pregnancy rate. So these are the things that the machines are going to keep on doing. So when I was in Israel, there was another AI system where you just have a band which you put on your arm, and the band every day sends a temperature message to the cloud through your mobile phone, and the machine tells you which days you should have sex so that you can have a child, or which days you should avoid sex so you don't have a child if you are wanting to have a contraception. And it is nearly 98% accurate. So these are the things that will happen with the AI when it is brought in. You can use it for stock taking and inventory, how many medicines are there. One of the biggest things that we already all are worried about is the expiry of medicine. So you can find out when the medicines are going to expire, so that you don't make a mistake of using an expired medicine. The anesthetist may take a trolley and say, oh, this medicine I used, but it had expired. So automatically the artificial intelligence will give an alarm system and say, oh, in your stock, in your OT number 1, in that particular card, that particular medicine is expiring, you please take it out. So these machines will help you to also prevent medico-legal litigation. Of course, QC, QA will be done by machine. Data analysis and research and publication. I keep on telling, yesterday also in Agra, I told everyone that everyone knows how to do a laparoscopic surgery. Everyone knows how to do an IVF. Everyone knows how to do fetal medicine or cesarean. So nobody is great. Who will be in the future? Who will be the great person? The great person will be the one who does research. Research in abroad, people who do research are given maximum respect. Even if they want to be politically powerful, a researcher, if he stands for an election, he will get more vote. So the person who does things is at the lowest level of the chain of academic excellence. Person who does things, does routine operations, yes, he's very important for us. But if you want to become big, and that's what I tell everyone, all the juniors, that if you want to really become noted and big, then you have to sacrifice. You can't just suddenly finish your MBBS, MD and go into medicine and start doing business. I mean, every fool can do business. What's the big deal about it? You must sacrifice your time, go abroad, work in research labs, do what is known as translational medicine. When I was in Australia for doing my fellowship in 1989, Professor Rahul Magara had come from Hammersmith Hospital. He had taken a sabbatical. He had just taken off from his work, and he had come and he was working on marmoset monkeys. He was doing IVF in marmoset monkeys. I used to help him. I used to assist him. He used to put laparoscope in marmoset monkeys. So that kind of work was done. And that's the work which creates new discovery, new invention, and new ways of doing work. This is where I would encourage all the younger people to deviate and go into research. Ultimately, you have to also make money in your life. I agree with you. You have to also serve the patient. So we are doctors, we have to serve patients. But that is not the be all and end all. Most of us, our younger children are going straight into private practice. That's not the right way. The right way is to dedicate, work in government hospitals, do research, and later on at the age of 40, 45, 50, when you feel that you have done enough, then you enter private practice. So you can also do in infertility. What can you do? In the male, you can predict male infertility. You can just look at the semen and you can predict the male factor. You can see this. There are a lot of these programs that are now available. You just take the machine and you load this sample in this, we have just introduced it in our lab. It is quite cheap. It costs about 1,50,000 rupees. And the syringe costs 350 rupees. You just load this and you just put it in the machine, and the machine will give you it gives 10 parameters. It gives more count, motility, morphology, and you can, so there is of course, it is not very highly accurate, but it is good enough. So these are the things that can be done for the artificial intelligence. You can also, machine will be able to tell you where are the sperms. So in a testicular biopsy, when you are doing micro TISA, you can actually, the machine can spot the sperm among the debris and you can help it to pick it up. You can also use machine to do identification of the best sperm possible. And this is done by, this is the IMSI technique, but now the new technique that has come, that is the SID technique, where you can actually connect your micro manipulator to the internet, and the machine will look at the various motile sperms and it will tell you which sperm to pick up and do the micro injection. You can see the machine is now looking at the sperms and it grades them as A, B, and C, and they'll tell you, okay, take the A sperm and pick it up and do the injection. So this is, see, the machine is giving the grading of the sperm based on its morphology, motility, and forward progression motility. And that is an important thing that the machine will do. Machine can also do oocyte imaging. And we have got a new program which we introduced in our lab now. We have done 36 patients with this new program where we can grade the oocyte. So suppose we are doing egg freezing. What we do is we grade the oocyte using the machine. We take the photo of the oocyte. You can see on the right hand side, we take the photos and we send them to the server, and the machine will tell you, okay, this oocyte, if you freeze it and you thaw it after 10 years and you do micro injection, there is a 33% chance that this egg will give rise to a pregnancy. On the other hand, this egg will give rise to a pregnancy 53% of the time. So if you do a pickup and there are, let's say 10 eggs, but the machine says, no, of these 10 eggs, 5 are really bad, Dr. Pai. Only 5 eggs are good enough to give good chance of pregnancy. Then I can counsel the patient and tell her, listen, you need to do one more cycle of egg freezing so that I have enough eggs so that you have a good chance of getting pregnant 10 years down the line when you want to thaw these eggs and do the injection and try to have a child. So we already have introduced these programs in our lab, and we are now giving it to free of charge to all our patients who come for oocyte freezing. This particular program is from Canada, and this research paper has been based on this program by Powart et al., presented in the HT 2020. And you can see here that they have done 17,000 oocyte image analysis, 17,000 plus images, and they gave this oocyte to 17 embryologists were given from 8 IVF clinics, 300 oocyte. Those embryologists examined them, and then the machine predicted a better blastocyst development than the embryologist. You can see that the fertilization prediction was 71% by the machine and 20 as compared to 58% by the embryologist. So 21% increase in chance of prediction was there. You can use machine for other things also. You can do machine analysis of the embryos, and based on that, so you do just a static image, or you can do a time-lapse image. So this is a time-lapse machine, the new machine that we are just about to install in our lab in Mumbai and Delhi. You can actually, that machine will analyze the video, and using artificial intelligence, the machine can use what is known as the IDA score, and it can tell you which embryo to put back so that you get the highest chance of pregnancy. But not everyone can afford an embryoscope. So even now there's a new program called ERICA, which we have been using for the last 3 years. During the COVID time, I got it installed. This artificial intelligence program is from Mexico. And this program, you can take the photo of the blastocyst. Suppose there are 5 blastocysts. You can take the photo of the blastocyst and then their machine will tell you which blastocyst to put so that you get the highest result. Now we have shifted from Erica to a new artificial intelligence program from Australia called Life Whisperer. And the other day, just about 4 days back, before I went to Agra, I had a patient. I had given her a child, first child, and she had 4 extra blastocysts. She had come for the second child. She said, Dr. Bhai, I want to put only 1 blastocyst back. So I used the Life Whisperer. I took the photograph of the 4 blastocysts, and the machine told me which is the best blastocyst to put, because she wanted only single transfer, because she already had 1 child before. So this is what the machine can help you to do. It can also help you to predict. So the Life Whisperer, which we are using the program now, it can also predict that embryo is genetically normal or not. Nearly 80% prediction. So not only can it predict whether the embryo will implant or not, but it will also predict whether the embryo is normal or not. You can also use the machine for analysis. So when we now do pre-implantation genetic testing, we have started doing NGS on spent culture media. The DNA is leaked in the surrounding. But after the DNA analysis is done, then the ultimate report of the NGS has to be sent to the embryologist, and the embryologist will tell us whether the embryo is normal or abnormal. But now the machine can tell whether the embryo is normal or abnormal. And there was this study that was carried out by New York Langone Fertility Center, where they showed that by using artificial intelligence instead of the geneticist and of course the final geneticist still does the final signing, but instead of that, if the machine uses it, then the pregnancy loss was reduced by 4%, the miscarriage rate was reduced by 1%, and the pregnancy rate and live birth rate was increased by 13%. So the machine could predict the report of the NGS done on the PGTA sample better than the geneticist. You can also do things like automatic follicular tracking, gonadotropin dose calculation. So now, as I told you, the Israeli form that is after my blood, I can just do the scanning, and I don't have to bother. I don't have to take a phone call from my assistant. Sir, this patient, we are doing this and we are given so much, and today the follicle size is this much. What is the dose should we give? Automatically machine looks at the follicle, the tracking, and it will give the dose as to how much is the dose you have to give. You can also do, as I told you, everything, uterine anomalies, all of them will be able to be identified. And as I told you, even the endometrial receptivity analysis will be done automatically. Already we are in talks with the Israeli people, and we may introduce that automatic endometrial receptivity analysis so that we know when is the right date to put the embryo so you get the best pregnancy chance. So what are the disadvantages of artificial learning? One is it is got multiple. The problem is that everyone, every second or third person comes to me and says, "Sir, I am starting my artificial intelligence program." So there is too many people that are there, too many programs are there, and too many inputs. So if you do wrong inputting of the images and all, you can create what is known as a wrong program and wrong prediction. Also, ethnic diversity is there. So a machine may have a program based on the Australian data, but the Indian data may be a little different. So now when I've tied up with the Australian company, so that they will also say, "Acha, Indian data," they'll also ask, "Dr. Pai, we gave you this diagnosis and you put the embryo back into the patient. Did the patient become pregnant? And okay, if she did become pregnant, did the patient go to term? And was the baby normal or abnormal?" So once I give them that input, then that photograph of the machine that they took, the machine will say, "Okay, if this photo was taken, that baby was normally born." So it will start correlating the Indian data also and will come out with the Indian algorithm. So this is very important. So ultimately, you have to remember that integration is important. Human being is important to take the decision. And what are the other problems? That there's a fear. Hello. I can't hear. Someone is talking.
Shahita, unmute others.
Hello. So there is a fear that long-term unemployment and job loss may be there, but a lot of people are saying that the job loss will not take so much in the health department, because in the health area we need to, for example, if a patient is there, he's on the bed. You have to make the patient get up. There has to be a human being who has to help the patient. He has to be given enema. He has to be taken to the toilet. So there are a lot of these things that are personalized, and it will be difficult to replace them with the machines. You can also, so the Stephen Hawking has been telling that AI will spell the end of the human. He's saying that at some point as I told you, that 23 people said that by 3000 machine will start having emotions and start crying and start taking decisions. So if there is a autonomous independence that comes because of the rapid advancing AI, 5G network, 6G, 7G, we don't know what speeds will come. So there is a danger that the machine may supersede the human being. Hello.
Can you
mute others, please? Please mute others.
Hello.
Ashita, please mute others.
Hello. The opinion of the experts within the field of artificial intelligence is mixed, with sizable fraction, both concerned and unconcerned by risk from eventual superhumanly capable AI. For the danger of uncontrolled advanced AI to be realized, the hypothetical AI would have to overpower or outthink all of humanity.
Why, sir? 1 minute. Sahita, mute others, Sahita. Somebody is talking. Others, please mute. Sahita. Yes.
Okay, I think so. The Stephen Hawking is all worried that machines will overtake the human beings, but there are a lot of other CEOs which like Dr. Peter Thiel of PayPal, Jeff Bezos of Amazon, and Elon Musk of Tesla have committed $1 billion to see how we can work with the artificial intelligence, but without allowing them to dominate the human race. So I would, in conclusion, say that over the last 3 to 5 years, we have witnessed the increasing utility and exciting applications of artificial intelligence in ObGyn, especially cancer, infections, and reproductive medicine. Artificial intelligence will usher in a new era of standardization, automatization, and precision of IVF. Artificial intelligence-driven approaches are more likely to be more objective, more rapid, and most importantly, more accurate. While applications of AI in embryology have gained the most attention and shown great promise, it is likely its use will widen to other aspects of reproductive medicine. I told you the clinical aspects, monitoring the patient, deciding what dose of gonadotropin to give, deciding when to do the transfer based on the endometrium, data keeping, QC, QA, EMR systems. There's one doctor in the United States, which, suppose he has got 40 patients in a month. The machine exactly adjusts the patient's last menstrual period so that they all don't come at the same time. So there's an optimal utilization of the IVF lab. So there's a wider use of AI in precisely assessing patient characteristics such as ovarian reserve, age, endocrine status. Clinical diagnostic tests will undoubtedly increase the efficacy and diagnosis and treatment of reproductive disorders. And so this is what is the summary of what I said, that ultimately the machines are important for us, and together we have to go ahead and make a better environment for the patients and for our fraternity and community. Thank you, Dr. Sampath, for inviting me for this. At some point in time, Zoom will also have an artificial intelligence. So once we tag the speaker, the machine will automatically shut out the other people. So, but that will happen. So ultimately, as we go along, we become more and more refined in how the implementation of the machine. Thank you.
Thank you so much, sir. In your busy schedule, finally, we made it. Thank you. Thank you. Thank you, sir. Fantastic. Starting with
COVID. It was fantastic. It was actually naturally intelligent person speaking on artificial intelligence.
Okay. Thank you, Palani. Palani is also our, our bard also, means he's a singer also. So, it's important.
We started with COVID and ended with artificial intelligence, sir. Fantastic.
Thank you. Thank you.
Thank you, sir.
All the best.
Yes, sir.
Wonderful talk, Dr. Rishikesh Bhai.
Thank you.
Thank you, madam.
Very
Thank you.
interesting.
Thank you. It's all the South Indians are they are human intelligence. So you don't like South India.
We will do, sir. Next year we will do fantastic one.
Yeah. Okay. Great.
Okay.
And only
Thank you.
for all of you who are there, Dr. Sampath is leading the team, but we all are together. So this year
Yes,
of
sir.
Foxy, we will all do it together as one family. And remember that, what happens that me or Dr. Sampath or all our people, we may forget, a particular person. So you must not, I always tell people that don't be shy. You have to tell, I want to do something. Okay, Dr. Pai, you forgot me to call me in the conference. So you have to be proactive. You cannot sit in a silence and brood over anything. This is an open society. We all are equal people. Okay, just that by the way, by fluke, I become the president. So, and Dr. Sampath Kumar is our vice president. Of course, we have put in a lot of effort for that. Having said that, you are all equally important. The society is made by the people who are there in the society. And remember that the Foxy is made by the local society. Foxy doesn't govern the society. The societies govern the Foxy. So Federation of Gynec Societies of India is what? Societies have come together to form a federation. So that we must never forget that in this whole hierarchy of things, society are the dominant part, not the fixed. Federation is just an expression of cooperation of the society. So that once we understand that, everything will fall into place.
Done, sir. Done. Thank you.
In TNFOG, all are equal.
Right.
All Southern. So
Right.
I thank all the delegates who are all logged in. Sir, we have 2057 delegates, sir.
Fantastic.
Congrats.
I request all of you to log in tomorrow by 9:30. Now we can go and have a tea in your house.
Thank you. And let me say that all Dr. Kalpana also.
Okay.
Thank you, Dr. Kalpana, Dr. Revti, Dr. Prem Lata, Dr. Pramila, Dr. Palani, Dr. Chandra, and so many others are there. So thank you. And of course, I expect a lot from Dr. Sampath Kumari. Very efficient person, very good person. And we are looking forward to more people coming from South India. All of you have to one day become vice president. Remember that. So we are waiting for you. Thank you.
Yes, sir. Thank you, sir. I will bring all of them. Thank you, sir. Thank you.
Thank you.
Thank you,
Bye.
Revati madam.
Bye.
We will leave
Bye.
on
Bye.
that.
Bye.
Bye.
Thank you.
Akita and Priya, thank you. We will see you tomorrow.
Thank you, ma'am.
Thank you, Priya. சரி நாளைக்கு 9:30 மணிக்கு எல்லாரும் லாகின் பண்ணுங்க. பிரேமலதா மேடம், thank you. All of you, thank you. See you tomorrow. Chandra madam, thank you.
Muted.
Narasimha Reddy sir, thank you.
Premlata ma'am, mute பண்ணி